Check, check, check. Hello, check, check. Hello, check. Hello, check, check, check. Check, hello. Hello, check, check, check. Hello, check, check. Hello, check, check. Hello, hello, check, check, check. Hello, hello, check. Hello, check, check. Hello, check, check. Check. Hello, hello, check, check. Check. Hello.
Specialities and backgrounds. They have generously accepted our invitation to share their wealth of knowledge and experience.
Before we begin our program, it is customary for us to start with a moment of reflection and unity. Let's invoke the blessing of God Almighty. Now I kindly request all of you to stand up for the prayer.
ശുദ്ധിയും സ്വഭാവശുദ്ധിയും ഭവഭക്തിയും വിവേകവും തരീണമേ ദയാനിധി ബുദ്ധിയും വിശുദ്ധിയും സ്വഭാവശുദ്ധിയും ഭവഭക്തിയും വിവേകവും തരീണമേ ദയാനിധി നന്മരൂപിയായ ദൈവമേ നിനക്കു വന്ദനം നന്മരൂപിയായ ദൈവമേ നിനക്കു വന്ദനം.
Please be seated. Thank you. And let us now commence the 16th Annual Conference on Current Trends in Limb Trauma Management. For the first session, I invite Dr. Raghu, Dr. Sanraj and Dr. Joseph Stephen to chair the session. I also invite Dr. Siju Wills, Consultant Emergency Physician, Daya Hospital, Thrissur, for the first session. The topic of the session will be stabilization of a trauma victim and initial management of major limb trauma in emergency room.
Good morning, everyone. Topic of my today's presentation is stabilization of a trauma victim and initial management of a major limb trauma in ER. For the systematic resuscitation of a trauma victim, we have a approach that is the ATLS survey and the Advanced Trauma Life Support Survey. We have got two components, that is the primary survey and the secondary survey. In the primary survey, it has 5 components, that's the ABCDE approach. There is airway with C-spine protection, breathing and ventilation, circulation with hemorrhage control, disability, that is assessment of the neurological status, and exposure and environmental control, that is for prevention of hypothermia. In ED, we got a 10-second survey for the quick assessment of a patient, whether the patient is stable or not. Just ask the patient his or her name and ask the patient what happened. If the patient is able to answer the questions, that means the patient got a patent airway, that means the airway is not compromised. The patient got sufficient air reserve to permit the speech, that means the breathing is not compromised. That patient has got sufficient perfusion, circulation is not compromised, and patient got a clear sensorium, that means the patient has got a clear neurological status. Coming to the first component of the ABCD approach, that is airway maintenance with C-spine immobilization, always check for signs of airway obstruction, check the airway for any presence of blood, vomitus or secretion. If present, immediately give suction and supplementary oxygenation. Check for any facial or mandibular fractures, check for any tracheal or laryngeal fractures. Those candidates are in high risk of airway compromise. Always reassess these victims. If needed, intervene immediately. In case of severe head injury, that means the GC score is less than 8, we have to consider definitive airway management, that is endotracheal intubation and ventilation. The major airway interventions are either you give supplemental oxygen, for example, if a patient is desaturating in ER, a trauma victim, we can give the supplemental oxygen either through a Hudson mask or through an NRBM mask. The Hudson mask delivers oxygen of 10 liter oxygen per minute with an oxygen concentration of 40%, whereas the NRBM mask can deliver up to 15 liter of oxygen per minute with an oxygen concentration of 100%. It's up to the decision of the clinician. If the airway is compromised with blood, vomitus or other secretions, immediately give suction. It can be given either with an Younger suction or with a suction catheter. Younger suction is used for giving the suction in the oral cavity. The suction catheter is used for suctioning the nasopharyngeal and oropharyngeal cavity. If the patient has got a low GC score and the airway is compromised because of the tongue fall, you can always give a jaw thrust maneuver. In trauma setting, better always avoid head tilt chin lift maneuver. In a patient suspecting a C-spine injury, it's better to avoid the head tilt and chin lift maneuver because it can aggravate the C-spine injury. If the airway is still compromised, the patient is still got a tongue fall, then you have to consider introducing the airways like oropharyngeal airway or a nasopharyngeal airway. In spite of the measures, the airway is still compromised. We can go ahead with the definitive airway, that is endotracheal intubation. In ER, when we intubate the patient, we always give the manual inline stabilization of the C-spine to prevent the C-spine injury. The C-spine immobilization always go in hand with the airway stabilization. In all multi-system involvement trauma, all polytrauma patients, we should assume the patient got a C-spine injury. For the stabilization of C-spine, we got nexus criteria and Canadian C-spine rule. Nexus criteria is more recommended. It includes any focal neurological deficit and midline spinal tenderness, altered level of consciousness, intoxication, or distracting injury. If any one of these present, immediately apply the Philadelphia cola. Coming to second component of the primary survey, that is the breathing and ventilation. The clinical examination plays a very important role in assessment of the breathing and ventilation, inspection, palpation, percussion, and auscultation. In inspection, we should always begin with the neck region. Always check for the tracheal deviation and distended neck veins. If present, there are features of tension pneumothorax, then always check for other features of the tension pneumothorax, which include hyper-resonant node during percussion, decreased air entry on auscultation, and if the patient is having hypotension, you can confirm the diagnosis of the tension pneumothorax with an E-fast, which can show an absent lung sliding. The intervention is immediate. We can go ahead with the needle decompression, which is done in the fifth intercostal space anterior to the mid-axillary line, followed by a tube thoracostomy, which is done in the same landmark. In inspection, we should always check for any sucking wounds on the chest region, chest wall. You should always assume those sucking chest wounds to be an open pneumothorax. Immediately a 3-way occlusive dressing should be applied, which prevents the further worsening of pneumothorax. In inspection, we should always check for the flail segment. If a flail segment is present, advise adequate ventilation and oxygenation, adequate pain management, and IV fluid therapy. In palpation, in the second part of clinical examination, we should always check for the subcutaneous emphysema. If present, it's suggestive of a tracheal injury or a chest wall injury or a blunt trauma chest. In bony crepitus, we should always suspect fractures of ribs. On percussion, if you are getting a dull tone, it's highly suggestive of a hemothorax. If we are getting a hyperresonance, it highly suggestive of a pneumothorax. In primary survey, next component is circulation with hemorrhage control. In circulation part, we should always identify the source of bleeding, control the bleeding, and resuscitate the patient. The source of bleeding can be external or internal. The external hemorrhage can be stopped by giving a direct manual pressure. The bleeding is not getting subsided, we can immobilize the limb with, by applying splints. In case the bleeding is not getting controlled, if the life of the patient is in danger, then you should consider applying the tourniquet. If you're suspecting an internal bleeding, always think of a cardiac tamponade. Always rule out a cardiac tamponade. You should look for the Beck's triad, which includes distended neck veins, muffled heart sounds, and hypotension. You can confirm the diagnosis with the help of a E-fast. After confirming, we can do the pericardiosynthesis. First, internal hemorrhage can happen in chest region or in the pelvis and long bones. If you are suspecting a pelvis fracture, always apply the pelvic binder. Once you identify the source, control the bleeding, then you should go ahead with the replacement of the intravascular volume. We can always start with the IV fluid therapy with crystalloids. Before initiating the crystalloids, it's better to check the IVC status and cardiac contractility. We can give bolus doses of isotonic solution, and IVC status and cardiac contractility should be checked very frequently. It should be reassessed frequently. After giving 1 liter of isotonic solution, then we have to consider giving blood transfusion. If BP is not picking up, if the patient is having still hypotension, then we have to think of the massive transfusion protocol. If we are suspecting a major limb trauma or suspecting a major internal hemorrhage, we should always think of massive transfusion protocol to avoid the coagulopathy. If the trauma victim is brought within 3 hours of the injury, we can give tranexamic acid, IV bolus followed by an infusion. In primary survey, the next component is the disability, that is neurostatus. In ED, our goal is to prevent the secondary brain injury. First of all, we should avoid hypoxia by giving aggressive airway management. We should avoid hypotension. The systolic BP should be maintained more than 90 mm Hg. Anti-epileptic measures should be administered immediately after diagnosing traumatic brain injury. Coming to the next part, that is the exposure or environmental control in ABCD approach. Initially, when the patient is brought to the ER, we should completely disrobe the patient. We do a thorough examination of the whole body of the patient and do the log roll to rule out any spine injuries. After that, you should give warm blankets for the patient. Patient should be kept in the warm trauma bay. Warm IV fluids should be administered for the patient to prevent the hypothermia. In secondary survey, coming to secondary survey, we take a complete history of the patient and do a head-to-toe examination. The history includes regarding the allergies, the previous medications, past illnesses, about the last meal, and the mechanism of injury. In head-to-toe examination, you do a complete examination of scalp examination, a proper examination of the eyes. You check the visual acuity, pupillary size, conjunctival hemorrhage, or ocular entrapment. In secondary survey, we should be very careful regarding examination of the neck region. There is in cases patient presenting with seatbelt injury over the neck region, should always suspect a carotid artery injury. Always palpate and auscultate the carotid for searching a carotid bruit. Post-trauma, if a patient is presenting with hemiparesis or hemiplegia, always suspect of a carotid artery injury. Limb-threatening. The major life-threatening injuries we come across are major arterial hemorrhage, traumatic amputation of a limb, or a crush syndrome. The limb-threatening injuries are open fractures or a compartment syndrome. Major arterial hemorrhage can be managed in a stepwise approach. Initially, give manual pressure to the wound, followed by a pressure dressing with a circumferential elastic bandage. If fractures are present along with the injury, realign it, immobilize the limb by applying proper splints. If joint dislocations are there, should be reduced immediately. Vascular clamps are not advised in ED because it can cause further damage to the nerves and veins. Suppose the bleeding is not getting controlled, if the life of the patient is in danger, we have to consider applying the tourniquet, the windlass tourniquet or the pneumatic tourniquet. In case of traumatic amputation, if you are planning for a replantation surgery, it's considered more for an isolated extremity injury, more for an upper extremity injury, preferably. We give a thorough wash for the amputated part, wrap the part in a sterile towel, keep it in a plastic bag, and transport with the patient the plastic bag in an ice container. Next is crush syndrome. We do the myoglobin assay for confirming the diagnosis. An amber color urine and a serum creatine kinase more than 10,000 units per liter are highly suggestive features of a crush syndrome. Crush syndrome can lead to rhabdomyolysis, which can cause metabolic acidosis, hyperkalemia, hypocalcemia, and DIC. Treatment is aggressive IV fluid management, IV carbonate, intravascular fluid expansion. Next is coming to limb-threatening injuries. Always you should look for the open fractures and open joint injuries. We should administer IV antibiotic immediately. We should remove the gross contamination by giving the primary wound wash. Appropriate immobilization should be given. Next is compartment syndrome. The main signs and symptoms are pain out of proportion, pain on passive stretch, tense swelling, paresthesia or altered sensation of the limb, absence of pulse, and weakness or paralysis could be late findings. If a compartment syndrome is diagnosed, we should release all the constrictive dressings, cast and splints, and fasciotomy is the only treatment. The take-home points are, in a year, we should always do a systematic approach for the resuscitation of a trauma victim. Always repeat the primary survey if the patient deteriorates in the year. A thorough clinical examination of neck region is very essential because we can detect a lot of life-threatening injuries. Thank you.
It was an elaborate and presentation by Dr. Shaiju. I would congratulate him for the good presentation and invite the next speaker as we have time shortage. Yeah.
The next session will be by Dr. Sijosi Babu, Consultant Anesthetist, Elite Mission Hospital, Thrissur. The topic of the session, Acute Pain Management in Limb Trauma.
A very good morning to you all. I am Dr. Sijosi Babu, Consultant Anesthesiologist and Pain Physician at Elite Mission Hospital, Thrissur. So, topic for today's discussion is acute pain management in limb trauma. So, as you all know, we are a leading trauma hospital in Thrissur city. So, we are getting lots of patients on basis of trauma. So, on a daily basis, we are actually treating a lot of trauma patients. So, what I am trying to tell you is what exactly are we doing in our hospital. So, this will be our today's topics. So, analgesic protocol at triage. What exactly are we doing at the emergency department? And then the role of multimodal analgesia, assessment of pain. Then the major part of the presentation will be nerve blocks. Then transdermal delivery, drug delivery systems, which are recent advances. And epidural analgesia, non-pharmacological adjuncts, importance of pain management, and selected analgesics and considerations will be gone. Now, first of all, when the patient comes to our emergency department, like any other department, like any other areas, we triage the patient into red zone, yellow zone, and green zone. And in the case of a trauma patient, we categorize this patient based on the shock, based on the presence or absence of the shock. So if the patient is in a profound or refractory shock, so that will be considered as a severe hemorrhage, and we will keep the patient in the red zone. And the primary target of intervention at that time will be stabilizing the patient, maintaining the airway, and correcting the hypovolemia. And at that time, we won't be looking particularly into the pain management of that kind of patients. And once the patient is stabilized, or if the patient is having an occult shock or a moderate amount of shock, then we will simultaneously correct the hemorrhage, correct the hypovolemia, and then we will also manage the pain of the patient. And if the patient is having a good level of consciousness and hemodynamically stable, then we will go with the protocol based on the green protocol. So, what about the profound refractory shock patient? So, if the patient is having a loss of central pulses, or if the systolic blood pressure is less than 70, and all efforts will be focused on the identification and treatment of the shock. So, we will correct the hemorrhage, correct the volume status of the patient, and then we will assess the patient further. So there will be a decreased level of consciousness or obtundation is the rule, and consider withholding analgesia until hemodynamics are improved. And at this time, And if at all the patient is perceiving, sometimes the patient is having a full level of consciousness, but the patient is deteriorating rapidly, and you want to intubate the patient. Along with that, you want to take care of the pain of the patient, then the drug of choice will be ketamine. That will be one of the best drugs available at that time. The next is occult shock. So poorly perfused extremities, loss of peripheral pulsations, and isolated or persistent systolic BP less than 105, a shock index of more than 0.9, and a base deficit less than or equal to -6. Then at that time, you can actually give some drugs like fentanyl 0.5 mics per kg IV or ketamine 0.1 milligram per kg IV over 10 to 20 minutes. So at this time, we know that most of the analgesic drugs tend to decrease the systemic vascular resistance and accelerate the deterioration of the patient. So it is better to give a drug which preserve the systemic vascular resistance of the patient and at the same time giving a profound analgesia. So again, the ketamine is the best drug at that time. And in a hemodynamically stable patient, here comes the role of multimodal analgesia. As we know that the pain is considered as a sensory and emotional component. It has both sensory and emotional component. So the emotional part of the pain is the one that we underestimate most of the time. The patient is highly anxious, is agitated, is distressed, and he will be having a lot of sympathetic overactivity at the time of this injury and because of the pain itself. And this sympathetic activity increases his heart rate, his blood pressure, and everything. And all the the pressure, the load of all these things comes upon his already compromised end organs like heart, brain, kidney, and liver. So we need to take care of all these aspects while treating a trauma patient. So as we all know that the pain pathway, it is a complex, the pain perception and its response is a very complex pathway. So we need to block this pathway at different levels. There comes the importance of the multimodal analgesia. So we have a paracetamol, which is a centrally acting, is an antipyretic and analgesic agent. Then we have an anti-inflammatory. We have an armamentarium of drugs in NSAIDs like diclofenac, lornoxicam, ibuprofen, and ketorolac. And then we have opioids like tramadol, pentazocine, fentanyl, morphine, like weak opioids, moderate potency opioids, and highly potent opioids. And then we have the new drugs in our armamentarium, that is alpha-2 antagonist dexmedetomidine, NMDA antagonist ketamine is already there. Then there comes the epidural and nerve blocks. So here I would like to tell you some newer advances in the management of the pain. There are a lot of studies we have published based on the combination, the efficacy of the combination of the drugs. So there is a combination of the drugs like paracetamol with tramadol. So what happens when you mix a tramadol with the paracetamol? The analgesic efficacy of the paracetamol and tramadol will augment each other, and the side effect of the tramadol, that is your hypotension and the nausea, vomiting tendency, will be taken care of by the paracetamol. And then here comes the next combination, that is dexmedetomidine and ketamine. We know that dexmedetomidine is an alpha-2 antagonist, is a central sympatholytic. It decreases the sympathetic outflow from the brain, and it is a very good analgesic drug. It is a very good, it causes the conscious sedation of the patient. And then when you combine this dexmedetomidine with ketamine, the analgesic effect of both the drug will be augmented, and the side effects of each drug will be taken care by the other drug. Like dexmedetomidine has a potency to decreases the heart rate and decreases the blood pressure. Then the ketamine will increases the heart rate and increases the blood pressure. The side effects of the ketamine, like the delirium, the nausea, vomiting, and the silicosis effect, and all this will be taken care by the dexmedetomidine. So a combination of dexmedetomidine and ketamine given as a slow infusion will be a very excellent choice of analgesia in a hemodynamically stable patient with severe pain. Now, nowadays the management of the trauma not only starts from the hospital setting. It starts from the periphery itself, like in the site of the trauma itself. We are actually moving towards the Western standards of managing the trauma patients from the site of the trauma itself. So the trauma care continuum starts from the pre-hospital area. So there we will start with the non-pharmacological therapy like positioning, splinting, heat or cold, or calming the patient. And when the patient comes to the emergency department, we will assess the patient, we will stabilize the patient, and then if the patient's consciousness is good and well, then we will start with the intravenous analgesic agents like acetaminophen, NSAIDs, unless it is contraindicated. And then in the ICU care phase or in the operation theater phase, we will proceed with the symptom-driven adjuvants and the increased potency drugs. And then we will increase the systemic opioids. And once the patient is adequately treated and recovered in the trauma ward, we will step down all these drugs, and then at the time of discharge, again, we will come back to the baseline drugs like our paracetamol and simple analgesics. Now the assessment of the pain, and we all know that there is a visual analog scale that is a standard all over the world, and then based upon the visual analog scale, we can actually use the pain ladder proposed by the WHO to select our drugs. Now here comes the nerve blocks. So these nerve blocks, it is a very underestimated or underutilized modality of pain treatment because the people tends to think that this nerve blocks belong to the anesthetist or inside the theater only. No, it's not like that. You can actually give a nerve block very safely and very efficaciously inside in an operation, in an emergency room itself. So that will produce a profound analgesia and immediate relief of the pain and sufferings to the patient with a very low risk rate. This is actually a patient we got very recently. It is a blast injury. So I would like to ask what kind of regional nerve block will give immediate pain relief in this patient. So the answer is a wrist block. So a wrist block is a very simple nerve block with a very evidently landmark present, and we can give 5 to 6 ml of plain lignocaine just based on the landmarks available there. Just outside the radial artery, you can block the radial nerve. Just medial to the ulnar artery, you can block the ulnar nerve. And in between the FCR and FPL tendons, you can actually block the medial nerve, which will provide the analgesia of the patient. Now the next is, if the wound is actually extending into the arm, into the forearm of the patient, the analgesic, the block of the choice will be an axillary block. Again, this axillary block is actually performed by our own surgeons inside the emergency room itself. After checking the nerve motor status of the patient, and if the patient is having a suspected nerve injury, we can actually record the nerve injury, then proceed with the nerve block. There is actually not an absolute contraindication for that. Now here comes an extensive limb injury, and here also you can actually go for a supraclavicular nerve block based on the landmark technique. The landmark will be very easily identifiable, just 2 finger breadth outside the lateral border of the sternocleidomastoid and 1 finger breadth above the clavicle. You just go directly downwards, hit the first rib and give the drugs, and the patient will be having a very good analgesia of the upper limb. Now here comes the lower limb part. This lower limb, if the injury is in the femur region, in the thigh region, and on the medial aspect of the leg region, you can go for a facial iliac nerve block. Here again, the landmarks are very visible. Anterior superior iliac spine in the lateral part and the pubic tubercle in the medial part. You divide the line into 3 equal parts, and 1 centimeter below the junction of the lateral 1/3 and the medial 2/3, you can go directly downwards, tilt the needle a little bit of 30 degree, then give the drug. You will get a very good analgesia. And now go for the below knee trauma. So a popliteal nerve block will take care this type of trauma. Now, here comes the most of the time we will get an ankle trauma, the below ankle trauma. So it's a very easy job for the surgeon or the emergency medicine physician to give a block around the ankle joint. We will be blocking 5 superficial nerves, the saphenous nerve, the posterior tibial nerve, the sural nerve, the deep peroneal nerve. And all of these nerves have a particular landmark just beside them. The saphenous nerve, you will be having a great saphenous vein on the medial aspect just in front of the medial malleolus. Then the posterior tibial nerve will be having a posterior tibial artery just nearby to that. And the sural nerve will be having a small saphenous vein, and the deep peroneal vein will have a dorsalis pedis artery just near to that. So you can actually block these nerves adequately. Now here comes the newer the drug delivery modality, that is transdermal analgesic patches. We have in our hospital, we have fentanyl, we have diclofenac and buprenorphine transdermal patches, and this buprenorphine transdermal patch will give analgesia for 7 days. The fentanyl will give 3 days of analgesic cover, and the diclofenac patch will give a 24-hour analgesic cover. Now, here comes the role of epidural analgesia in the case of a lower limb trauma. And if you are planning for repeated surgeries, repeated debridements, and planning for surgery on the next day or the other day, then you can actually directly go for an epidural insertion, and you keep the patient in a sensory level of block. When you have a local anesthetic, you have bupivacaine, which is 0.5%, that will be giving a sensory and motor block, but you decreases the concentration of the bupivacaine to 0.25 or 0.125%, that will give only sensory block. So that the patient will be able to move, you can assess the extremities, and you can prevent a lot of complications, and in spite of that, you will get a very good analgesia. And there is something called elastomeric infusion pump, which is coming to our hospitals nowadays. This is actually a self-deflating infusion pump. You can set actually the flow rate in that. You don't need any electricity or particular monitoring for that. So you fill the drug in this system and keep the rate at 0.1 ml per kg of the patient, and the patient will be getting enough analgesia. Now, this is also very important, the non-pharmacological adjuncts. So, early discontinuation of the spinal immobilization, reduce and splint immobilize injuries, Foley's catheter to decompress the bladder, and pre-procedure patient briefing for the anticipated painful procedure. All this give you a comfort to the patient. Now, the importance of the pain management in the limb trauma, there will be, you need to give comfort to the patient, prevention of the complications, and psychological impact, enhanced recovery, and patient satisfaction. So, the prevention of complications, if the patient is having a pain, the patient tends to immobilize everything. So, the immobilization causes a deep vein thrombosis, and the acute pain will be converted to the chronic pain, pressure ulcers, joint contractions, all these things will happen. Now, the PTSD is a very common thing after a major trauma, so you need to take care of that also. So the pain control will give an adequate chance of recovery from the PTSD. So the patient satisfaction, again, the trauma, when you, after all these sufferings and everything, you need to have a patient which is very much satisfied with your approach, with your treatment, with your pain control, with the recovery and the functional status. So it is very important. Now I have added these slides. Just if this PowerPoint will be available in our website. So if at all you wanted the doses, the considerations and everything, it is available here. So this is my references. We have taken this mostly from our hospital protocol, and then we actually made this protocol based on the best practice guidelines for acute pain management in trauma patients by the Royal College of Surgeons. Thank you so much.
Thank you very much, Sijo, for your wonderful lecture here. You have covered almost all the modern techniques here. I'm very much satisfied with your presentation. I have 2 questions only, a short only one. One about the first thing is that being a major hospital which receives the extensive polytrauma here, what is your suggestion about the pain from the primary side, the pain management. What he said is that this is the one which we do in Western countries, okay, I understood. But receiving the patient at the casualty level, at the ER level, did you find any patient getting this satisfied pain management arriving at the casualty?
Sir, most of the time what exactly happens is, in the pre-hospital setting, when the rescue, the ambulance people or the police or the public is shifting the patient, they are actually not keeping the primary standards of care. We are not stabilizing the patient. We are just taking the patient and throwing into the ambulance and bringing the patient as early as possible to the hospital. That is the dictum most of the times followed here. So by the time patient reaches the hospital, their hemodynamics will be already shattered, not only from the trauma itself, but also because of this rash transport and everything. So that is one part of this. The patient will be in a very much suffering state. Second of all, what they can do is follow a strict guidelines of the transport of the patient by immobilizing whatever parts it is suffered from the trauma. Second of all, it is not advisable to give any intravenous drugs in out of hospital settings. But in Western countries, the trained ER persons who are going to the field to take the patient, they are actually taken they have trained to start an IV line and to give a ketamine, a lot of ketamine. So there it is possible. I don't know whether it is possible here also. Second of all, when the patient comes to the emergency department, all the attention goes to the trauma part, not for the pain part.
Exactly.
So that is the main problem here. The emergency medicine people. So not in our hospital. We have a very dedicated trauma emergency medicine department. We follow a set of standards. But in peripheral hospitals, what they are doing is, when they see a lot of blood and the tissue disruption and everything, they just refer the patient, or just when they start the treatment and everything, they just keep intubate the patient and will avoid all the analgesic agents, and they don't, their mind is totally blank about the pain part of the patient. So even if the patient is intubated, even if the patient is on skeletal muscle relaxant, the patient still feels pain. So that is the primary part. And most of the time, our nursing staff believe that giving a trachurium or giving any other skeletal muscle relaxant will take care of the pain. I don't know from where that notion comes, but it is most of the nursing staff believe like that. Sir, I have given midazolam or I have given atracurium, so that is enough. So it is not like that. Even if the patient is under general anesthesia, if they are not given analgesia, the patient will feel the pain and the hemodynamic consequences will be there.
Thank you very much. As time doesn't permit,
Yes,
we can further proceed to the
Thank you, sir.
programs.
Thank you so much.
Thank you.
Thank you, sir. I would also like to thank Dr. Regu, Dr. Sandrash, Dr. Joseph Stephen for chairing this session. Thank you, sir.
Next, I invite Dr. Renji Isaac Thomas and Dr. Anto Francis to chair the session. The next speaker is Dr. Binoy Sayujanandan, Consultant Hand and Microsurgeon, St. James Hospital, Chalakudi. The topic of session, Management of Hand Fractures and Principles of Just Fixation and Suzuki Frame Application.
Good morning, everyone. Thank you for inviting me to give this talk. I'm grateful for the opportunity. I'll be talking on the hand fractures. When I was doing my FNB in Ganga, so one of my senior was drilling, and to get anatomical perfect fixations. Then SRS Raj Sabadi came that way, and he was just screwing him. So Sir was telling, so then this fellow was trying to justify, no, that is not correct, there is a step. So Sir was telling, no one becomes a great surgeon by doing extraordinary surgeries. One become a great surgeon by doing ordinary surgeries extraordinarily well. So you have to actually do it well with minimum attempts. That is actually a very true statement. When we start our practice, then only we realize that. So you can see this fracture. It's a very simple fracture. Nobody actually will think twice to put a plaster. But it is very important that you see not only the X-rays, but the patient as well. So you can see that you can see that when he starts moving, his finger is actually going in a different way. So if you had looked only at the X-rays, you would have just put him on a plaster. Or if somebody had sent you the WhatsApp X-ray, you would tell him that doesn't need a surgery, you just need to put a strapping. I mean, or even a finger cord, not even a strapping. So if you come to the next slide, you can see that this is a very innocent looking fracture. Again, we will never think twice to put treat it conservatively just with a finger cord, which was done for him. And you can see that it is actually an unstable fracture pattern which can actually displace over the time. So this is what he has ended up with after 3 weeks of immobilization. So the points to remember is that all fractures do not need surgery. Clinical examination is a must. Patient needs repetitive education regarding the seriousness of fracture because the patient tend to think it's a small fracture, it's only a finger. If it's a femur or tibia, you don't need to explain to him. He knows it's a fracture and it knows its importance. So hand fractures, it's not that you tell him once, you have to, every time he comes to your OP, you have to tell it is an important fracture, he has to do this, he has to do the therapy, he has to, work on it. Prolonged immobilization should be avoided. And decision on fracture fixation is multifactorial. It's not just X-rays. So we need to be extremely good with fixations. We never have to be aggressive with fixations. Can lead to, if we are very aggressive, it can lead to soft tissue damage, tendon adhesions, and many may warrant secondary procedures. And always remember, operative fixation must be used judiciously and with the expectation that the ultimate outcome will be as good as and optimally better than the outcome after a non-operative management. So these are the points when you think of a fixations like irreducible fractures, malrotations, articular fractures, subcapital fractures of phalanges, open fractures, polytrauma with hand fractures, multiple fractures and fractures with soft tissue injury. So these are the only indications for fixations. So let's go stage by stage or step by step. So we will divide it into 7. What X-ray to take to see a fracture, which fracture needs fixation, which fracture needs an open fixation and when to fix it, what to use for fixation, when to mobilize and when to remove the implant. So let's come to the X-ray part. So we have to take a lateral view, which is very important. Most of the time, the X-rays are only AP and oblique, where you can actually mix, serious injuries. You can see this guy. He had an AP and an oblique X-ray, and the moment you take a lateral view, this is the view. It's actually a shattered PAP condyle. Proximal middle phalanx base, which was actually looking like an innocent fracture on the oblique view. So which fracture needs fixation? That is a little difficult thing. So we need to understand, I'm actually covering only the phalanx part because the topic is so vast. So I thought I will concentrate on the phalangeal fractures and dislocations. So we need to understand you are not fixing a phalanx fracture for it to unite. When it comes to the both forearm, when it comes to the humerus, tibia, femur, they are fixing it for that it has to unite. In phalanx, it will unite. Ultimately, it will unite, even if you don't do anything for it. So we are fixing it so that you can mobilize them faster, you can get back to their functions faster. So if you If you, we need to understand, and there is an articular injury that has a major influence on the ultimate results also. And the fingers, for the fingers, they are not subject to heavy loads. So stability and alignment are more important than the articular congruency in determining the outcome. So as I said, we are actually fixing the fracture to mobilize. So what is the significance of a mobilization? If you look at the literature, if the patient is less than 20 years, at the end he gets almost 88% of functions. But if the patient is more than 60 years, it's only 60%. And if you immobilize the patient less than 4 weeks, then he gets 80% of the total active motions, where if you immobilize more than 4 weeks, then the results comes down. Next comes the stability. So the fractures with potential to rotate, angulate or shorten are unstable, and these are the fractures which needs a fixation. So the rotation is a clinical finding. You can't see it from the x-rays. You have to tell the patient to flex the finger, and if he has pain, you have to give him a local, and you have to make him pain-free and make him flex. And angulation is something we need to check in the coronal plane and the sagittal plane. So if it's there in the coronal plane, it produces a digital overlap. And if it's in the sagittal plane, it causes a pseudocloying. So shortening is something which is evident on the X-ray. So this is the digital overlap, and this is the pseudocloying. So we have 3 basic fracture patterns. It is the transverse. They tend to angulate. Transverse fractures always tend to angulate. If it's an oblique and spiral, these are the fractures you need to, 100% you have to see the patient. It's an oblique and spiral fractures, they can rotate and can angulate. And a comminuted fracture also. It can angulate, it can rotate, and it can shorten. So transverse fracture, to some extent you can make a decision on the X-ray, but not on an oblique and spiral fracture. So this is the same thing which I was talking about. So we have this, if you are deciding a patient to treat conservatively, so we need to divide it like stable fractures which are undisplaced and stable fractures which will become, displaced fracture which can become stable after reduction. So if it's a stable undisplaced fracture, we can cast or splint in the James position. So, and we have to, mobilization has to be initiated within 3 weeks depending on the pain. And we have to do weekly X-rays so that we make sure that it doesn't get displaced. So if it's a displaced fracture, we reduce it by flexing the MP joint to stabilize the proximal fragment and then flex the distal fragment to correct the volar angulation. And we have to assess, once you reduce it, you have to assess the rotation by comparing the planes of the nails. So extension block splinting with a buddy taping is done to control the rotation also. Again, we do the weekly X-rays to assess the displacement. Next comes the casting. We reduce it and we put a cast. So, but traditionally, digital stiffness was an almost inevitable sequelae of phalangeal fractures. It was changed following the studies of James and later modified by Burkhalter and Reyes. So the good function result in 60% of 485 metacarpal and phalangeal fractures which were treated with CMR casted, what was observed in this study. They also stress the importance of early motion. So this is the James position. So if we look at the cast, from the side it has to be straight. That is the funda. It should not be like this. Because if you do a cast and if you take a lateral view, then only we realize that our casting was actually not proper. So these are a fracture which needs 100% fixation. These are subcapital fractures or subcondylar fractures. It is common in children. So there is no tendon attachment to the head, and head fragment displaces dorsally, rotates 90 degree, articular surface face dorsal. So this is the fracture. So these are fractures which you just cannot treat by a splint. These are fractures which you need to reduce. And the reduction is actually very difficult after 1 week. So we need to reduce it and we need to just put an axial cavity. And this is another indication. If the patient has a head injury, even if the fracture is undisplaced, you have to just fix it, because You see the fracture undisplaced. When the patient recovers, you will see that it's all in different planes, and by the time it is too late, and the patient will recover from the neurotrauma, and he will end up with a hand stiffness. So which fracture needs open fixation? So most of the time phalangeal fractures we treat with a close fixation. So there are some indications like where you do an open. So if it's an unstable proximal phalanx and middle phalanx fractures that cannot be reduced, especially in the zone 2. The pulley system can get entrapped get interposed in the fracture site, or it can be even the flexor tendon itself. So when the percutant spinning is not possible. So when you are opening it, it's always better to do a rigid fixation. Rigid constructs, they have significantly better outcomes than non-rigid. Non-rigid means it's a K-wear basically, because immediate mobilization is possible. So these are open fractures. So even in a close fracture, this fracture pattern, it's very difficult to align with a K-wear. So this is something which you need to do a plating and fix the fracture. So when you are opening it, you can open two ways. You can open it dorsally and you can open it laterally. Dorsal is something which should not be done because it produces an extensive scarring. Your X-ray will look fantastic, but the patient will have full stiffness because the tendon will get adhered to the fracture site and the PAP will become stiff. They will have an extensor lag also with a flexion contraction. So always go laterally. Mid-lateral incision and excise one of the lateral bands to expose the fracture. So there is less scarring of dorsal apparatus and PAP extensor lag is minimal. So next is when to fix it. So if decided, fix it as soon as the patient is fit for anesthesia. It can be done on digital block, wrist block or breakaway block. The only thing is patient has to be pain-free. So what to use for fixation? We have so many implants available. You have K-wires, we have the flexible intramedullary nails. We see screws in the X-rays, plates and external fixation. I use K-wires, plates and external fixations. So, so this is from the Bible of Orthopedics, Campbell. Rarely is more fixation needed than that afforded by K-wires and external splinting. So that is what the ortho textbook is telling. So advantage of a K-wire is that it's actually useful in the shaft fractures. So we can put the K-wires in different configuration. You can put one K-wire, you can put two K-wires, you can put three K-wires. You can put it in crisscross fashion, so many different patterns. So this is actually a very useful configuration. It's described by Belsky. It is for extra-articular transverse shaft fractures at various levels of proximal phalanx. It gives an excellent results. Immediate mobilization can be started. You can start the mobilization from day 2 or day 3, depending on so this is a fracture. So this is how you fix it. The good thing about Belsky is that you don't need to cross the other cortex. So it is always a struggle when you try to cross the other cortex because your driver has to be nice. It has to be a light driver. Your orientation has to be good. Then actually you can pass two cortexes very well. This you don't need much actually accuracy. Your entry point has to be from the condyle and you have to carefully drive it inside the thing. The only thing is your two wires you have to use, not one wire, and it has to just fit in quite close within the medullary canal so that it doesn't rotate also. So this is how it unites quite well also. The only thing is it can distract the fracture site. So you should not push it very distally. You should just keep it little below the PAP joint if you are fixing the proximal phalanx. So this is another useful thing. This is actually really better than the other fixation, but this we may need a little time to master it because as I said, for the proximal phalanx fractures, it is not the X-ray, the itself, it is the attempts which matters. The more we attempt, what we need to understand is each time it actually crosses the cortex, it is hitting onto the flexor tendon or it is hitting onto the extensor tendon. So it can actually, these can cause the tendon scarring and later stiffness. So mid-lateral pins we use when if it's a long oblique fractures, we use at least 2 pins. You can, like in the fracture which I showed, we can actually fix it like this. Another question is whether you should cut the pin under the skin or you should bend it over the skin. So there is no difference in infection rate between the buried and protruding pins. That is what the study shows. But in my practice, I felt that patients, if you keep it outside, they actually each time they move, after some time, the pin gets irritated, then they have pain, then people may not move. So if you cut it a little down under the skin, it's not about the infection, the pain part is less and the movements are better. So when to mobilize? So this is the same thing which I talked, like, the earlier the mobilization, the better the results. So there is a direct correlation between the severity of soft tissue injury and final range of movements. And the fractures in zone 2 flexor tendon, proximal phalanx fractures towards the base, they are very difficult in the sense you have to mobilize faster, otherwise it will get stuck, especially the little finger. So when to remove the implant? So many authors have cited lack of correlation between the radiological and clinical signs of union. So averageical time for a complete bony healing is 5 months. So you have to tell the patient, especially if he is a Google guy, you have to tell him, in the X-ray, for the line to disappear from the X-ray, it will take 6 months or 5 months. Otherwise, each time, they will correlate this thing with the pain with that you remove the wires before it is united and all. Because 3 months, 4 months and all, still the X-ray will show the fracture line. So the clinical healing time when the patient could return to work is 5 weeks. That is 1/4 of the time. Screw fixation, again it is for oblique fractures we can use. We need at least 2 screws and always go for a nice screw. Always go for a Synthes kind of screws where it is self-tapping. So they found close reduction, percutaneous cavering versus open reduction and lag screw fixation in oblique and spiral fractures, and there was no statistical difference in outcome. So next comes the plate fixation. It provides stable fixation, permits early range of movements. So external fixation is done when you have an open fractures with a concomitant soft tissue injury, or if it's a highly comminuted articular or diaphyseal fractures and fractures with significant bone loss. So this is not a commonly done procedure. So we can, fixator is left in place for 4 to 6 weeks and movements of uninvolved joints can be started. So in these kind of fractures, there is nothing much more you can offer with a caviar or, it's very difficult to do it with a plate. You can see that the joint is actually fully destroyed. It's not congruent. So this is how you do it. Basically the external fixator will give you distraction and it will help you put the fragments in place. So the expected outcome with a close reduction and cast is 90 to 94% satisfactory results. Close reduction and pinning 90% good and excellent results. Plate and screw frequently associated with complications. So basically it is all the choosing the patients for what. You can choose if you choose the right patient for a plaster or a splinting, you can get the same results you will get with a pinning or with a plating. So next comes the PAP fracture dislocations. So we know that the PAP joint is almost like a box. On the volar side, it is protected by the volar plate and on the side by the collateral ligaments. So when there is a disruption in this box structure, then the PAP joint dislocates. So we need to look at 2 things. You need to look at the fragment. You need to look at the dorsal subluxation. So if the fragment size is less than, it's a tiny fragment, if it's less than 40%, that means the collateral, some of the collaterals are still intact and you can treat them with a conservatively. If it's more than 40%, it's an unstable configuration which needs a fixation. In this X-ray, we can see that the fragment size is smaller in these X-rays. Some in the second X-ray it is bigger, but in the third X-ray, like in this one, in this one and this one, the fragment size is same, but you can see that dorsal subluxation is actually quite different. And these are very comminuted base fractures, so which we cannot do anything. We can better with a skeletal traction. So these are the 3 pins which you use for a Suzuki frame. Okay, this is an extremely useful construct. So the first wire goes through the proximal phalanx head, the second wire through the dorsal fragment, and the third wire through the middle phalanx neck. So the idea is that the fragment is going dorsal. So your first pin, so each pin has its own role. The second pin is actually through the dorsal fragment. Your first pin has to go over the second pin, dorsal to the second pin. Then only this will bring the dorsally subluxating fragment down. So, and the third pin is for giving the traction. So, this is the construct. So, you can see that this is the second pin, which is actually, in this you can see that the first pin is actually going dorsal to the second pin. That is how it should be. Then only it can reduce the dorsal subluxation of PIP joint. I hope you understood the concept. And the third pin is actually for giving the traction. So we actually get reasonable movements. So this was that compound fracture. It gives some fantastic results. Unless the patient is very pain sensitive, it gives beautiful results, Suzuki fixations. So a review of several recent reports showed an average range of motion of approximately 85 degrees at follow-up after 1 to 2 years. Superficial pin tract infections are present in 10 to 30% of cases, but they typically resolve without incident. And patient demonstrate 92% grip strength on an average. Thank you. Thank you so much for your.
Thank you, Dr. Binoy. Very excellent presentation. I actually liked all the cases that you've presented. Thank you very much for that. And it was brief also, it was a vast topic. Now, I don't think we have much time, but I think we can take at least one question from the audience because it's very interesting. Any questions? Okay then, no questions. Thank you very much, Vinay.
Thank you. That means nobody understood anything. They understood everything. Thank you.
Thank you, sir. I would also like to thank Dr. Renji Isaac James, Dr. Anto Francis for chairing the session. Now we move on to the inaugural ceremony for today's conference. I invite Dr. K.C. Pragashan, Managing Partner, Allied Mission Hospital, Dr. Raman, Senior Plastic Surgeon, Dr. T.M. Balakrishnan, Dr. G. Karthikeyan, and all the consultants of Team SUSHRUTHA for the inaugural ceremony. I request Dr. K.C. Pragashan, Managing Partner, Elite Mission Hospital, to deliver an inaugural speech.
Good morning to you all. And this is the 16th year of our SUSHRUTHA plastic, reconstructive and aesthetic surgery departments beginning. And all these years we have been conducting this. And every year the number of participants are increasing. It shows the interest in the people. And we at Elite have a good team of plastic surgeons, started with Dr. Aniljit, Dr. Anto Francis, Dr. Pradeep Kumar, Dr. Joshit, Ajay, Vinu, and now Prince. And they, along with the anesthesia team, and of course with the other departments, and our rehabilitation and physiotherapy department, they have been doing fantastic work. And of course, this is with all the help of in and around of Trichur, and all the consultants and doctors from in and around Thrissur are supporting us, and they have been continuously doing that. And we, from the management side, we have provided them all they needed in doing this work. And we hope they continue to do their work with this teamwork and with all your good support. With these few words, I declare this conference open. Thank you.
Thank you, sir, for your valuable contribution.
Next, we will have a small tea break.
സാറിൻ്റെ നെക്സ്റ്റ് ടോക്കണോ അടുത്തൻ്റെ അഭിഷേക് എന്ന് പറഞ്ഞിട്ട് ഇതാണ് സാറേ. ഇതിൽ വീഡിയോ താഴെ കുറച്ച് വീഡിയോസ് ഉണ്ട്. അതെ അതെ, ഇത് ജസ്റ്റ് നമ്മൾ അമർത്തിയാൽ മതിയോ? ഒരു മിനിറ്റ് സാറ് നോക്കിയോടെ.
ഒരു ഓപ്ഷൻ ഇവിടെ ഞങ്ങൾ ഇട്ടേക്ക് കേട്ടോ. നിങ്ങൾ റെഡ് ലൈറ്റ് ഉണ്ടാവും. അപ്പോൾ സാർ ഇവിടെ ഇങ്ങനെ പോയിന്റ് ഈ മൗസ് മറ്റേ പോയിന്റിൽ വർക്ക് ചെയ്യില്ല. LED സ്ലൈഡ്സ് സാറിൽ ചേഞ്ച് ചെയ്താൽ
മറ്റൊന്നും വെച്ചോ
അത് ഞാൻ വെച്ചോ. ലാപ്ടോപ്പ് ചേഞ്ച് ചെയ്യാം. ലാപ്ടോപ്പ് ചേഞ്ച് ചെയ്യാം. ആ മൈക്ക് ചേട്ടാ ഒരു മിനിറ്റ് ആ ഒന്ന് നോക്കിയാ സ്വിച്ച് ചെയ്ത് നോക്കി.
I request all of you to please reassemble to the conference hall. I request all of you to please reassemble to the conference hall. I request all of you to please reassemble to the conference hall.
Next, I invite Dr. Jay Prakash and Dr. Pramod to chair the session. Next session will be by Dr. Abhishek KM, Senior Consultant Orthopedician, Allied Mission Hospital. The topic, Interesting Case Scenarios in Limb Trauma.
Respected faculties, senior consultants, the chair, colleagues and friends. I am Dr. Abhishek, consultant orthopedic surgeon, Allied Hospital. Today I'll be presenting on a few of the polytrauma cases that we have managed in our hospital. As you all know, polytrauma is the leading cause of death and disability in young adults. In civilian life, it is often associated with motor vehicle accidents. A proper polytrauma management team and a well-defined SOPs are the key in effective management of these patients. Timely and safe fracture fixation is a critical component of the multidisciplinary care that these patients require. Coming to a few of the cases, we had an 18-year-old male patient with a history of road traffic accident. It was a run-over injury of his thighs. He sustained bilateral femur fracture. On the left side, he had a type 3B comminuted fracture of the left distal femur with an extensive bone loss. He also had a subtrochanteric fracture on the same side as well. On the right side, he had a supra with intracondylar fracture of the distal femur. On presentation, his HB was around 5.8. He had head injury. He had a frontal bone fracture, diffuse axonal injury, and intraventricular hemorrhage. So this is his left side X-rays, which I was talking about. He had a segmental femur with an extensive bone loss. Initially, the patient was on ventilator support. Conservative management of the head injury was done. We did damage control orthopedics. We fixed both the limbs with bilateral external fixators. On the left side, we put him on a skeletal traction as well to take care of the high subtrochanteric fracture. Once the condition was stabilized, we staged the procedure into two. In the first stage, we fixed his the left side subtrochanteric fracture with a proximal femoral nail. And on the right side, we did a distal femoral locking plate system. So this was one of the major challenges which we had, how to address and go about with this extensive bone loss of his left distal femur. How to fix and what are the options that we have. So for this case, we went in with something called as a double barrel free vascularized fibrillar graft. The double barrel free vascularized fibrillar graft is a further modification of the free vascularized fibrillar graft, where we harvest the fibula and its pedicle. We osteotomize it. It produces a two vascularized bone set that may be folded parallel to each other with an intact periosteum and the muscle cups. This was the graft intra-op picture. This is what we did. We took the fibula, osteotomized it, fixed it into the defect, and the pedicle of the fibula was anastomized to one of the muscular branches of the femoral artery. These are some of the literature showing the efficacy of double barrel fibrillar graft for metaphyseal bone defects in distal femurs. This is again a comparison study. This was done in fibrillar shaft fractures, where they did a comparison studies between the vascularized fibula and the double barrel fibrillar grafts. So we did an extensive workup. We took a CT of femur to assess the bone loss. We also did a CT angio to assess the vascularity of both the lower limbs. And this is a brief procedure. A patient was in supine position. Both the thigh and legs were draped. LRS was applied over the left distal femur. Through a medial incision, the femoral artery was exposed. The lower femoral defect was approached between the vastus medialis and the rectus. Space was created. The fracture ends were freshened. The free fibula with the pedicle was harvested from the opposite leg. The fibula flap was telescoped into the proximal femur, and the double barrel part was telescoped into the supracondylar metaphyseal defect. The flap anastomosed to the branches of the superficial femoral artery and the vein, and the closure was done. These were the intra-op pictures. You can see we went in medially, exposed the fracture, and that is a defect we had. You can see that scale was around 15 centimeter. We had around close to 18 centimeter of bone loss. This is the double barrel graft which was harvested from the opposite leg. This is the intra-op CM picture. You can see the graft was filling the metaphyseal region, and it was further stabilized with the LRS fixator. This was his 8 weeks post-op, 12 weeks, 16 weeks, and this is the 7-month post-op and weight-bearing X-ray. So you can see how well the graft has united and the defect is closed. 10 months post-op. So I have a walking video. So this is the same patient who's walking. This is almost a year video. And he's got a very good range of knee movements. So this was a case of extensive bone loss which we managed with a double barrel vascularized fibrillar graft. Coming to the second case, he also was an 18-year-old male with a road traffic accident, sustained head injury with LOC. This patient also had a similar fracture of what we have seen in the previous case. He had a type 3 compound fracture right distal femur with bone loss, as well as a combinated segmental fracture of the left femur. So this was his initial presentation, how he came to the casualty. So on the right side you can see the X-ray which shows extensive bone loss missing bone of the right side. And on the left, you have a shaft fracture with a segmental femur. But the difference was, in this case, we were able to get the missing bone. They had the missing bone, and since it was not contaminated, we did a thorough wash, and we incorporated the missing bone into the defect and then fixed it with the external fixator. Once the patient was stabilized, left side, we did a femoral nail for him. This was the wound closure and X-fix applied post-op picture. Waited for 2 weeks. Once his condition recovered, we did a minimal plate osteosynthesis for the right side. We had to span the whole femur because of the extensive bone loss. No grafting was done for him. So this is his 6 weeks follow-up X-rays, check X-rays. 3 months follow-up. You can now, in this picture, you can see how well he is flexing the left side already. And this was his, one of the recent X-rays we had. The right side is fully united, and he is back to his work. Coming to the next case, a 45-year-old male, history of again road traffic accident. He had a fractured clavicle, a comminuted fracture of the neck and the body of the scapula, as well as fracture ulna on the same side. So you can see the X-rays, the clavicle with the glenoid fractures, with the scapular fractures, as well as ulna fracture. This was the CT picture of the shoulder, showing extensive comminuted fracture of his scapula. So he had something called as a floating shoulder. It's a combined injury. When you have a fractured clavicle and on the same side when you have a scapular fracture, especially a dorsally angulated fracture, it's called as a floating shoulder. These are some of the classifications of scapula what we follow. This is the AO-OTA classification of scapular fractures. These are some of the criteria for fixation of scapular fractures. When you have a scapular fracture along with the injury of the clavicle or a clavicle acromial complex, when you have a glenopolar angle of 22 degree or less, when you have a 2 centimeter lateral offset, in such cases you need to go fix the scapula. Again, we staged the procedure. First stage, we fixed the clavicle and the ulna in a supine position, and then we went to the second stage to fix the scapula. Scapular fixations are not done commonly. So these are the special plates which we had to get. It's called as boomerang plates. These plates fits well into the contour of the borders of the scapula. Through a modified Jude approach, patient was in a lateral decubitous lateral position. We have marked the incision, and once you retract the deltoid, you can release the infraspinatus and then expose the fracture. You can see how well the plate fits into the fractured fracture areas. Intraop pictures and the CM picture. Post-op X-rays. All on the same side, the patient. This is his 2 months post-op. Axial view. 2 months range of movement. This is his range of movement after a year. So he's got a full range of movement, and he's all back to normal work. Coming to the last case, we had a 10-year-old female child, history of road traffic accident. She had a compound comminuted fracture of both bones of right leg. No neurovascular deficit, but she had a circumferential wound with bone loss. You can see how bad the wound was. It was just holding on a tag of skin. It was all open circumferentially. The X-rays, type 3B compound combinated both bone fractures. So immediately we took the patient in, did a thorough wound debridement. We were able to get a good circumferential wound closure, and we had stabilized the fracture with the external fixator. So the fragment which was outside was contaminated, and we had to remove the fragment. So that is why there is a bone loss over the middle of the tibia. 6 weeks post-op, wound healed well without much complications. And then the question was how to address the bone loss for, she is a small girl. So once her condition and the skin condition improved, second phase we did the intramedullary ipsilat. We took an intramedullary, we took the fibular strut graft from the same side and fixed it intramedularly into the tibia and stabilized it with the external fixator. So you can see the fibula taken from the same side, and it was inserted into the tibia canal. And it was stabilized with the LRS construct. So this was her 5 weeks post-op, 12 weeks. And this was her 4 month post-op. The fracture is very well united, as well as the graft, the fibula which we took, it has also come back, and she is doing good. Thank you.
Thank you, Dr. Abhishek. You have done a wonderful presentation. And I must congratulate you and your team for reconstructing limb injuries with significant bone loss. I only have a sad comment about the Thomas splint application. As a professor of orthopedics, I have always tried to teach people to apply a Thomas splint properly. But many a time the Thomas splints are applied in a reverse direction. That's only a small comment which I want to make, because that's something which I have failed as a teacher over the years. But the results are fantastic, and the bone reconstruction is well done. Since you have a better vascular surgical team, you could always do a vascularized fibular graft for bone loss, because that is one thing which I remember when I had a brief association with Professor Bangarsamy in Madras. He said, you learn one technique, that is a vascularized fibular graft, which will help you as an orthopedic surgeon in the future. So that is something which you can always consider for significant bone loss. Any questions, please?
Sorry, I'm Dr. Jijiraj. So it was a fantastic presentation. Congratulations for that. So a few questions about it. One is, how much is the length of the free fibula which was harvested for the first case? And was there any internal fixation which is being used? Because there was a bit of discrepancies of the double barrel fibula. And number three, how will you compare with the Elizarow's method for the bone distraction for a 15 centimeter gap? Thank you.
So the defect what we measured was around 18 centimeter approximately. So we had to take a bit more lengther fibula, because we had to telescope one end into the shaft, get it back, and the double barrel was in the metaphyseal defect. Since it's a big defect, that's why we went in for a double barrel fibula graft. I have records of still much more bone loss patient, 20 centimeter, 22 centimeter, which we have done, which we have put just a strut graft with a plate and took both iliac crest and filled the defect. I have a series of that. But since this was a metaphyseal defect, that's why we went in for the vascularized fibula. And the other part was that no iliac crest bone graft was used for such patients. So that was, and you were asking what was the fixation. We fixed it with a LRS.
Any internal fixation which was used?
No. There was no fixation. It was only with the...
The third question was when you compare with distraction osteogenesis, how is the result, the time duration which is taken with the union of the fibula and distraction?
Personally, I do more of a LRS fixator. Ring fixators are not done by me much. In our hospital, like there are other team who does the LRS fixators, but I prefer the LRS much more. The results were good. The thing was, we could weight bear the patient much faster. If you see the last slide of the kid which I showed, I think the whole treatment was around 3 months. And within, I think around 2.5 months, she was running around with the LRS fixator. She comes down to see me. She was actually running around in the... So the fixator wise, I feel LRS is very stable. But yes, the ring fixators do play a role, but in my hands, LRS does much better.
Any further questions? I would say that the take-home message should be that what you are having in your hands, what you are best at doing it, and what are the armamentarium and the support staff you have. With that, you can do the best possible work which you can. And you can see that most of the cases which you presented were young patients with which are handled much more earlier, and which have a better, their transfusion, their ABCD is taken care of faster. You know the Ganga score and the MES score and all, they get a better results than if once the age is more and they have associated comorbidities. Anyway, it was an excellent presentation, and in the end it is like what you can do in your hands, the best for the patients. The results can be equally matched by other techniques as well, but you have done a wonderful job. Thank you, Dr. Abhishek.
Thank you.
Thank you, sir. I would also like to thank Dr. Jayaprakash and Dr. Pramod for chairing the session. Thank you, sir.
Next, I invite Dr. Shaji Matthew and Dr. Jacob for chairing the sessions. Next sections will be by Dr. T.M. Balakrishnan, Professor, Department of Plastic Surgery, Madras Medical College. Topic of sessions, Management of Peripheral Nerve Injuries and Management of Flexor Tendon Injury.
Good morning, everyone. Good morning, everyone. I thank the organizers for providing me this opportunity, and also another special thanks for running these two topics in continuum. And the first topic is going to be on the management of the peripheral nerve injuries. Let us move on to some basics. What happens when the peripheral nerve is cut? There is for 21 days, there is going to be a period called a Valerian degeneration, in which in the proximal cut end up to the proximal node of Ranvier. Okay? So there is going to be a kind of a degeneration which happens up to this proximal node of Ranvier. And then subsequently, in the distal end, or simultaneously at the distal end, there is a degeneration of myelin sheath, axon, axonema, down to the level of the effector organ. So after that, by the synthesis of the neurotropic factor from the central nervous system and neurotrophic factors there from the effector organ, there is going to be a formation of a porous tube formed by the proliferation of the Schwann cells, which invite, and once the nerve is co-opted like this, that invites the regenerating axonal sprout towards their destination. And this is called band of Bungner. And subsequently, the axon started growing at the rate of 1 millimeter per day. And the myelination also starts there. And this is the basic unit of any peripheral nerve system. And you have the regenerating axon in the center, which has got the axolemma, axoplasm, and it is engulfed by the Schwann cells, and subsequently there is going to be a myelination formed by the Schwann cell. And thereby the nodes of Ranvier are formed, and thereby the reinnervation begins to happen. And it is enclosed there in a cytoskeleton called the endoneurium, and such a multiple nerve fibers are enclosed there within the perineurium, which is forming the fascicles. And multiple fascicles are all enclosed in another cytoskeleton, and that is the epineurium. Now, what is the applied importance of this Wallerian degeneration? Remember, for the 3 weeks, for a meaningful interpretation of an electrophysiological test, the Wallerian degeneration must be completed. So it is better to order for neurophysiological test after 3 to 4 weeks following the nerve injury. And what is the applied importance of rate of regeneration of axons? So we have two different organizations in the peripheral nervous system. One is the sensory, the other one is the motor. In the motor, remember that we are running race against the vitality of the end plate, the motor end plate. In the adult, it's going to be up to 9 months. The vitality is retained following any nerve injury. In children, up to 12 months. So we have formed, or we have coined a rule of 3. We call that as MMC rule of 3. And before 9 months in the children, and before 12 months in children, before 9 months in the adult, we can do 3 important procedures. The primary nerve reconstructive surgeries. It may be a direct neurography, nerve grafting, or nerve transfer. After the 9 months in the adult, after 12 months in the children, you can do 3 procedures, which are all the tendon transfer, the muscle transfer, or a free functional muscle transfer, or the simple salvage procedures like arthrodesis or arthroresis. Okay. So what is there on the sensory organization? Remember that even after several years later, if you could bring about a proper nerve anastomosis, the regenerating axons can go to the effector organ, especially the fatefacinian corpuscle, which retains their vitality for a long time. Or it itself can form a free nerve ending which can protect or which will give a protective sensation. So that is the essential subtle difference between the motor and the sensory organization in the peripheral nerve. Now, in any other wound, in the peripheral nerve wound healing, one should mainly, here we have the chance, one should aspire for regenerative wound healing. That will have the best outcome. Okay? So, how to promote a regenerative wound healing there in the peripheral nerve? The most important are the 2 factors one has to observe is, the one we have to promote regenerative wound healing, and the another one is the anatomical repair. When I say anatomical repair, we must have the perfect matching of the fascicle. Motor fascicle to motor fascicle, sensory fascicle to sensory fascicle. This is based on the internal topographic anatomy of the peripheral nerve. So, to promote the regenerative wound healing, we have to co-opt the nerve endings which in the tension-free manner and without any ischemia. The next important thing is atraumatic handling without causing any injury to the vasculature of the peripheral nerve. And another important thing is co-opt the ends, which should be tidy. Otherwise, you will be precipitating a local compartment syndrome within an inelastic healing epineurial cytoskeleton that may cause mesenchymal healing. Always try to have a well-vascularized bed and well-vascularized cover. This will promote regenerative wound healing. Rest after the nerve repair, and try to utilize a vascularized nerve graft rather than the inert nerve graft, because as the axons cross the second anastomotic site, invariably there will be a scar which may bring down the outcome in the case of inert nerve graft. So, in order to promote a regenerative wound healing, apart from atraumatic handling, magnification, diligent handling, microsurgical sutures 8090 are needed. If you don't follow all these norms in your repair or in your technique, it is likely to going to result in a mesenchymal healing, which becomes very predominant and which will trap all the regenerating regenerating axons are trapped there in the scar, and that forms a painful neuroma, and the outcome will be very less. So what we mean by anatomical repair? The next important factor to bring about a good outcome. And you know that when the sensory axon and it enters into the endoneurial tubule, which enters there or which is going to end up there in a motor end plate, it's going to be a wastage. It gets pruned. Okay? So to avoid this kind of an axonal wastage and the pruning effect, one should go in for good knowledge of internal topographic anatomy of the peripheral nerve at every stage. For example, at the proximal wrist crease level, look at the last picture. On the volar aspect, you have a sensory fascicle, small sensory fascicle, which can be easily visible on your loop magnification. And then on the dorsal, you will have a motor fascicle. So you have to aim for a grouped fascicular repair in order to avoid a sensory wastage, axonal wastage. And like antibiotic stewardship, we do also must practice a powered stewardship. Remember that instead of going for a proximal nerve transfer, one should aim for a distal nerve transfer, otherwise called target neurotization. And it should be a scar-free bed, and you must also have the joints during the regeneration of axon must be kept full of range of movement. And try to re-nervate extensors over the flexors and give the importance to the antagonist over the agonist. And then whenever you do a muscle transfer, a tendon transfer, or a free functional muscle transfer as a part of the salvage surgery, try to observe three important principles of tension capability match, tendon excursion match, and length tension ratio to be maintained. And non-essential sensory fascicles sometimes can be excised, and it can be even used as a vascularized nerve flaps. And it is very important that whenever you do in a situation a proximal nerve transfer, in order to rule out the second injuries along the nerve, you must dissect it down to the level of neuromuscular junction to rule out any second injuries, which are the common reason for the failure. And then whenever you do a peripheral nerve repair, look for the gel mushrooming, which says that there is a central persistent connection. Okay. So this is called the power stewardship. And the nerve transfer, which I said, try to have always a target neurotization, which convert the proximal injury to the distal injury. There is a subtle difference that exists there between the proximal and distal nerve. I'm going to quote few of them. The proximal nerve repair is there done very close to the point at which the peripheral nerve emerges from the central nervous system, whereas towards the target effector organ, when you do the repair, it's called target neurotization. And single anastomosis is usually done in target neurotization, but there may be a nerve graft in the proximal site. The important thing in the target neurotization is the donor nerve is harvested close to the neuromuscular junction and anastomosed near the recipient site close to the neuromuscular junction in such a way that the regenerating axon has to take the shortest route. Thereby you will have a early recovery and best recovery. Okay. So this is ultimately going to be the protocol. So you are going to divide the peripheral nerve injury, whether it falls within this period of 9 months in the adult and 12 months in the case of children. If it is going to be beyond that period, you are going to do only a salvage procedures. And within this period, you are going to look for whether it's a closed injury or open injury. If it's going to be a closed injury, remember that many times there may be a neuroplastic element and give the time for them to recover. At the same time, after the 3 to 4 weeks, you order for electrophysiological test. The one thing, the electromyography, the MUP, the multi-unit peak potential, one should look for. If there is going to be a giant MUP, that is a sign that it is regenerating axon is good, or the pathway is lied down for the regenerating axon is less scar-free. And therefore, once you have that sign, you can observe and continue your conservative measurement. On the other hand, if you don't see any kind of a giant MEP after the period of 4 to 6 weeks, explore and do the primary nerve reconstructive surgery. On the other hand, if you have open wound, you have to go in for a primary nerve reconstructive surgery in a case of the clean cut. Okay, if there is a gap, go for the nerve transfer or the nerve grafting. If it, on the other hand, even if there is an element of suspicion from the history and on examination, you find there is a traction element, tag the nerve, re-explore and do that as a delayed primary repair after a period of 4 to 6 weeks, because you are likely to find where are all the scars, where are all the neuroma, and thereby you can go for a definitive repair at that time. So this is the protocol one has to follow for a peripheral nerve repair. Okay, sometimes you will have a neuroma in continuity and the patient has come very late, but there are several functions which are intact as shown by the regenerating axon, which are black in color. In this situation, we go for a black boxing. Under the propofol awake stimulation, we isolate the fascicles which are all not intact proximally by stimulation intraoperatively. And similarly, this other thing on the other end of the neuroma, and then we do the group fascicular repair. So this is called the black boxing. But in the case of the children, you can completely excise even this neuroma in continuity and then can go in for nerve grafting. And when you have a lateral neuroma, this is the way one has to go and do the repair. And now we'll see several clinical cases. And this is a situation where you have a 20.5 centimeter nerve gap following the excision of sarcoma in the extensor compartment of the arm. And that was excised. That left behind a composite defect of the arm, in which there is a bone defect and there is a nerve gap. There is a muscle in the middle of the triceps was also lost. Therefore, we have harvested a chimeric fibula flap. And look at that here. The superficial peroneal nerve was harvested based on one perforator there from the peroneal artery. And there is a bone. And there is a peroneus longus muscle also harvested based on another perforator. And there is a bone and there is a cutaneous paddle for monitoring. And the bone fills the bone gap, the nerve fills the gap there in the spiral groove of the radial nerve, and is based, this is a vascularized nerve flap. That is the essential difference. By the time the axon, they cross the second anastomosis, they will not face the scar barrier. And thereby, the effect of the outcome, effect on the outcome will be better. So look at that, this patient, at 12 months period, and he has got a flickering extension of the fingers, but he has good wrist extension, which is possible because of this vascularized nerve flap. Okay, next case is a complete neurotomesis in an 8-year-old child with a supracondylar fracture and dislocation. And now that is the status in which the child presented, and the X-ray shows a dislocated supracondylar fracture. And that was fixed there by the K wires, which are seen there at the top end of this picture. And then the nerve is repaired there, proximal to the trifurcation of the radial nerve in the cuboidal fossa. And that is the result in the 7 months. And you can see there is a lag in the extension of the fingers. But over the period of the splinting and physiotherapy, you can have a very good recovery on the side of the involvement. And this is possible in a case of children. When you have such kind of an eye injury, you must always go in for internal splinting in the case of the adult. Now we'll see the median now. Okay, this patient has presented for the late after the period of 8 weeks, where there was a median nerve was not properly repaired when it was found cut. And we find that there is a thenar muscular atrophy and there is absence of any abductor pollicis brevis action, and his apposition is also deficit, and there was a sensory loss in the radial 3.5 fingers and radial 3.5 aspect of the hand. And the electrophysiological test shows a possibility of neurotomesis, and then we go in for exploration. You find that proximally the bulge is due to that of the neuroma, and distally it is because of the glioma. And now you find that there is a gap, and how to approach this one. We go in for a kind of a bread loaf excision, and here what we have to do is 3 things are observed intraoperatively. One, how much is the fibrosis is there, whether you are getting the gel mushrooming of the fascicle, and then the vascular or bleeding pattern of the cut end. Okay, so this point we cut the neuroma. And then the next step after cutting the neuroma, you still find that, but what is the most important thing is that here, you notice that the median artery on the nerve is well maintained. Even the perforator arising from the median artery, which is supplying the adjacent flexor digitorum superficialis, is also maintained. And when we do that, again, one fascicle, the large one fascicle, motor fascicle, is gel mushrooming, but the other one, the other areas, it still the fibrosis persists. Therefore, again, another kind of a blood flow excision has to be done until you get, you can see the gel mushrooming of only one fascicle. That is the median artery perforator to the flexor digitorum superficialis. And now again after the blood of excision of that particular area, you will get the good bleeding and good gel mushrooming. And then now the distal end, the glioma is also similar kind of the blood of excision is done until you get a kind of half. Here you cannot expect the gel mushrooming. The rest two area, look for the fibrosis, look for the architecture of the fascicle, and then the internal topography, you identify the fascicle size. And that is a glioma preparation, glioma site preparation. And these were all after the multiple excision. And the gap has to be filled by inert sural nerve graft. What you have to understand in the inert sural nerve graft, you must reverse it in order to garner this funneling effect. Because when you do in orthotopic manner, here all the regenerating axon have a chance to go through the side branches and there will be an axonal wastage. So when you reverse it this way, you will find that they will reach their destination. So this is called the funneling effect of reversal of any inert nerve graft. And grouped fascicular repair with a good match, understanding the internal topographic anatomy just proximal to the wrist was done here. And that is the immediate post-op. And this is the late 12 months. You'll find that the patient is having a good Kappanji score of 10, able to do a good apposition, and then he is capable of making the good face and good apposition and good grasp. Now we'll move on to the ulnar nerve. High ulnar nerve injury. Remember, in high ulnar nerve injury, we always combine that with the Zankolis procedure in our institute, because this kind of an internal splinting will help to keep the disability of the clawing. Remember, the clawing is going to happen following about 3 months later. Reinnervation of the flexor carpi ulnaris and the ulnar half of the flexor digitorum profundus is going to cause the clawing. So when you combine with the high ulnar nerve palsy, the adynamic procedure of the Zankolis pulley advancement, you will find that this patient will have lesser disability during the rehabilitation period. And that is always you do a repair and then transfer that anterior to the medial epicondyle. And this kind of a disability like ulnar hand will be bypassed when you have this kind of combination of work. So look at that. This patient had the Zankolis procedure combined there with high ulnar palsy, and the nerve was repaired and transferred anterior to the medial epicondyle. The patient had because of the Zankolis, and he has recovered later with a good amount of half flexion of the flexor digitorum profundus on the lateral finger, and a good grasp in the last, utilizing his adductor pollicis in the first web space. And then this will happen. But in the low ulnar nerve palsy, it is very close to the effector organ. And again, here you need to go in for either a nerve transfer or a grouped fascicular repair. Sometimes you can utilize the anterior intraosseous nerve, you harvest from the substance of the pronator quadratus, and then you can utilize it for the motor, which is fascicle, which is situated on the dorsal aspect of the nerve close to the Guyon's canal. Here, the similar way, the excision of the glioma and neuroma, grouped fascicular repair, and that is the effect of the 12 months. And now common peroneal nerve injury. In the lower limb is the most common type of injury, and it may be associated with the head and neck fracture of the fibula. You can see the dangling common peroneal nerve along with the fracture of the fibula, and that is the nerve which is there dangling the distal end. And after the repair or the fibula fracture fragments were reduced, and then we go in for the repair of the common peroneal nerve, and that is the result of 12 months on the right side. Thank you. I think with the chair's permission, shall I proceed with the next topic, or take question and then proceed to the next topic?
I think we can have the questions now before proceeding to the next question.
Yes.
Thank you, Dr. Balashran, for the excellent presentation. Are there any questions? May I ask you a question?
Yes, sir. Yes, sir.
You presented a case with a very long vascularized nerve graft.
Yes.
What could be the length if you do use a non-vascularized inert grafts?
Yes.
What is the maximum length possible?
No, inert graft can be used even in that situation, but the results of that inert graft is less than that what you have with the vascularized nerve graft. Because once the proximal anastomosis, the regenerating axons can cross. And you all know that after the period of 30 days, the nerve will grow by 1 millimeter per day. So when the thing reaches, that means that it is going to be a 20 centimeter here, that means 200 millimeter, that means 200 days. When the regenerating axon is going to cross the second anastomosis, by that time, there will be always in the endoneurial tubules, there will be a scar barrier. So even though the things can happen by the effect of the neurotrophic factor, most of the time you will have in the vascularized nerve flaps, there will be no scar barrier because of the vascularity. Okay. That is the benefit of compared to that of the inert graft and the vascularized nerve flap.
Are you using nerve glue or sutures? Which one do you prefer, nerve glue or sutures?
No, I have no experience with the nerve glue, and I always use the fine suture material 8090.
Thank you. Are there any questions? Okay, you can proceed to the next talk.
Thank you, sir. Okay, so flexor tendon injuries. That is going to be the next topic. And the aim of reconstruction in any flexor tendon injury is to get back the full range of mobility, Apart from the triaging and ruling out of all the other priority injuries, the 5 important things one is to ask in the history of the any flexor tendon injuries: where, when, how. Because that is going to tell us about what are the associated injuries, extent of injuries, and what kind of a repair we're going to take for this injured flexor tendon, and what is the posture of the hand during the flexor tendon injury and associated comorbidities. That has to be optimized before going for the flexor tendon injury. The posture of the hand, if it is there in the flexion posture, when the injury has happened, the main thing is that the proximal cut end and distal cut end, they retract well away from the skin laceration. That means what? We need to have an extensive access incision to retrieve and do a anastomosis. When you have this kind of a ward-off injury during attack, this will tell you that the ends are all not retracted. The proximal distal cut end of the flexor tendon will be adjacent to that of the skin laceration. Therefore, the need for the access incision may be limited. Always do not miss the diagnosis of the flexor tendon injury, because the correct treatment will begin with the correct diagnosis. When you have such a kind of a large distracting injury, you may miss a small zone 2 injury which is there in the ring finger. This is reported as the no tendon injuries or no flexor tendon injuries, and when we explore that, we found out that there is FDS was cut with a 20% partial cut. And remember that more than 20% or 20% we need to go in for the consensus is going for the repair in the line of the complete cut tendon. The clinical diagnosis is easier and easier to diagnose, except in the case of the partial tendon injury. You need to know where there is any kind of a tenderness during the movement of the tendon. You need to isolate the movement of the flexor digitorum superficialis and flexor digitorum profundus by doing this kind of a test. Otherwise, the injury is very obvious, and because the finger is not falling in the rosette. And in the case of an inebriated patient, uncooperative patient, and the patient who is in the loss or altered sensorium, and this wrist tenodesis test will help us to know that whether the finger is coming in unison or not, will tell you about the presence of injury. But always when you have in doubt, please explore. And always treat the associated injuries, because then only you will have the best outcome. Okay, now if you see that this is a Jesse finger, there is an avulsion fracture involving the base of the distal phalanx and the volar aspect, but there is an associated injury there, osseous injury, associated injury there on the ungual side, there is an associated injury there on the pulp, there is a pulp hematoma. So all these things have to be taken care of in order to get the best outcome. In the case of zone 5 injury, zone 4 injury, always associated with the other nerve and the vascular injuries. So this has to be taken care of to get the best outcome. The flexor tendons are all the most commonly injured structures in any upper limb injury. The flexor tendons are simply the intercalary segment which transfer the power from the contracting muscle to bring about a movement of the joint. So, in the history of the flexor tendon injury, the one notable thing is that in the 2nd century AD, the great physician is Galen. And he considered that, this is the Klinet's word on zoning, and I need not elaborate on that. It is available in almost every textbook. But what is the more important striking feature about the history of the flexor tendon injury or repair is that the Galen mistake. It persisted for 1500 years, the 2nd century AD. Galen conceived that the tendons has nerves. He advised against repairing any tendons because he felt that it is going to cause the severe pain and twitching, and he advised against a repair. So that was the thing which persisted for nearly 1500 years. And then we'll move on to this principles of the flexor tendon repair. Remember the primary tendon repair, the primary tendon grafting is going to be done, almost is considered as a standard of care in all condition scenario. It should be done by the expert. And surgeon involved in that work should have a thorough knowledge of anatomy, biomechanics, and pathophysiology of the tendon healing. We all know that there are 12 flexors and there are 6 flexor zones. The flexors were arranged in the superficial, intermediate, and the deep manner in the forearm. And the tendons were also considered intrasynovial tendon, extrasynovial tendon, because there is an implication in their survival and the healing. We'll come to that in forthcoming slide. The cruciate pulleys always collapse, and that doesn't have much of connotation in the repair. And the A2 pulley, which is there, the most important pulley situated in the proximal 2/3 or the volar aspect of the proximal phalanx. And it can be either the distal 2/3 or posterior 2/3 or proximal 2/3 can be vented out when you do a repair. In the case of the thumb, we have only oblique and annular pulleys, no cruciate pulleys. And this is the distilled principle in the management of the various zones, zone 1 and zone 2 injury. In the case of zone 1, at the site of insertion of the flexor digitorum profundus, if you have such kind of an injury, it should be managed by the Tajima type of suturing. In the case of 1B and 1C, which are situated volar to the distal interphalangeal joint and just distal to that, just proximal to that until the insertion of the flexor digitorum superficialis. In this 1B and 1C, we need to use large amount of figure of 8 sutures. And in the volar to the metacarpophalangeal joint, volar to the proximal interphalangeal joint, we need to repair the 2 tendons. But whereas volar to the proximal phalanx, volar to the middle phalanx, we need to repair the single tendon. And this is the preferred method, and this has to be practiced. And the tendons receives their blood supply, especially the extrasynovial tendon, they have the segmental blood supply, and that is through the mesentery called mesotendon. And the ligaments are important because they maintain the moment arm, which increase the mechanical efficiency of the flexor tendon. The tendons have predominantly the type 1 collagen. And like any cutaneous wound healing, here also there are 3 phases, inflammatory and other 3 phases. But the most important thing is that there is called an intrinsic healing of the tendon and extrinsic healing of the tendon. Okay, so one should always strike a balance with both the intrinsic and extrinsic healing of the tendon, because intrinsic healing itself is insufficient. Therefore, we need to have a complementary extrinsic healing following the repair of every flexor tendon. And how do you achieve that? Following the repair, the tendon in the post-operative period need to be mobilized. Early protective motion protocol should be done. And the importance of which I'm going to tell you in forthcoming slide. But we need to strike a balance by transporting or facilitating the extrinsic wound healing by that way you are trying to transport the mesenchymal cells from the surrounding area in a well-vascularized surrounding area. That's why I said that the flexor tendon repair should also have a better well-vascularized cover. From there, the mesenchymal cells are transported, converted into the tenoblast, and they start proliferating and producing and contributing to the extrinsic healing. Why I said that the intrinsic healing is insufficient? Because it doesn't have that amount of the tenocytes within the substance of all flexor tendon. Either so, it is there with the extensor tendon. And in the presence of depleted growth factors, intrinsic healing itself is insufficient. So it has to be complemented with the extrinsic healing. And remember, the intrasynovial tendons will have the predominant survival using the diffusion nutrition, whereas the extrasynovial tendon will have a perfusion nutrition, but both by intrinsic or whether the intrasynovial, extrasynovial, the tendons have to be moved, and moved tendon, stressed tendon only will heal better. And especially when we want to have a complementary extrinsic healing, we need to aim for a membranous adhesion, filmy adhesions, which are responsible for the transporting the external mesenchymal cells towards the site of the repair to contribute for the tenoblast transformation. So that is achieved by type 1, type 2, type 3 kind of adhesion. And it may be an open injury or it may be a closed injury. Closed injuries are rare. It occurs in certain general conditions. And you can have a partial cut and you can have a complete cut. But remember, more than 20% of the partial cut need to be managed in the form or in the line of complete cut tendon. Eeping of the frayed ends, increasing the diameter at the suture site, and especially not providing a smooth gliding surface, increased diameter at the tenorophysis site are likely to increase the work of gliding and likely to precipitate the two important complications of the flexor tendon repair, which is the tendon adhesion, the other one is the tendon rupture or dehiscence. And important thing is that you can use core stitch. The core stitch must be multi-stranded. That is the most important principle one should follow. On the left side of this picture, you can see the Kessler bundle. The other one is a Savage. But what we follow in our institute is this one. This consists of the 4 locking cross stitch, which grasp the tendon substance of 0.75 centimeter with each grasp, and it will have a single knot. So that is the important thing, which is going to be buried there at the tendon approximation site. And this 4-stranded double core stitch will give the 40 Newton of the tensile strength of the repair, which is far away and provides a better amount of a safety buffer between the movement protocol, which is going to be practiced there after the repair of the tendon. So thereby, you can have a multi-stranded stitch facilitating the post-operative motion protocol. And the two best things to prevent the 4 and 5 adhesions is that you have to have the early movement protocol and multi-stranded stitches which facilitate the early movement protocol. There are multiple innuendos you have to practice there. This is available in every textbook. But what is more important is that use for the core stitch the 40 Prolin 3/8 needle round body. And for the epitendinous, which also add to the strength of the flexor tendon repair, it should be done by the fine material like 50. And remember, the grasping locking stitch can be of any type, but what we said that this cross stitch have got the better amount of the substance purchase and thereby provides a better tensile strength of the flexor tendon repair. The epitendinous sutures can be of any type, but we always follow simple over and over continuous. And these are all the factors which is likely to increase the work of gliding, and this should be avoided. Rough gliding surface, tight sutures, edematous tendons, and when you are trying to suture over that, it will cause a further amount of work of gliding. And bunched up repair, untidy sutures, sutures projecting beyond the point of anastomosis, and all this will lead to the work of gliding will be increased and lead to ruptures and adhesion formation. The extensor tendon adhesion and the range of mobility, if it is not properly maintained, it may also lead to the increase of work of gliding. So it is very important that the stressed tendon will heal better. There is the unstressed tendon will have a dip in the tensile strength in the 3rd to 4th week, which will overcome by using the multi-standard core stitch, because it has been proved beyond doubt by multiple laboratorical and the peer studies. They show that clearly that the stressed tendon effectively and early way it recruit all the tenoblast, and the proliferating pool of the tenoblast increases tremendously in the stressed tendon, and more formation of collagen, and the collagen which is in the tertiary phase to the quaternary phase is rapidly formed, thereby the tensile strength is obtained early, and all this contribute, or all these findings favor the early motion protocol in the postoperative period. And the two important complications can be easily prevented when you follow all these things which I said previously. And defect size in the fibrous flexor sheath less than 2 centimeter can be simply ignored, and A2 can be vented, as I said, either proximally, distally, about 2/3 can be, with impunity you can do that. And we'll move on to these are all certain distilled principles which need to be followed. The purchase of the core stitches must be at least 1.5 centimeter on either side of the anastomosis. And the extensive exposure of the sutures must be avoided at the tendon suture site. And at the completion of your flexor tendon repair, please do this test, which is called GGI test, the gliding and the impingement. And then the most important thing is the triple point. When you do an hyperextension, you have to look for gaping. 1G stands for gaping. And when you do a flexion extension, it shows that whether the gliding is smooth. And when you do a full flexion, look for any kind of an impingement of your flexor tendon site, repair site, in any of the area like fibrous flexor sheath or any other adjacent structure. And every time when you do this kind of a GGI test or the triple point test to know that your repair is healthy, at the same time it is not, or it is favoring the smooth gliding. The investigations are all redundant in most of the time in the flexor tendon injury, but you need to have sometimes in the case of a closed injuries, ultrasound or MRI is needed. Contraindication for the flexor tendon repair is a heavily contaminated thing, and when there is also an associated infection in the late presentation cases. And the preferred anesthesia now is coming up is called Valen technique, wide awake local anesthesia, no tourniquet technique. Because the patient is now allowed to have active movements on the table, and you can check the triple point test there on the table with the help of the patient moving the parts. And the tourniquet necessary, and the access incisions are varied, mid-lateral or Brunner's incisions. And the flexor tendon repair can be called as various types. There is also a need which type of repair is needed, which I told you in the previous slide. Remember, zero delay work within 72 hours, and the delayed primary repair up to 1 week period, delayed primary repair up to 1 month with or without tendon graft, and secondary flexor tendon repair definitely with the tendon graft, which is needed after the period of 1 month. And the types of the repair, suppose you have a rupture in the post-operative protocol, you need to repair that. If it is less than a week, less scar, you can go in for a tendon grafting immediately also. And this is the Valen technique, and this is the recipe which uses 1% lignocaine, and is used without any problem, adrenaline combination with the lignocaine injected in the midline of the fingers. And that produced a very good analgesia, and it permitted him to do all the flexor tendon repair. And now each zone, and which I already described about the zone 1 and zone 2, and this is zone 1 injury, Jesse Finger classification, Leddy Parker classification. The importance here is in the type 1 injury where you have the avulsed fracture fragment and the tendon, when it comes to the palm, it rapidly degenerates. So there is an urgency in repair of this type of injury within the period of 3 weeks, but you can go in for a delayed work there in the type 2 and type 3. This is the Tajima type of the suturing that is needed there in the case of avulsion fractures or the avulsion of the flexor digitorum profundus from the volar aspect of the distal phalanx. And this is the type of the repair specially required for the type 1 or in the zone 1 injury. The multiple figure of 8 stitches, multi-stranded stitches are needed, at least 5 of them is needed, especially in the zone 1 injury. And in the post-operative protocol, along with the dorsal block, the 30-degree flexion at the wrist and 30-degree flexion at Madagabu-phalangeal joint, the IP joint in the distal IP joint must be kept by another plaster which keep that at 30-degree flexion. In this posture, it can be mobilized in the passive manner following that in the 24 hours. And in the zone 2 injury, remember that the retrieval of the tendon must be done as a traumatic manner. There are 2 methods of the retrieval of this tendon. One is McRouther's armalis, which is a railroad technique. You will find that the flexor digitorum profundus sometimes in the palm, but beyond that it cannot retract because of the attachment of the lumbrical. Sometimes even the lumbrical can be avulsed, in which case you will find it in the zone 5. And this can be used for the railroading technique, or sometimes you can reverse needle if it is there found just in the zone 3, the proximal cut end. And in the zone 4 and 5, the associated nerve injuries and vascular injuries has to be taken care of. In the digital pulley reconstruction, in the secondary stage, when the first stage you induce a pseudo-induction of the smooth gliding pathway using the implant, and secondarily with the tendon graft, you need to reconstruct some pulleys. And what we always prefer is the Strickland technique using the facial graft. And the post-operative movement protocol can be an active and passive, but what we follow commonly in our institute is a combination of an active and passive movement protocol. And in the case of we always follow the place and hold exercises, and especially in the case of the zone 3, zone 4, zone 5, and this is the place and hold exercises under the supervision of physiotherapist. We keep the splint there in position, and then the patient is allowed to hold the ball or round object at least for the period of the 60 seconds, and then he has to drop that. So this is repeated every 10 times or 15 times there in an hour, 24 to 48 hours after the repair of the tendon. But in the case of the zone 2, we need to have a differential gliding between the flexor digitorum superficialis and the profundus in order to have a better repair. So we do the Kleenex traction here, and that is the Kleenex traction here in the zone 2 repair. There is an active extension, but there is a passive flexion here. In those patients who do not have that much of IQ, or in the case of a patient who is not cooperating, a passive Duran-Hauser protocol can be done in this situation. 2 complications most important to be avoided: adhesion and the rupture. This is a zone 2 flexor injury, and it is there a single tendon repair because they are situated there volar to the PIP joint. And after the repair of the flexor digitorum profundus here, associated nerve injuries has to be repaired, and you will have a good return of function. This is about 13 months following the physiotherapy and the return of function. The secondary tendon grafting, sometimes this is needed when the patient doesn't have a proper conducive environment for the primary repair. The patient has to be taken for the secondary repair. Invariably, we need to go in for a tendon graft which is harvested there from the flexor digitorum superficialis. And the tendon graft is done there between zone 1 to zone 3 because the repair should not impinge there in the narrow osteofibrous tunnel. This is done along with the dilatation of the pulleys. And look at the way the tendon is being managed here. It is there with the umbilical tape, which is there applied to the proximal distal end. The anastomosis is completed. At the end, you check for the true or smooth gliding of this tendon graft through the pulleys which are there being dilated. And then the repair is completed between zone 1 and zone 3, and that is the result. And now come back to this zone 5 injury. FC is cut, it's called spaghetti wrist. More than 3 structures cut in the zone 5, it's called spaghetti wrist. Ulnar neurovascular bundle cut, FDS cut, median nerve cut, FDP cut, and DP cut, FPL cut, pronator quadratus also cut, and FCR cut, PL cut, repair from the deeper to the superficial aspect. All structures are repaired as a primary manner. And then the physiotherapy. This is after the period of 10 months, the patient could have a good amount of flexion, but the extension lag is still there. You need to undergo further physiotherapy. And zone 5 and zone 6. Remember, whenever you do a flexor tendon repair, try to give the immediate cover, because any tendon which is injured is divided half its segmental blood supply. It is prone for drying, desiccation, and death process. Therefore, this was a paddy trasher injury. The patient was left for a long time after the simple debridement by the surgeon, and it was referred to as after the extensive debridement, there was loss of half the median ulnar nerve and as well as the flexor tendons. And then his staged reconstruction was carried out, and then the patient had the 4 sessions of the reconstruction of the flexor tendon and the ulnar and the median nerve using the inner nerve grafts, and that was the good flexion he could achieve after the period of 12 months. And zone 6 injury, this is especially area where the muscles need to be repaired specifically, and here you can go in for the myography, and the need of immobilization is just 3 weeks, and then you can mobilize them, and then you can get this kind of result in the case of zone 6. Thank you very much for your attention. Now I'll take the questions for this session. With the chair's permission, of course.
Thank you, sir. So it was such a detailed,
Thank you, sir.
It was such a detailed, wonderful lecture and a presentation.
Thank you.
Almost, I think you have covered the entire topic in flexor tendon repair and surgery. And to add just a few points, can you discuss about the Hunter's rod, silicone rod insertion, how long we have to keep it
That's
there?
true, but the time constraint is there.
Yeah, no, sir, I just want the
So
questions.
it's a very large topic. That itself we can do it by a 1 hour lecture. I do agree with you, sir.
Thank you so much, sir. Any questions from the audience?
So, thank you, sir, for the wonderful presentation. Just to, there is a delay in asking the question. This is about the previous presentation.
Yeah, okay.
The vascularized nerve graft was used for that arm defect,
Yes,
no?
yes, yes.
So, is it a cable graft which was used, or is it because the radial nerve size mismatch is there? So, is it a single vascularized nerve which is used, or is it being placed as a cable?
Yes, again the superficial peroneal nerve is used as a whole based on its peroneal perforator. Okay, the whole superficial peroneal nerve was there taken and anastomosed proximally and distally. It was not fascicular grouped repair, or the multiple cables were not used in that case. It's a single whole peripheral nerve, superficial peroneal nerve. Yeah, go ahead. I think you are not audible, at least. Go to the mic, no? Krish?
Why?
Yes.
Why superficial peroneal? Why not sural?
Yeah, remember that always the superficial peroneal nerve resists the better perforators from the peroneal artery. So when you have a chimeric flap, free fibula flap, especially, because some of the perforators may pass through the soleus, may supply a musculocutaneous perforator, but most of the time, remember the sural nerve has got a very prominent vasa nervorum, which is there supplied there from the median superficial sural artery. So it doesn't get its blood supply there from this peroneal arterial system. Therefore, in order to have a well-vascularized nerve flap to be harvested as a component of the chimeric free fibula flap, the choice is always superficial peroneal nerve.
Sir, because we raise a reverse sural, so we base it on the perforator of the peroneal vessel. Mostly,
You are talking about the free sural nerve flap.
Yes, sural nerve flap, the nerve is included in a sural flap.
Okay, okay.
In a distally based sural flap.
Yeah.
And that one perforator supplies the whole of the skin and everything over there.
That comes from there, from the median superficial sural artery, and its connection there from the peroneal system. Not there, that is a distal perforator.
Anyway, we are taking a skin paddle for this fibula.
Yeah, yeah.
So if the extension of the fascia along with the sural nerve, we could be harvest as that way also, I want to ask you.
No, that is what I am telling you. That paddle of the skin which here was harvested, there from the middle third.
Middle third.
In the lower third only, you will have a prominent
Yes.
connection
Yes.
for the median superficial
Yes.
sural artery with the peroneal arterial
Yes, sir.
system.
Yes, sir.
So utilize, if you want to utilize that through that anastomotic circle,
Yes.
it should be from the lower third.
Okay.
That's the reason.
Okay, thank you.
Okay.
Thank you, sir. Now I request the chairpersons, Dr. Shaji Matthew and Dr. Jacob, to please come out to dais to hand over the memento to Dr. T.M. Balakrishnan. I also request Dr. Binoy Sayujanandan to receive memento. Thank you, sir. The session continues. The next session is by Dr. Raja Tiwari, Associate Professor, Department of Plastic Surgery, AIIMS, Delhi. The topic is Reconstructive Elevator for the Upper Extremity Reconstruction.
A very good afternoon, chairpersons and all the audience. So the next topic is important because we have already seen how to repair and replace the nerves and the tendons. So next thing is, which is very important for a forearm reconstruction, is the skin part. And also there might be various and along with the skin, many times we use several other structures involving the muscles, the bones, and the tendons or the nerves. So keeping all that in mind, sometimes we have to choose the best possible option in a patient. And this is all the concept of a reconstructive elevator. So to begin with, a soft tissue coverage of the upper limb poses a serious challenge to the reconstructive surgeons. The quality of reconstruction has a significant effect on the patient's aesthetic and functional outcome. There are several options for reconstruction in the upper extremity, which involve skin grafts, local flaps, regional flaps, and free flaps. Now, classically, the approach has been to use the simplest method, providing the most stable coverage, and this is called the reconstructive elevator. So, by using the reconstructive elevator, we start from the simplest option by which we can cover a defect and then move on to the next complex ones. However, with this method, you are not providing the patient with the best possible option. So sometimes we have to end up doing multiple stages to achieve our final outcome. The reconstructive elevator concept means that if the resources and the skill is present, we should aim to achieve the best reconstructive goals in terms of form, function, and aesthetics. And this we will discuss in this topic. So in order to set our goals for achieving the best possible reconstruction, we also know what is best in terms of the reconstructive options. So to understand the best, we have to consider certain clinical situations. Number one is the site of the defect. So different site of defects such as the hand palmar defects, dorsum of hand defects, forearm or elbow defects, they have their own skin requirements. So we have to consider reconstructive options based on the situation. Now, different injuries may have different tissue requirements. In some cases, there may be additional loss of neurovascular structures. Some may have a loss of muscles and skin. There may be lost tendons or sometimes even the bones. Also, we have to keep in mind the rehabilitation goals. So in the first patient, you can see that doing a pedicle flap in this case hampers the effective mobilization of the fingers. So the patient will end up in a stiff hand later on. And in this situation, if a free flap option is available, then we have to choose a free flap option in order to perform better rehabilitation in the post-op period. We may also have to consider the donor side requirements. So all flaps which are harvested from different parts of the body may give rise to different types of donor scars. So we have to discuss the donor side scars of on different parts of the body along with the patient. You can see this is the calf, the forearm, and the groin. So we have to discuss in detail with the patient and come to a final conclusion. Once all this is decided what we want, the next possibility is whether it can be done. And the challenges in terms of a reconstructive surgeon are requirement of a pedicle length. So if we are doing a free flap, we have to know what length of a pedicle may be required. And secondly, if we'll be able to harvest the flap simultaneously along with the primary team in order to reduce the duration of surgery. And lastly, we also have to consider whether we are capable of doing or we have enough experience of performing that procedure. Now, depending upon the different reconstructive goals, we have our different options. So the number one is the skin defects of the palmar hand and fingers. And the requirement of a flap in this location is it should be thin, it should provide a sensate and glabrous skin with a good color and texture match. Many local flaps are available in the hand, which include the cross finger flaps, unilateral proper digital artery flaps, advancement flaps, reverse short or metacarpal flaps, thinner flaps, and so on. And similarly, many regional flaps are also available for coverage of palmar defects. However, in many cases, poor acceptance by the patient, along with poor appearance and requirement of multiple operations, may lead to joint stiffness and later other problems. So, in terms of managing a large skin defect of the palmar hand, our choice of flap is the medial plantar artery flap or the medial plantar artery perforator flaps. And the advantages being that it provides a significant amount of glabrous skin for the palm reconstruction, and it is a versatile flap, which means that it can provide a fasciocutaneous, musculocutaneous, flow through, perforator based, and chimeric variants. And in this picture, you can see that there was already a scar. This was a scar from a pre-existing skin graft. So the patient again had a contracture. The skin graft had to be excised and replaced by a medial plantar artery perforator flap. And in the post-operative period, you can see that a good color and texture match has been obtained. Next, we come to small defects of the fingertips. Now, one of the problems with medial plantar flap is that the regeneration of sensation in the medial plantar flap is not as great as other flaps or as what is required for a fingertip reconstruction. So the second flap in our armamentarium are the partial toe flaps. So partial toe flaps are taken from one of either the great toe or the second toe. They also give like a glabrous skin, which can be made sensate. The only thing is that the pedicle length is small, so we should have recipient vessels which are very close to our defect. And sometimes there can be anatomical variations of the dorsal vein. And the great toe can provide us with a larger flap as compared to a second toe flap. And in this picture, you can see that the fingertip of the ring finger has been reconstructed with a great toe flap. Now we are coming to the skin defects of the hand dorsum. So the peculiarity of the dorsum hand defects is that it is a visible part of the hand. So the color and texture match should be perfect, and also many times secondary procedures are needed. So the flap should be easily be available to be elevated in the secondary stages, and it should be easily to perform with minimal donor sites. And one of the better choices for such reconstruction is the superficial circumflex iliac artery perforator flaps. So these flaps provide good color and texture match, and they have a hidden donor site in the groin. So in the post-operative period, we can easily mobilize the hand if it is required for rehabilitation purposes, and there would be a concealed donor site. The only problem with this flap is that it has a short pedicle length of around 3 to 4 centimeters only. And in situations when a long pedicle length is needed, the second flap in our armamentarium is the medial sural artery perforator flap. So this flap is taken from the calf region. It can provide a pedicle length of 8 to 10 centimeters, and it can provide thin supple skin. The only problem being that sometimes the calf can be hairy, and the color and texture match is not as great as the other flaps. The third flap in this series is the lateral arm flap, and the benefit of using this flap is because it is in the same region, so the color and texture match of a lateral arm flap is much better in compared to the previously mentioned two flaps. But the problem with this flap is that the donor site is on the visible side of the body. So if the patient is a male and who wants to wear half sleeve shirts, then sometimes if the defect is not closed primarily, then the grafted area may be visible, creating some problem with the aesthesis. Now coming to the second type of defects, which are defects of the skin of the hand, forearm and arm. So hand, forearm and arm regions mostly have larger defects which cannot be managed by the previously mentioned flaps. So in such conditions, the most versatile flap is the anterolateral thigh flap, because it can provide ample amount of skin, and there is propensity to take tendon grafts or free nerve grafts, or sometimes even muscle, vascularized functioning muscles from the same region, making the anterolateral thigh flap the first option for managing all types of defects of the forearm and the arm region. The only problem with the anterolateral thigh flaps is that sometimes the perforators can be unreliable or small, and they can have an anatomical variation. So the surgeon has to be quite skillful in choosing the perforators carefully, preoperatively. Then there are the long defects of the forearm and the arm. So these mean these defects are very long, sometimes longer than the total length of the anterolateral thigh flap. So in such situations, one of the flaps which can be used is the deep inferior epigastric artery flap, which is taken from the abdominal part. And if you measure the length from one ASIS, almost 5 centimeters distal to the ASIS also, onto the contralateral size, then we can get a significantly long flap. But if we have to make this flap survive completely, then we do have to anastomose both sides of the pedicles, or the both DF perforators have to be anastomosed. So this significantly increases the operative time, because two venous anastomoses, two arterial anastomoses have to be performed. Although the advantage is that it is far from the reconstructive site, so two-team approach can be used to use this flap. Now the third category of defects are the circumferential skin defects of the hand, forearm and arm. Now DF flap is a long flap, it is not a wide flap. So when there are circumferential defects of the hand or the forearm, then we need more tissue or more tissue which can provide a significant amount of surface area. So in these situations, the scapular, parascapular and latissimus dorsi flaps can be used as single or chimeric flaps to cover all these regions. In this picture, you can see that there was a circumferential defect of the hand, and parascapular and latissimus dorsi flap has been done to completely wrap the hand and the volar and both the dorsal aspect of the forearm. Now, what disadvantage of this flap is that it needs position changes for the reconstruction, so which may increase the total operative time. Although the benefit is that we can also take bone along with this flap if we tend to do a bony reconstruction also. Then there are the defects of the skin along with functioning muscle, and the gracilis myocutaneous flap is one of the best flaps for supplying good muscle tissue, long muscle with a long tendon to deal with all types of flexor tendon losses. The gracilis has a very anatomically good nerve or motor nerve also, which can be easily traced, and there are barely any anatomical variations in clinical practice. The next type of defects are the defects of the skin and the bone, and all of us must know that the vascularized fibular bone is one of the best options for managing defects of the upper and lower extremities. So in this particular child, this was a small child, 3 years old. So we not only needed a bone which was vascularized, but also which could grow in the future. So in this case, a vascularized epiphyseal fibular transfer was done along with part of the muscle for extensor muscle reconstruction. And at the end of the postoperative period, that you can see that the skin, muscle and bone requirements all have been solved in one single go. And finally, there can be composite transfers. So there can be situation in which the entire length of the forearm is lost. So in these situations, we need not only the skin, the muscle, the bone, but also the nerves and the tendons. So these type of defects can also be dealt with by using combinations of various sort of flaps that we have mentioned. And I'll be discussing more about this particular case in my next presentation. So coming to the final slide about how to choose the best option for a particular defect. So we can see that the hand defects, the palmar, hand and finger defects are best managed by the medial sural artery flap if it is a large defect, by the toe pulp flap if it is a small defect. The defects of the dorsum of hands are managed by the skip flap if we want a concealed donor site, by the lateral arm flap if we want a good color and texture match, but we can accept the donor site scar. And if we need a very long pedicle, then a medial sural artery perforator flap is a good option. Similarly, all defects of the forearm and arm, when there are multiple or extensive soft tissue defects, then we can use a ALT flap. And if there is a large circumferential defect, then a scapular flap is a good option. Defects which have, in addition, requirement for muscle, then ALT with the vastus lateralis muscle can be performed. And if a large amount of bone is also required, then a fibula osteocutaneous flap with muscle or nerve can also be used. So coming to the conclusion, so microsurgery has introduced innovative techniques for successful restoration of the hand, arm and forearm defects. Free flap coverage of the upper extremity defects offer a wide range of options to deal with majority of defects. And following an algorithmic approach, we can choose the best option in terms of patient, form and function replacement. Thank you so much.
Thank you, Dr. Tiwari. You have shown some wonderful results with the concepts of the reconstructive elevator concepts.
Thank you, sir.
Now the topic is open for discussion. Are there any questions from the audience? You have shown one partial toe pulp transfer for the reconstruction of an amputation stump of the finger. Why you didn't consider toe transfer? Was it not willing?
Actually, it was the patient's requirement. So he did not want to lose any toe. He just wanted to have an opposing surface for which we can hold the objects. So it was not one of his priorities. Otherwise, we would have definitely done a toe transfer in that case.
Thank you. If there are no more questions, thank you very much, Dr. Tiwari.
Thank you, sir. I also thank Dr. Shadri Matthew and Dr. Jacob for sharing the session.
The next session is by Dr. G. Karthikeyan, Professor and HOD, Tamil Nadu Government Multi-Super Speciality Hospital, Chennai. The topic of the session, Management of Extensor Tendon Injury.
Vanakkam. I would like to thank the organizing team for two reasons. One, it has given me an opportunity to meet all my friends here. And secondly, they have realized that the extensor tendon injury is more important than the flexor tendon injury because they gave only one topic for flexor tendon and 3 for extensor tendon injuries. Thank you, CIPRA team. Right, next. Yeah, so as I said, extensor tendon injuries are more than the flexor tendon injuries. And a single tendon injury is injured in about 72%, and especially the index finger extensor tendon injury. Commonly injured zone is zone 3. So today, what our agenda is going to be for the next 12 to 15 minutes is going to be what are the zones of extensor tendon injury, what are the general principles in the management. So that is what we're going to cover in this topic. So now the zones of extensor tendon injury, first originally it was described by Kleinert and Burden into 8 zones. Whereas later on Doyle modified it and said there are 9 zones, where the 9th zone was the muscle injury, extensor muscle injury. So this is zone 1 that comes over the distal interphalangeal joint. Zone 2 comes over the middle phalangeal region. Zone 3 over the proximal interphalangeal joint. Zone 4 over the proximal phalangeal region. Zone 5 over the metacarpophalangeal joints of all the fingers. Zone 6 is over the region of the metacarpals on the dorsum of the hand. Zone 7 is over the wrist, and zone 8 is proximal to the wrist till the musculocutaneous junction, and zone 9, as I told you, described by Doyle, is the muscle injury. So if you look at it, zone 1, 3, 5 and 7, that is the odd numbers all come over the joints, whereas the even number zones come over the bone region. So, similarly, it is slightly different in the thumb. In the thumb, what happens is, zone 1 is over the interphalangeal joint, zone 2 is over the proximal phalanx, zone T3 or zone 3 of the thumb is over the metacarpophalangeal joint, and zone T4 is over the metacarpal bone. So, the treatment of extensor tendon injuries can be non-operative or operative. That is not so in the flexor tendons. It's always operative in the flexor tendons, whereas in the extensor tendons, it can be non-operative and operative. And we shall also see the techniques and the rehabilitation. Of course, the complications. Now, the presentation of extensor tendon injuries in the zone 1 and zone 2 injuries, inability to extend the distal interphalangeal joint. We'll deal with this in the next topic when I'm going to talk about the mallet finger injuries. But remember, the extension of the distal interphalangeal joint, that is, from 90 degrees of flexion to 0 degrees, that is the neutral position, is not by the extensor. The first 30 to 40 degrees is by the oblique retinacular ligament. Only the final 20 to 30 degrees is by the extensor tendon. We need to remember this. And zone 3, when there is an injury in zone 3, remember, zone 3 is an odd number, so it's over the joint. So inability to extend the PIP joint, but it could be variable. Zone 4 and 5, extensor lag is common. Here we always make the mistake of asking the patient to just lift the fingers in the air. That is a problem. You have to keep the patient's hand on the table, palm flat down, and ask him to lift each finger up from the level of the table. That is very important. We all tend to miss this point. You can have a partial extension. That is because the junctionate tendinae can compensate a little bit for the extension. And secondly, there may be a sagittal band injury. And zone 6, 7 and 8, you will definitely have a extensor lag of the fingers. In zone 9, when it comes to an injury at the level of the muscle, you also have to think of one more thing, whether the nerve also could have been injured at that level. So the general principles, radiographs and MRI, especially radiographs, are important mainly in the mallet finger, and we shall see that also later. The non-operative management could be immobilization with early protected motion, distal interphalangeal joint extension splinting, proximal interphalangeal joint extension splinting, and metacarpophalangeal joint extension splinting. Now, I'm talking about this as a main course of treatment of management of an extensor tendon injury in certain injuries, and sometimes it is also an addition to the surgery that you may be doing. So immobilization with early protected motion, when you find that the laceration of the extensor is less than 50%, you can go ahead with conservative management in all the zones. And if the patient can extend the digit against resistance, it means that it is less than 50%, so you can go ahead with conservative management. Distal interphalangeal joint extension splinting is for the mallet finger, and as I said, we'll talk about this because I'm going to talk about the mallet finger also. And the full-time splinting is for 6 weeks. And we need to avoid hyperextension. Proximal interphalangeal joint extension splinting, since I'm going to talk about the boutonniere also, I'll talk about this later. So here it is closed central slip injury. As you know, zone 3 is over the proximal interphalangeal joint. And we'll talk about the details. Metacarpophalangeal joint extension splinting. Close zone 5. Usually we never place the metacarpophalangeal joint in extension in any splint. You all know that the collateral ligaments can get tight when the joint is kept extended. But here it is important that you keep it in this position. There are a few exceptions to this rule. You can do it in certain situations, and we'll discuss that later. But here in a closed zone 5 sagittal band rupture, and full time extension for 4 to 6 weeks is important. So operative treatment, what are the principles of operative treatment? IND. Now this is a very different thing from flexor. In a fist injury, you have an injury over the knuckle. Sometimes the patients present late. So there you might have an abscess. Very important to clean this area, because cleaning this only will get you a good healing. Only then you can go ahead with tendon repair later on. Second is tendon repair. Tendon repair can be done. Then fixation of bony avulsion is the third option. And lastly, tendon reconstruction. So these are the 4 types of treatment with extensor tendon injuries. IND is one of the methods. Tendon repair. Fixation of bony avulsion, because the extensor tendons can be avulsed along with the bone. And tendon reconstruction. So as I said, fight bite to the metacarpophalangeal joint. You need to get good healing of the wound so that you can do a repair or reconstruction later. And they say that the Echinella corrodens is supposed to be the commonest organism that from the mouth that can infect, contaminate the wound. Now tendon repair, if laceration is more than 50% of the tendon width in any of the zones, it needs a good exposure, good suture, good technique. One important point we need to remember is that to get a good repair, as a matter of fact, in any hand surgery, please make a good liberal incision. Putting 2 more sutures is not going to do any harm. But trying to look for the tendon or trying to do a repair within a keyhole doesn't help anybody. It's only going to cause more scarring, and that we definitely do not want. Fixation of the bony avulsion, like in bony mallet finger with the terminal phalanx volar subluxation. Here you need to fix the bony avulsion by different techniques. I'll be showing you one of the techniques in the video. Tendon reconstruction. Tendon reconstruction. We have seen repair of the extensor tendon. We have seen avulsion and fixation of the bony avulsion. Tendon reconstruction is indicated in extensor injury, in chronic tendon injury, when repair has not been possible or repair was not done, patient has presented late. So you can do it in 2 forms. You can do a graft or you can do a tendon transfer. As far as rehabilitation is concerned, the most important, all the books will talk about early mobilization after extensor repair. In my experience, I do not follow early extensor repair. Somehow I feel that all the Western books, they talk about early extensor repair after, early movements, mobilization after extensor repair. Somehow I feel that Western hands and Western tendons are different from Indian hands and Indian tendons. I do not know how many people here follow the early mobilization, but I always follow the static immobilization technique. After any extensor injury, it's very simple to remember. Extensor injury distal to the metacarpophalangeal joint, immobilize for 6 weeks. Proximal to the metacarpophalangeal joint, immobilize for 3 weeks. Very simple to remember. At the level of the metacarpophalangeal joint, also 3 weeks only. So at the level of the metacarpophalangeal joint and proximal to it, any zone, immobilize 3 weeks. Distal to it, immobilize 6 weeks. Sometimes, we need to put in a K-wire, for instance, for a mallet finger injury. Do we have to immobilize with the K-wire? Not needed. You can always take out the K-wire. If you're worried about pin track infection and bone infection, remove the K-wire at 3 weeks, but follow it up with a correct splint to continue the immobilization. So total of 6 weeks. Complications that can develop, adhesions. The commonest complication are adhesions. When you have adhesions following extensor tendon repair, what happens is you have less of function. You have a loss of flexion. That is very important. Tendon rupture and swan neck deformity. Tendon rupture is also a common problem. And of course, boutonniere deformity. I think we'll be seeing those also later on. Adhesions, I told you, leads to loss of flexion. That is a dangerous thing because he went in for extensor repair, now he doesn't have full flexion. That is because of adhesions. It is common especially in zone 4 and zone 7 because they come over important parts of the bone. So next is prevention. How do you prevent these adhesions? early protective range of motion. When I'm talking about early protective range of motion, I'm talking about after 3 weeks. After 3 weeks, start using the hand. You advise them to start. If you see these patients, if you follow up these patients far enough, you will find that it takes about minimum of 1.5 months after you remove your POP for the full extension to be got back. It is very important to follow up these patients, because usually we never give the same importance to extensor tendon injuries as flexor tendon injuries. Extensor tendon injuries take a long time. It is very important to keep following them up and advising them to flex the finger. Only after they get back full range of flexion of the finger, assess what is the deficit in the extensor tendon. So how do you treat it? If you have extensor adhesions, you need to do an extensor tenolysis. Complications like rupture. Rupture is also a complication which could be due to the use of a poor suture material or technique, or aggressive therapy sometimes can lead to rupture. Non-compliance. Patient doesn't do any of the therapy afterwards. It's possible, or he doesn't wear the splint that you are given in the first 3 weeks. And the complication usually occurs in the first 7 to 10 days. This is very common. Even in flexor tendon injuries repair, the complications occur in the first 7 to 10 days. So the treatment for rupture would obviously be early recognition and revision repair. If it has not been recognized early, it is better to wait till all the tissues are soft and supple and go ahead with reconstruction. Late rupture, as I said, tendon reconstruction. Thank you. And before I say thank you, do you want to have a hands-on training for flexor, extensor repair, hands-on training, nerve repair, vessel repair, eyelid repair, local flaps, and ear cartilage carving, all in one day with natural tissues and at a reasonable rate? Yes, it is done. Look out for TANPAPS 2024, February 8th at Chennai. Thank you.
Thank you so much, sir. Such a well-detailed lecture on this extensor tendon injuries. We are all your YouTube subscribers also, sir. So any questions open for discussion?
No questions. Good. I'm also hungry. Thank you.
Thank you so much, sir.
Thank you, sir. I also thank Dr. Shaji Matthew and Dr. Jacob for chairing the session. We will continue the remaining session after the lunch break. I request all of you to please collect the certificate.
Now I welcome Dr. Pradeep and Dr. Gigi to chair the next session. So please assemble. Next speaker will be Dr. Aniraj. So he is the professor and HOD, Department of Plastic Surgery, Government Medical College, Trivandrum. So he will be talking on flaps for hand reconstruction.
Good afternoon. First of all, I congratulate my allied friends for restarting this program. Because of COVID, last few years, this program was not there. And again, for inviting me to present this topic. So, flaps for hands reconstruction. I think all of you might have done at least few flaps, because this is part and parcel of hand surgery. So this is a very important topic in hand surgery field. When you think of hand surgery, what is our aim? So the first and foremost aim is you must have a proper function after any type of surgery. It may be a nerve surgery or vascular or whatever it may be. You need good function. That means we have to restore the function. So that means we have to restore the mobility, sensibility, cosmesis, and the donor side morbidity should be less. So it must be durable. So the best possible function with least morbidity and best cosmesis. So what we need? So we need to cover the bare bone, joint, tendon, nerve, implants, or any volume deficit in the hand. So how will you plan a flap? So flap is a broad topic considering, because each and every flap need a separate session. So I will just give an overview of, so all flap surgery needs good planning, because in plastic surgery, in first year itself, we said case planning. Yeah? So planning is very important in planning in flap surgery. So before planning, we have to examine the patient, carefully examine the patient. Then we have to communicate with the patient as well as the family. Then we made a surgical plan, what to do. Then we have to check the equipments for the particular plan is available. Then we mentally reconstruct the technical sequence. So the overall aim is to reduce the morbidity and the flap failure. For making a good surgical plan, we have to do detailed assessment of the patient. For example, for this type of injury, you see this is a degloved thumb injury. The distal part was crushed and it was not replantable. So you have to assess the size and type of the wound, the structures exposed, evidently the bone, tendon, all things, nerves are all exposed, the zone of injury, age of the wound, and any previous incision, any infection. You plan for any vessels, the donor vessels, any perforators nearby. Then is it a dominant hand or not? Patient is smoker or tobacco use. Then you have to consider other medical comorbidities. Then you have to think of the equipments. So the first and foremost is magnification. When I was a PG student, I don't have any exposure in magnification and all. When I joined in Ganga Hospital in 2001, the first day itself, Rajasapavati sir, we affectionately call him as SRS, told me that Aniraj, you must buy a loop. But at that time, the loop comes around only 60,000 rupees. I don't have money for that. What he did was, every month, he will cut 5,000 rupees from my salary. So that is how I got. So what he tells us, when you can see better, you can do better. So even after 25 years, these words are precious. When you can see better, you can do better. So you need magnification for all types of flap surgery. Then hand Doppler. So nowadays, where even for a transposition flap, if a perforator or something is there, it is well and good. So hand Doppler. Then hand surgery instruments. Then sutures. Then tourniquet. So at that time, before joining there, we were reluctant in doing surgeries under tourniquet. But when we do under tourniquet, especially in trauma cases, you will feel the difference. So if you have a good high-end microscope, it is well and good. So you must have heard the talk about the reconstructive ladder, then elevator. So elevator is, you can jump, but it depends on your institution, your infrastructure. So we are getting at least 15 cases per day, and sometimes you may have to do at least 5 or 6 flaps per day. So your elevator may be different from an institute, a higher institute. So elevator is different, but it is well and good. So finally we can see the reconstructive triangle. That is, this is a triangle with one side form, the other side function and safety. So the flap planning, the flap you choose must be safe for the patient as well as for the surgeon himself, because flap loss is a disaster. So coming to the technical plan. So when you see a cases, this is the previous case I have shown you. So you can make a cover in different ways, because my plan will be different from yours. And it varies in institutions also, and your equipment also. So the plan, so this type of cases, we have to do the debridement, then you have to measure the defect, and you have to mark the perforators, then you have to see if there is any available nerves. So for these cases, we plan for a reverse radial forearm flap. So this is another thing. So these type of cases, fingertip injuries with doubtful vascularity, this is a common error in our hospital also, in a medical college. So somebody will just put a pin over that, a needle or a cannula. So within days it will go for gangrene. Actually, in the initial stage itself, we have to assess the vascularity. If you have good microscope or infrastructure, you can revascularize it. Or if you don't have that equipment or your infrastructure is not up to that, you can debride that, you can put some other flap. In this case, this is after the gangrene, we put a thinner flap. Then coming to the classification of flaps for hand, generally, just like any other flaps, it can be local, regional, distant, and free flaps. So coming to the local flaps, there are emptying number of local flaps, lot of local flaps. But the most common one we are doing is the triangular volar skin flap. It can be a single flap or on the lateral two triangular VY advancement flap, it is called Cutler flap, or an oblique triangular flap. There are so many. Then the other one, cross finger flap, that is the most common flap, commonly done flap everywhere. Then you have the first dorsal metacarpal. There's a lot of flaps, local flaps for the hand surgery. For this case, you can see this is a Cutler flap. You mobilize triangular flap. This is based on the subcutaneous pedicle. Definitely it needs magnification, otherwise the flap will come out during dissection. So this is a single volar flap for the fingertip reconstruction. This is the the last picture is the thinner flap for the middle fingertip reconstruction. So this is another flap, oblique triangular flap, actually described by our own surgeon, Dr. Venkateswamy. But when you see after flap insert, so this is an oblique triangular flap based on the digital artery and the nerve on that side. So this is done by my resident. When you look carefully in the postoperative picture, you see the contour. So the tip must be round. So you must take care of that aspect too. So the contouring of the flap, the shaping of the fingertip. Then coming to the cross finger flap, it is the most commonly done flap in the hand, very simple flap. So still it is the most commonly done flap in our place also. So actually when I searched for few pictures of cross finger flap, because it is too commonly done, nobody took pictures. So this is a flap done in 2008. So you can see the fingertip volar defect on the ring finger. So it is covered with a cross finger flap from the dorsum of the middle finger. And this is, the thing is that you will get, instead of the volar skin, you will get the dorsal skin. It will be a black skin. So that is the problem, but still it is very simple. The initial days we were putting split thickness graft to cover the donor defect. Nowadays we are putting full thickness graft for the donor defect. So this is a recently done. We have put a full thickness graft over the donor defect. This is another case for little finger defect, little finger tip volar side defect, cross finger flap. Usually the second flap division will be after 14 days, 10 to 14 days. Then, so there are a lot of local flaps. I don't have time to enumerate all this. Then we will go for the regional flaps. So the most common regional flaps, one is the posterior introitious flap. It's a very versatile flap. It's very interesting to raise the flap because the anatomy and all, if you are thorough with the anatomy, it is very interesting to raise the posterior introitious flap. Then you have the reverse radial forearm flap. So then coming to the distant pedicle flap, the first and foremost is the groin flap. Every hand surgeon, because groin flap was done in 1972 by McGregor, still it is the most commonly done flap for the hand surgery. So every hand surgeon must know, because it is a versatile flap. Still, if you can go for free groin flap, but still this pedicle groin flap is one of the most versatile flaps for the hand. Then abdominal flaps, chest wall flaps. So this is groin flap. So I don't have time to enumerate all anatomy and all. So usually we will divide in the third week. So we can divide it early if the insert is good. So we usually divide it in 2 to 3 weeks. So this is syndactylization after division. So we will separate it after 2 to 3 weeks. So same thing, you can, if the patient is comfortable with the chest flap, you can do the chest flap. Actually, it is a random pattern flap. Nowadays, we look for any perforators using Doppler. Then, so the flap will be more robust. So you can have the chest flap for ring avulsion. Then coming to the free flaps, so if the indications for free flaps in our institution is if the OT is related, because in our government institution, the OT is, usually we don't get slots. So if the OT is relatively free, you are getting a nice patient, and the indication is also there. We will go for free flaps. So this is an innervated radial artery superficial palmar arch flap. This is taken from the crease. So this is a free flap based on the superficial palmar arch of the radial artery, and the nerve is also there, the superficial palmar branch from the medial nerve. It is anastomosed to the ulnar digital artery of the thumb. So this is a very versatile flap. Then you can even transfer joint, tendon, or this is a composite flap from the second toe. We have taken the metatarsophalangeal joint for the replacement of for reconstruction of the metacarpophalangeal joint of the thumb, not the thumb, index finger. So this is the end result. So this is another sensate flap. So this donor site was from the first web space of the foot. So this is the result after 2 months. So finally, so these are the flaps. This is in general we are doing. So the most common flaps, as I said earlier, is the cross finger flaps and the groin flap. So finally, I have a word about the skin substitute. Suppose you have a defect like a mid-palm defect. So the reconstructive elevator, it may end up with a medial plantar artery flap, free flap. But in our setup, that is not possible. So we have put a dermal substitute, collagen. So this is the matriderm we have put. So in what flap surgery we have to avoid complication. So we have to think of these things. Can the patient tolerate the procedure? The comorbidities of the patient, evaluation of the donor and recipient side, the donor defect, adequate debridement, recipient vessels, then meticulous and efficient flap dissection. And that's all. Thank you.
Thank you very much, sir, for a wonderful demonstration of all these with nice illustrations. So actually, when we look, we both are from Kottayam Medical College. 20 years down the line, with or without loops, sir, you look the same. Any questions from the audience?
Actually, it gives a great pleasure because both of us are his students. It gives a great pleasure to be chairing a wonderful talk on hand reconstruction. If there are no more questions, we'll go on to the next session.
Thank you.
Thank you, sir.
Thank you, sir. The next speaker, Dr. Sabari Girish Ambad, Consultant Plastic Surgeon, Apollo Firstman Hospital, Chennai. The topic, Overview of Adult Brachial Plexus Injuries and Updates in Management of Adult Brachial Plexus Injury.
Respected chairpersons, senior colleagues, my teachers and friends. Oh, I have been given a very difficult thing to talk about after a good lunch. Anyway, and I have been given enough time, half an hour compared to others. So let me see if I can do justice to it. Adult brachial plexus is not a very infrequent problem. It is basically a little more neglected than other problems which we see usually. What strikes you in this photo? I would like, yeah? Sorry. Okay. What strikes you in this photo? You see they are all very young, either college going or just joined some work. And they are in the very productive age group. And this injury is really devastating for them. And it is not about the person itself alone, you know. Furthermore, we have a situation where we usually, there are so many jinxed features in these nerve surgeries that initially it was like nerves don't grow, so no point in doing it, and then very extremely unpredictable results. So that again differs you from promising anything to the patient. So from there, why is it not moving? Okay. We see like this, such patients, father and son, Both of them had a road traffic accident, which is the common cause. Both of them, the father was driving and son was sitting behind. Both of them have similar brachial plexus total palsy. Father sacrifices all his money for the treatment of the son, and he remains disabled like that. He says, I don't want to do anything. So it's a huge tragedy. It's not only for the patient or the individual, it is for the family, and in turn, it is for the nation. That is why my guru, Professor R. Venkataswamy, with whom I have been trained and I have been working from 2007, he always says creative hands should be protected at all costs. And it is with that notion, with a lot of like-minded microsurgeons, this group of brachial plexus surgery group of India was started in 2003, way back in 2003. Few of our Elite Mission SUSHRUTHA group are members of it. Dr. Pradeep is an executive member, and he'll be conducting the next conference in 2025 on brachial plexus here in Thrissur. The problem is, it is a difficult place to operate, the neck, because it's a very complex anatomy, lot of crisscrossing of nerves and a lot of branches being given, and there are a lot of other vital structures around it which if you damage can lead to a lot of morbidity. So in general, it is a relatively complex problem. So that is why many of them were not keen on venturing into it. But eventually, in the past 25 years, 25 years, we would say that the treatment for brachial plexus has moved in leaps and bounds, and now we can assure many things to these patients. The other problem is, as a brachial plexus surgeon, any new patient of brachial plexus injury comes, even in the best of the best clinicians, there is a difficulty in diagnosis. Why? Because there are several lesions in one plexus. For example, in the photo which we have shown here, C8, T1, and is all avulsed. That is, it is completely pulled off from the root. That is a preganglionic lesion. Then C6 is a rupture, which is a postganglionic but completely neurotomesis. Then there is one where it's an axontomesis. There is axons are ruptured inside, but the nerve is intact. And then you have one which is normal. So there can be a combination of mix-up of all these injuries in a same patient. And furthermore, the distal branches from the brachial plexus can have double level lesions. For example, suprascapular nerve, if there is a fracture in the scapula, in the notch area, you can have another injury which you will miss only if you keep looking at the neck area alone. And there is no single tool which will give you a complete picture. But one thing is for sure, if there is an avulsion or a rupture of a nerve root, then there is no scope for spontaneous recovery. So the false sense of, any brachial plexus injury you see, you wait for 6 months with physiotherapy and electrical stimulation and hope for the best is not the right way to go ahead. We all know all these facts. I just wanted to revise, Dr. Balakrishnan was very crystal clear on all these things. Having said, there is all salvage procedures will not give good results. Early nerve reconstruction only will give the best results. Nerve grows only a millimeter a day, and the muscle atrophies completely in 18 months. After 9 to 12 months, the functionality or the amount of muscle fibers which remain is very poor for a good quality function. So it is not only that then the distance from the nerve repair, when the injury happens in the neck level and the hand is paralyzed, the distance matters, because if you take at 1 millimeter a day, the nerve, by the time the nerve reaches, the muscle is gone. So I would say it is a race against time whenever you see a brachial plexus injury, or for that matter in any nerve injury, it is a race against time. So finally, if you want to diagnose, it should be a collective amount of history taking, clinical examination and investigations, which should give you a rough idea of what kind of injury it is. So when you do all that, you know where is the level of the injury and what are the available donor nerves which we need to reconstruct this plexus. It's not moving. We can broadly classify them into partial palsy and total palsy. Total palsy means no roots are available, all of them are injured. Partial means if the upper plexus, 5 and 6 is involved, we call it upper plexus palsy. If it is a lower means it's CAT1, and if anything in between, we call it as extended palsy. But what is more important is whether the root is still attached to the spinal cord or not. Because if it is not attached to the spinal cord, then there is no scope for recovery of that nerve at all, and that root cannot be utilized in any way. However, if the injury is post-ganglionic, that means the root is still attached and there is an end to it, you can utilize that nerve root using nerve grafts to give some useful nerve supply to the rest of the muscles. You can neurotize that nerve root. So, just to tell you where the injury happens in a pre-ganglionic and a post-ganglionic. Pre-ganglionic injury is from the spinal cord itself. But in that, what happens is the sympathetic ganglion is spared. So the chances of contractures are very little. So if you see a very flail limb with no contractures, no stiffness, nothing, you should start thinking of pre-ganglionic injury. And if it is all got contractures, the fingers are tight, metacarpal joints are tight, MCP joints are tight, everything is tight, then you should think it is most probably a post-ganglionic. These are characteristic of avulsion injury. There will be no tinnitus. Tinnitus is something like, you tap the neck, and if the patient gives a shock-like sensation and he says that it is going to the fingers, you are sure that there are some roots which are post-ganglionic, which you can use for reconstructing the plexus. But if you don't see that, then it means that it is most probably avulsed. And usually in CAT1 avulsions, there is something which you see in the eyes. Look at the eyes. The left eye is smaller on the right side, this guy, and in him it is in the right side it is small. That is Horner's. If you see Horner's, most probably CAT1 is avulsed. And these patients suffer from a very different kind of incapacitating neuralgia called as brachial neuralgia, to the extent that few of them even have tried to commit suicide, and there is no big real good answers to this problem. This also tells you that most probably it is a preganglionic. You see the neck, it is scoliotic because of the weakness of the paraspinal muscles, and you see a bulge here. This is all pseudomeningocele. It's filled with CSF. So this all tells you that the nerve has been completely avulsed along from the spinal cord. The next most important thing is the motor examination. Every muscle around the shoulder, arm, hand, forearm, every muscle has to be examined. If you examine and put it in a chart, it will straight away give you a rough idea of where the problem is. So usually the shoulder is supplied by C5, the biceps and all are mostly by C6, forearm is by C7 and C8 with 6 also supplying few muscles, and hand is by CAT1. So if you color code these things, you will get a rough idea of what you are looking at. And that is how you plan where the injury is and what is going to be your reconstruction. Never forget to look for vascular injury in these brachial plexus patients, because when you see a large hematoma in the neck, always check for the pulse. Because if you have a devascularized limb which is just supplying on the collaterals, subclavian injuries, usually the limb will be surviving because of the collaterals which are going through the scapular side, humeral side, etc. But it will be poorly vascularized limb which will directly have an effect on the growing nerves. So reconstruction of the vascular tree is also important. The only investigations nowadays which we really look for or ask for from the patient is when we see the patient, the first we ask for an X-ray of the chest, and the next is the MRI, which is very, very important, and nerve conduction studies. Nerve conduction studies and EMG are of more of a prognostic value. You have done something, or you are waiting, seeing some recovery in the nerve, and you want to be sure that, oh, I think the deltoid is coming. I am not sure. So then you do an EMG, and if it shows peak potentials, then probably yes, you are in the correct direction. But it doesn't have any significance when you just simply send him after you know that it's a total palsy, and they are not going to give you any added information. X-rays, you have to look for fractures around the brachial plexus region. Most commonly it is the clavicle. Apart from that, scapula, rib, complete disruption of sternoclavicular joint, all these things can be seen, and they all indicate a severe violence or the trauma to that area, which is not a good sign, and you have a lot of scarring around that area. But what defines, what do you say that this is the investigation which I would really rely upon to a certain extent, is an MRI. If your radiologist can give you this kind of a picture, look at this picture, you see the rootlets emerging and it is becoming a root. If you can see rootlets and roots all along like this, and then you see this affected region where there is pseudomeningocele all around, the complete avulsion. And if somebody can give you cuts like this, where they see a retracted lower trunk, CAT1, there is nothing more to think about, These are the patients where you have to go in and do it. There is nothing more you want to know, and you don't need to wait. So MRI is essential, but should be done preferably in 3 weeks. Why 3 weeks? Because initial stages, when you do an MRI, everything will look white, and there will be no difference between the injured one and the edematous area due to the inflammation. So you wait for it to calm down and then do it at 3 weeks. You can see a pseudomeningocele, you can see all the roots like this. The next question comes, when to intervene. You have to keep following them very frequently, and whenever you feel that the recovery has suddenly stopped, that is the time when you should quickly intervene. Post-ganglionic, if it is recovering well, it is going as per the plan, the shoulder has come in 3 months, now the elbow is going to come, biceps coming, then you can wait. But if you feel that it is not going the way you want, shoulder has come, the elbow has not come, hand some movement is there, radial nerve is not coming. So when you find such kind of patchy recovery, then again you should be worried. You should quickly get in and do a exploration. And if you find a root avulsion of C8 and T1, there is no other reason to wait. You have to do it as early as even up to 1 month. 3 weeks you do the MRI, you find it, the next week itself you post and do it. Because if you do it at that time only, patient will have some useful hand function which you can achieve following a reconstruction. So whenever we do an exploration, we always make sure that an exploration is done. Why it is done? Because we want to know whether our clinical findings are correct. So you go in, dissect the nerve roots. This is the upper root, the middle. So they are all looking thick. So that is all injured. While now I will be stimulating the lower root, lower trunk, sorry. So once you stimulate, you see the hand moving. So this is a confirmation of the fact of whatever clinical diagnosis and whatever MRI has told you, they are all confirmed on the table, and depending on your findings on the table, you decide how to go about it. So exploration of brachial plexus is essential. You cannot skip an exploration and do something away from it in the initial at least a year or so. If it is beyond that, there is no point in exploring. So we can classify them into isolated nerve palsies, partial palsy, and total palsy. Upper plexus is 5-6, extended is 5-6-7, Then there is something called as T1 hand where it is C5, 6, 7, 8, but T1 is paired. And then there is lower plexus, 8 and T1. Total palsy means all are involved. This is an isolated nerve injury. Most commonly is either a suprascapular nerve injury or an axillary nerve injury. This boy had a weakness in the upper plexus which gradually improved, but his suprascapular never improved even after 6 months. On exploration, we found that there is significant scarring in the suprascapular root. So it was a very short segment, but it was thinned out at that level. So what we did is we just coapted, removed that segment, and we were able to primarily coapt it. And that is the post-operative result after 1 year. So if you have doubt, you should explore. Nowadays, there is nothing like if you explore, you lose anything. You only gain. You are sure that you are not missed out on anything. So always explore the brachial plexus. When it comes to 5 and 6 injury, you can see in this video, patient is unable to do good abduction. He has no elbow flexion, but his hand is fine. His wrist extension, finger flexion, everything is fine. This is pure 5 and 6. This is pure 5 and 6. So in these cases, we do something nowadays called as nerve transfers. Nerve transfers is nothing but taking shortcuts. So if you have C5, C6 injury, ulnar nerve, median nerve and radial nerve, all are available as small, we have them, and we can take one small bit of nerve from these funiculus from these good nerves at the level close to the biceps, deltoid and brachialis and connect it. So it is like something like a shortcut. So you quickly get the results. So these patients, if you do all these 4 transfers, and within probably 1.5 years, he will get a full range of movements, and these results are very, we can standardize and say yes, we can confidently tell the patient that please get it done early, we can give you results. It is not like, we may get, you might not get, it's not so. We are sure that you will get it. Then what if another root is also involved? C7 is involved means apart from what you have in upper plexus, you will lose, there is a weakness of triceps and there is weakness of the wrist extension, etc. So in these cases, we have to do something different. You do nerve transfers. This is the MRI which shows C5, 6, 7 injury. So you do nerve transfers and we add on more donor nerves to supplement the muscles which have become paralyzed because of the C7 involvement. For example, serratus. You can take intercostals and do it. And the triceps is weak. So you can use again another intercostal, extra intercostals for it, or you can use some other nerve. So like that, you go close to the target muscle and do a coaptation with the available donor nerves. So when you do that, usually the results are very quick, we can achieve them quickly, and at the same time it will become a very quick functional hand very quickly. And these also, to a good extent, we can assure them that you will get a nearly good rehabilitation. I'm sorry. So this is the same patient. He is 14 years down the line. He is a bus conductor. His only thing is that he wants to hold the railing once in a while. So with this hand, he was not able to do it. So initially he came so this is, now he is back to his work. So he's got a very powerful biceps. He has done a lot of exercise for it. So this is how it is. Now what if another root, one more root is involved? C8 is also involved. And only thing is T1. This will project as if the hand is also very weak. If you carefully see, the finger flexion is also weak. The hand is lying flail. But there is some movement. Flexors are still working. And MRI confirms the fact that it is a 5, 6, 7 avulsion and C8 is also involved. So you see the wrist lying, there's a wrist drop. And there is in the back you can see the serratus not working, winging of scapula, no biceps, But only good thing is he had a strong tenils. So the triceps also weak, hardly moves. So that is the tenils. You tap there, immediately he will tell you, yes, I can feel a shock-like thing, yes. So that means that it's a post-ganglionic. There is some root available. On exploration, we found that there are roots available, which we connected by using sural nerve grafts to posterior division of upper trunk and middle trunk. It's basically a reconstruction of the plexus. And at the same time, we wanted to do some nerve transfers also. So we did some nerve transfers for elbow flexion and wrist extension. So this is the 3-year post-op. Oh, sorry. So he is now back to his college, and he's joined. And he doesn't write with that hand. He's always been a left-hander, but he does most of the work. Total plexus palsy is always missed. The problem is it is missed thinking that it is something like a ape thumb deformity and you have a claw. So they think that it is something, there is a problem in the hand. And they usually come to us little late compared to other patients. So, and even in spite of that, you can see his involvement is in the left-hand side. And the only problem is he has got a weak hand. You see the thumb is lying in the same plane as the fingers. The finger flexion is there, weak, thumb is not opposing, and it is more like a claw. It's like a total claw. So what we do in this is, you do a claw correction, you do opponent's plasty, and because CAT1 is involved, the FDP on the ulnar side is weak, but on the median side it will be fine. So you basically tag all the FDP so that the tendons become stronger. So this is the same patient. After we did that, so it ended up doing a tendon transfer. But that is not all these things you have something to borrow from. But when total brachial plexus palsy, it is a totally different ball game, especially when all roots are avulsed. That is the time when we have to really go searching for donors. Where do we find donors to reconstruct? And nerve reconstruction is always better. And the aim is to reconstruct all the functions as much as possible. So when you follow the same principles of a plexus reconstruction or target-oriented nerve grafting from the neck, you end up getting only good shoulder and elbow, but no hand. Finally, the patient will have a shoulder and elbow, and a hand will be completely paralyzed with no functions. So you don't want that. Finally, in spite of all this, if your hand doesn't move, you are not able to do anything with that limb. So that is where you start thinking what are the ways by which in such total palsies how we can get a hand function. So it depends on many things, not only the reconstruction. It is about donor nerves. If you increase the number of quantum of nerves which can grow through a coaptation or a nerve repair, more number of neurons come, better. And if you can reduce the number of coaptation sites, repair sites, because if you put a sural nerve graft in between two ends, there will be two anastomoses which it has to cross. So if you can reduce that, and if you can have a nerve graft through which the nerve recovers faster, like if it is more than 1 millimeter a day, if it can grow in 2 millimeters a day. And what if the target muscles are many, you've got a lot of target muscles can be innervated, then all these things will help in improving and getting the hand function. And it also can be that if we can reduce the distance from the neck to the target muscle. For example, if you want a flexors to move, if you reduce the length of the humerus by 5 centimeters, you gain 500 days, you gain straight away. So that is also a strategy. So looking into all these things, there are procedures which are being planned. Nothing is standardized, but something which has come which is very promising is Wang's procedure. Wang's procedure is basically you shorten the humerus, try to get the lower root, C8 T1 root, trunk all the way to the opposite side neck and connect it to the opposite C7, which becomes the donor nerve. And in that you basically get more quantum of neurons, and because it is vascularized, it grows faster, and the length is also shorter for it to reach the target muscles. But what we do in our institution is our own, this one is what we call as all-in-one or a hole-in-one reconstruction, where we go for the contralateral C7. Why contralateral C7? Because you just compare the amount of neurons which you have in C4, intercostal, phrenics, spinal accessory, and compare it with contralateral C7. It is at least 5 times more than what it is. So you get a lot of neuronal output so that you get some function in the hand. You can take nerve graft of the ulnar artery based on the ulnar vessels and connect it like any free flap or a microsurgery to the blood vessels in the opposite side of the neck. Or you can take it as a pedicled based on the superior ulnar collateral artery, which is a pedicled VUNJ, vascularized ulnar graft, and flip it, turn it to get the function, to reach the opposite side of the neck. So when you do a vascularized nerve graft, we have seen that up to 2 millimeters it grows in a day. So it reaches faster. So almost the difference you see 19.5 months if it is just a regular sural graft, and it is only 10 months when you do a vascularized ulnar nerve graft. So how we do it, I just have a small video. You say once you dissect it out based on the vascular pedicle, it's a long nerve. So you can see the bleeding from the one end of it. And then we just flip it. Once you flip it, it comes to the opposite side neck. It is tunneled through the subcutaneous plane and connected to the contralateral C7 root. Taking C7 from the contralateral side does not cause any significant morbidity because no muscle is individually supplied by only C7. So whichever muscle has got C7 root in it will have also either C6 or C8 roots. So usually you will not find any motor weakness whenever you take a contralateral C7. So this is what we do. We do almost 10 nerve cooptations, and we direct the vascularized ulnar nerve graft with the contralateral C7 directly to median nerve for finger flexion. So what we achieve in this is more quantum of neurons coming in a faster way through the vascularized ulnar nerve graft to muscle groups which are more in number. So that way you are able to provide cooptation for almost all functions. So this is one of our patients. We saw him and we treated him within 3 months. He is a total palsy, complete avulsion, no native roots available, and we have done the same thing. And this is after 4 years. And in between, I am not going to talk about physiotherapy and electrical stimulation because it will be covered in the next this one. This is the same patient. So good shoulder, good elbow, and even thenar muscles. The most distal target muscles are the thenar muscles. So even thenar muscles. So if you want this, you have to get them very early. So in a total palsy, avulsion injury, there is no recovery. So do it as early as possible. That is the only way by which you can get the hand. So take home points, they are very complex injuries, but early reconstruction, nerve reconstruction only will yield you the best results. Partial injuries, the treatment is standardized and the results are also, we can assure them of a good result in most of the partial nerve injuries. But most important thing is early referral. If you find such a patient, no point waiting with trying physiotherapy and all. It is the best if you explore and do it. Total palsy still is a challenge, and only if you have an early referral, early diagnosis and early reconstruction, then only you can achieve a hand function. This is how our total palsy hand behaves. It's just like an Easter Island stone sculpturing. We don't know, nobody knows who has done this. But to move it from one place to another is an extremely difficult task. On one side, you have to have a good support from the family. On the other side, we all are sitting and treating him with physiotherapists. And then there is a third rope, which is the third hand, the God. And you have to have great faith in him. Thank you.
Thank you, Dr. Girish. Actually, thanks for coming all the way from Chennai to Thrissur and giving this talk for us. Actually, Thrissur is Girish's second home, and actually came home yesterday, came from there. Anyway, thanks a lot also for making this presentation simple so that everyone do understand.
Thank you.
If there are any questions from the delegates, please.
Sir.
That was a wonderful presentation and excellent results. What I wanted to know was, when we do an Oberlin procedure, you take one fascicle from the median nerve and ulnar nerve, you stimulate it and make sure there is a movement there and put it to the recipient nerve. Yes. But when you're doing this whole-in-one procedure, you're taking the contralateral C7 with the vascularized nerve graft and just attaching it.
Yes, sir.
How do you know that the motor branch is going to grow into that?
Initially we used to take small twigs of small nerves from the vascularized ulnar nerve graft and connect it to all the way from nerve to biceps, brachialis. That is how you see of a series of nerve. We used to connect them all the way along. What we realized is there is something called as neuronal steal, where the first coaptation takes away all the nerves, and there is no distal functional improvement. So now we have completely stopped doing that. We are only giving it directly to median nerve. So there is nothing in between which we are providing. So that is when we started getting these results.
So does it mean that you are not actually matching a motor fascicle to a motor fascicle?
No.
But it happens,
Yes,
as we can see the results.
It happens. Okay. It is very difficult at that level to say which is motor, which is this one. It's all a mix-up.
Okay, can I ask a corollary question with the permission of
Yes,
the chair?
sir.
Now, supposing you have harvested a contralateral C7 and you want to use it as a donor for a free functioning muscle transfer.
Yes, sir.
Will the same principle work? If I put any fascicle, will the muscle work?
It should. We have not tried.
Okay.
Because when you do this contralateral C7 with vascularized ulnar nerve graft, we have never got a chance for us to divide it and connect it to a functional muscle, because some function comes. So the problem is, the moment some function comes in the hand, patients are very hesitant to allow us to divide it and connect it to a functional muscle transfer. So in those cases, what we do is we go and borrow another 2 intercostals, connect it with the nerve graft, bring it in the at the medial aspect of the arm, wait. After 6 months, once the tinils comes there, then we do a functional muscle to augment it. So that is also not something uncommon which we do. We do because not all patients get good results. It all depends a lot on some unknown factors which we also don't know. And then there is about physiotherapy, how long they are persistent about it, how much they want. Some people eventually they accept.
Girish, just two questions. One is, how is the results of the deafferentization pain in your total palsy cases?
Whoever has got good results have hardly any pain.
That's all. Actually, that's the greatest advantage of these procedures in pan plexus.
Yes.
One more thing, I was a bit worried when I took back, before coming to a large brachial plexus meet, when I was checking through my records, I found a lot of cases of undetected phrenic nerve palsies along with these cases. Even in obstetric palsies. I was wondering because most of them are being treated in 2-3 hospitals, then later they come to me. None of those previous records have a recording of phrenic nerve palsy. If I don't check it and I do a procedure, finally it will become that I have created that palsy. So during the examination, I just wanted to know what is your experience.
X-ray chest is basically for all these things. It's not only about fractures, it's also for the, I missed it out. I had written it, but I didn't tell. So if the dome is elevated, there is a problem. But more than X-ray chest, if you ask anybody to do an ultrasound of how the diaphragm is moving on that particular side, even in children you can find out.
Actually, now I routinely do ultrasound. For
Ultrasound is much more better.
Any more questions? No more questions. We'll go to the next.
Thank you.
Thank you, sir. Moving on to the next speaker, Mr. Subin Solomon, physiotherapist in charge, Department of PMR, Government Medical College, Kottayam. The topic is role of physiotherapy in adult brachial plexus injury.
Good afternoon, dignitaries and delegates. Currently, I am practicing more into the brachial plexus injuries and stroke rehabilitation. So already in the abroad, the protocol developed for exclusively for nerve transfer is called as DAFRA, donor activated focused rehabilitation approach. So I have just did some modification, and what I observed that what we get within 8 years, we get within 5 years. And for a C5, C6 nerve transfer, what we get in 1.5 years, we get in 8 months. So I just want to introduce this protocol. So currently, what are the treatment techniques available in the nerve transfer is injection technique and DAFRA. And third one, which I have modified and I have presented to and I have published it, then neuromuscular electrical stimulation, bilateral arm training. That should be given in the starting part and also should be given in the later phase. And mental imagery exclusively for the neuropathic pain in preganglionic lesions. So what is injection technique is, which donor nerve they transfer, they need to do this 30 times per hour for 10 hours. So that means you should do it for 300 times a day. If possible, try to do it pre-operative. More you do pre-operative, more the post-operative results will be. So for example, for spinal accessory to suprascapular transfer, shoulder shrugging 30 times per hour. Oberlin you should do with flexion with ulnar deviation. Oberlin 2, flexion with radial deviation. C7 transfer, I have found 7 techniques to be done. If you do that 7 techniques, we get better result in C7 transfer, especially within 8 months, we can see the biceps movement and even the finger movements too. For phrenic, I have introduced the inspiratory muscle trainer, which is currently available in Indian market for a cost of 1,750. So that I have used for phrenic nerve transfer. So DAFRA, what they have done, published in 2016 was divided into 3 phases, early, middle, and late. I have just modified this into 7 stages. So the first stage, the donor muscle strengthening along with the recipient muscle passively we should do together. The second phase, donor muscle strengthening, the recipient muscle should be done in assisted. And third one, with strengthening, recipient should be active. So finally resisted. When you reach stage 5, patient will be able to do isolated movement, and 6 will be resisted. 7th, I go for functional training. So what especially happens here with training is neuroplasticity. So what you can observe here is, in the first picture, the nerve is intact for biceps and flexor carpi ulnaris. In the second picture, the nerve to the biceps is cut. So in the third one, Oberlin transfer was done. So in the third picture, if you see, the center for both biceps and flexor carpi ulnaris is same. But with the neuroplasticity, we get a new center for the biceps, which is adapted from the center for flexor carpi ulnaris. So main aim is of DAFRA is to produce or attain the cortical plasticity. Now coming to the stimulation, if you see in the earlier stage, you should try to give galvanic currents. They will give a brisk contraction like this. But after 1 year, with the NCS report, we need to take CMAP ratio. If the ratio is above 30%, immediately go to Faraday currents. Till you achieve 30%, you should try with only galvanic current. Once you cross the CMAP ratio of 30%, we can give Faraday current. So Faraday current, what is the advantage is, patient can do along with the movement, so it is mainly used for re-education. So I have shown you the picture, how it happens. Now this is a contralateral C7 transfer. Stage 1, what we have to do, the patient affected side is left side. So right side you resist it, left side the movement should be done passive. Now, when you see this Oberlin, this is a 65-year-old patient, 4 months old. So here what I'm doing is Oberlin 1 flexor carpi ulnaris. I just give a grip exercise, put in a gravity eliminated position. So donor is resisted, the recipient muscle is assisted. This was just after 4 months post-operative. Now, this is the one we do for phrenic nerve transfer. We use the inspiratory muscle trainer. The patient will do a deep breath, and the triceps we put in a gravity eliminated position. So all phrenic nerve transfer, I request them to buy this equipment. So this is another case, just 1 year old. The opposite side spinal accessory is transferred to PDLT. So in the right side, I resist shoulder shrugging. Left side, we put in a assisted position, the triceps moves, just after 1 year. Now, this is a C7 transfer for biceps, stage 3. The donor side, we do resisted exercise, and recipient side, he can do actively. The right side is affected. So as I told you, we do 7 actions. One is the extension of flexed arm against resistance. This is the first one. Second is adduction. The third one is internal rotation. The fourth one, arm across the chest. The fifth one is triceps and pronation and fast finger flexion extension. So these 7 exercises, if you do, we get good result in C7 transfer. And what I observed is, whenever you do triceps movement, biceps is more coordinated in a C7 transfer. And whenever you do a adduction movement, it is more coordinated with finger flexion. And the crossed movement is more coordinated with thumb flexion. So this was the first case I got reported with a finger extension with phrenic nerve. So just after 2.5 years, what I did is I put a lot of weight on his abdomen to resist the inspiration. So the other side, the affected side, he was able to do finger extension. So this is stage 3, donor resisted and recipient free range of motion. Both sitting and lying also. This is in sitting. Within 3 months, we got finger extension in sitting as well. So he was doing inspiratory muscle training also at the same time. So this also, if you see, the adduction is more associated with finger flexion. So this is DAFRA stage 3. When you do donor side range of motion, recipient side also moves. So this is a full range of motion was achieved within 2 years for this patient. He was able to do full free, abduction and full flexion within 2 years with this technique. The same patient, phrenic nerve transfer after 2.5 years, currently is able to lift 2 kg weight in supine lying. So in stage 7, we give something called as functional training. In that, the first one is called as BRIM. BRIM is brief resisted isometric exercise regime. Once that is done at a 90 degree, 30 degree, and 120 degree, we progress to multiple angle isometric exercise and functional training as well. Then graded motor imagery, what we use it for, especially sensory reeducation, especially after 5 years or 4 years after surgery, especially for neuropathic pain. So it has 3 components. One is implicit motor imagery, then explicit motor imagery, and third one is mirror therapy. In implicit motor imagery, it is mainly right to left discrimination, and explicit motor imagery is the patient should imagine the movement, but you should not do it. In the third one, we need to do mirror therapy. So mirror therapy, if you do, the affected hand should be inside the mirror box, and we give instruction that you move your affected side. So this mirror neurons activate. This has a indirectly can bring down the pain. It also improves the sensation as well in the affected side. And I do this only on Sundays. So remaining 6 days, we concentrate more on motor reeducation. Sunday, we concentrate more on sensory reeducation. Now we come to the second part, what we do for neurolysis and nerve graft. So first is passive movements, electrical stimulation, roots approach. So if the nerve is intact, if you do roots approach, brushing should be done first, then quick icing, then vibration, then tapping. If you do, you get earlier recovery. Then if you see this picture, electrical stimulation, when Faraday currents is given in the starting phase of denervation and the later phase of regeneration. Galvanic currents are given in the later phase of degeneration and earlier part of regeneration. So you have to do this stimulation based on getting your chronaxy. So we need to plot a SD curve to get the chronaxy. So based on that, we select whether to give Faradic or galvanic. So progression is motor education and sensory education. This is how we do progression. I have published this article as well. It is available in the internet. So from grade 0 to 1, grade 1, 1 to 2. So like that, once we reach grade 5, we move on to progressive resisted exercise. So this and all we use for gravity assisted. First one, if you see, there is a tilt, so which will help in grade 1 to 2 or grade 2 to 3. We can use a re-education board, or we can use the powder board for just for grade 2. Now, this is the protocol for nerve transfer. I tell DAFRA to be done daily 2 times, 6 days except Sunday. Injection technique hourly 30 times. Electrical stimulation 6 days, Sunday is rest. Initially twice daily, later once. Mirror therapy only on Sunday. After getting grade 3. Passive movements should be done daily. Then they come for my consultation once in 3 months or 6 months. And I have found that more supervise the patient, better the result is. And sensory reeducation, I start only after grade 3, and I give on Sundays. And now I am more into publication. So what I observed, these are the variables we use for publication. Especially the 2-3 articles have come with a CMAP ratio. So we need to take the unaffected side CMAP, and the affected side take the ratio, and subtract this from your pre-score. That is your score for each patient. Take the data, we can go for research. Right now I'm collecting the NCS of all patients. The second one is neurotization time. Elapsed time in days by anticipated day. If this value is less than 100, there is good recovery. If this value is above 250, there is no chance of improvement with physiotherapy. And physiotherapists will do SD curve routinely to find out which duration to be given for the patient, or whether Faradic or galvanic to be given. So finally, at present, this patient, the first patient is after 4 years, the second patient is after 3 years with Wang's procedure. Thank you.
Thank you, Subin. That's an excellent talk, actually. first time I'm just listening to someone who really understands the pathology of plexus injuries. Actually, I think that's what you need to do. You should understand about what you are supposed to do for that patient. What has been done by us. Only when we communicate, we learn what to do more. That's why we get such excellent results in these patients. Any questions, sir? Yes, sir.
I just wanted to congratulate you on your excellent work, and I learned quite a few points today, new points. Thank you, and it's a blessing to have a physiotherapist like you for brachial plexus rehabilitation. Thank you.
Thank you, sir.
Yeah, your techniques are totally different from what we see. I think we have to go back.
These results are good, sir.
Yeah.
Already it has come.
Yeah.
What DAFRA is telling, it's 8 years, but we get just half of it. Within 4 years, we are getting for full wangs,
Yeah.
and C5 is just 8 months.
Yeah. And one more thing which we have started doing now is we also now stimulate the coaptation of the contralateral C7 with the nerve graft in the opposite side neck. That also we give some nerve stimulation. So that's supposed to improve the nerve growth.
So but that said, if you give, it will be purely Faraday current.
Yes.
And the Faraday current studies have shown that it has a negative effect.
Is it?
Unless and
But
until.
there are a lot of now papers which are coming.
So you have to just find out the duration. Any duration less than 10 milliseconds is not advisable.
Okay.
You can give it 100 milliseconds.
Yeah, but I don't, it's a very recent thing which has been added on. We are just trying it. We don't have any data to say that it is, but it is something which has come out. And phrenic is not a good nerve in terms of a donor. Please, because a lot of phrenic has been going on. People think phrenic is a good nerve and with good finger flexion. Unfortunately, phrenic will never have a voluntary control. And it will always keep moving every time you take a breath. And it is very socially, it doesn't look nice at all whenever you are sitting in some table and your hand keeps moving with every breath. So phrenic as a donor is a no-no. And the morbidity which we cause in terms of the respiration is huge when we take phrenic. So usually better to avoid.
Thank you, Subin, for the very passionate talk about the physiotherapy aspects.
Thank you, sir. I also thank Dr. Pradeep and Dr. Gigi for chairing the session.
For the next session, I invite Dr. Mohanan, Dr. Jacob to chair the session. The speaker is Dr. Raja Tiwari, Associate Professor, Department of Plastic Surgery, AIIMS, Delhi. And the topic of the session, limb amputation, replantation techniques and challenges.
Good afternoon once again, and thank you organizers for inviting me for this presentation. So in my talk, I will be covering the proximal upper limb replantations, which means the replantations at the level of the arm, forearm, up to the wrist crease, and all the implantations distal to it are called the distal replantations, which will be covered by Dr. Joshi. So replantation has been defined as the surgical reattachment of a body part, most commonly a finger, the hand or arm, which has been completely cut from a person's body. If we look at the history of replantation, there are many tales of replantation as old as the time of the Christ. However, most of such instances have been either due to partial amputations or just reattachment of a body part which did not survive later on. The first instance of the concept of replantation was given by Abbey, who divided all the tissues of a canine forelimb except the brachial artery and the vein. And he reattached the tissues and it survived. So this gave us a concept that if the vessels are repaired, then the limb has a potential to survive. Later on, Carroll, when he pioneered the techniques for re-anastomosis or anastomosis of the artery and the veins, he showed the world that the replantation of a canine hind limb was possible, and he received a Nobel Prize also for it. Later on, Molt performed the first amputated arm replant in 1964, and later Komatsu and Tamai did finger replantations in 1968. So replantations have been happening for quite a long time in history. The most common causes of amputation in our setup are the agricultural machines. So whenever there is the harvest season, various machines are used, the threshers and other machines. So within these machines, the hands are caught and they are amputated. Sometimes within the conveyor belts or sometimes within the blades of the machine itself. The second most common cause are the industrial accident and the households, and then these are followed by the traffic accidents. And something to note is that most of the population which is affected are the active young males who get most of these injuries by who are working on these different scenarios. So as soon as the patient comes to us, there are a few couple of things that we should remember. So number one is the triage. So being in the with the adventure of the replantation surgery, we should not forget that the other body parts or systems can also be injured. So we have to pay a good attention to exclude any other injuries which might be present in addition to an amputated body part, especially in the road traffic accidents. So as soon as the patient is received, in the slide shows the setup in our department itself. So within 15 minutes, the patient is taken up, given a registration, and the optimization is started. And within 30 minutes, the part which has been amputated is delivered to the operation theatre so that an initial look can be taken up by a plastic surgeon, and it can be decided whether the part is even feasible for a replantation surgery. Simultaneously, the patient is subjected to blood investigations, x-rays, etc. to come to a conclusion if it can be decided, and then a decision making takes place with simultaneous transfer of the patient in the operation theatre if we seem that the replantation can be performed, and then the operation is done. So the decision making alone involves several factors which we have to keep in mind. Now, number one is the polytrauma, like I mentioned, because there can be head injuries, cervical spinal injuries, other abdomen and thorax injuries which need to be taken care. And if these are significant injuries which may even cause life, threaten the life, so these have to be excluded first before taking up the patient for replantation. And the second one is the cold ischemia time. So as we all know, in proximal replantation, it is very important that the part is taken up for replantation quickly or within a period of maximum 8 hours. If you take up the part for replantation after 8 hours, then it means that there would be formation of free radicals when we revascularize the part, and there would be higher chances of multi-organ failure. So this is an important thing which we should keep in mind. Then there are multi-segmental injuries, which means that there are injury at 2 or more levels. So in such cases also, it sometimes becomes difficult to technically perform a replantation surgery. And secondly, especially the proximal replant, the time duration increases during the surgery if multiple segments are involved. And therefore, a careful decision has to be taken whether we want to go for a replant or not. And also, we have to consider the mangled or the severe crush injury to the part which is taken for replantation. There is a score called as the mangled extremity severity score. So we do it for all the patients, and if the score is less than 7, it means that we can take up the patient for a replantation surgery. Whereas if it is more than 7, it does not exclude the patient for replantation. Rather than it means that the patient has suffered a severe injury. And lastly, we have to do a thorough patient's attendance counseling, that what are the potential pros and cons or the risks involved with the surgery. So once we have taken or made a decision to replant a part, we have transferred the part which has been amputated quickly through the operation theatre, where a thorough cleaning is taken, and all the necrotic tissues and even avulsed muscles are debrided, and all the parts are tagged. The next step is when the patient is shifted to the operation theatre, a thorough debridement has to be performed. So in this case, you can see the bone has been shortened to accommodate amputation and also to remove the devascularized part of the bone. The necrotic muscles have been removed, and the long nerves which were avulsed, these are not discarded. Rather than they function as channels through which the new neurons can grow. So these nerves can be used as a non-vascularized nerve grafts also, and can be reattached to the distal part. Then we follow an operative sequence. So if the patient comes early within the period of ischemia, and if we are confident that we would be able to vascularize the part within the period of ischemia, which is 8 hours for the proximal replant, then we follow this sequence. So we do the bony fixation or the we establish a stable fixation for the bony structures. Then muscles and tendons are repaired, followed by the arteries to re-establish blood flow, the veins to take care of the venous return, then the nerves, followed by skin, and if some skin is missing, then we perform a flap or a skin graft. In some cases where the cases have already delayed, or they have reached us after, say, 4 or 5 hours with a long duration of cold ischemia time. So in these cases, we perform something called as a temporary arteriovenous shunts. So what this is done to prevent further ischemia which is happening in the distal part. And so in these cases, we do not perform the muscle and bone repair first. What we do is we put heparinized solution in the recipient artery first, wash the limb with the heparinized saline. Once we have a clear outflow from the veins, then we put a temporary AV shunt. So we use blood transfusion tubings for this. We connect the proximal and the distal artery, then allow the veins to bleed. So veins are allowed to bleed for 5 minutes so that all the free radicals are washed off. And after 5 minutes, a venous shunt is also placed, and all the distal veins are clipped. So now the part is revascularized, although not completely connected, but it is revascularized. So the ischemic injury may not take place further. Next, we do the stable bony fixation, followed by muscle and tendon repair, and then a formal arterial repair of the second artery, most commonly in the forearm, and the same brachial artery in the arm is done. And then all the other veins which were left or clipped before are connected, and lastly the venous shunt is removed and the vein is also connected. After the revascularization is complete, then the muscles and tendon units are repaired. There is a slight difference in repairing isolated injury vis-a-vis compared to a repair in a replantation setting. So for the muscle, muscles are mostly unipennate in the forearm and the arm region. So a simple suture repair may not help. So these 3 techniques, the figure of 8, Mason Allen, and the perimeter stitching is useful for repairing the muscles. And especially the one which is most useful is the figure of 8 technique, because with this, the muscle can take up more tension, and the amount of tension gapping which can occur is less. The perimeter is also a good technique. However, the central core of the muscle may not completely be united. Similarly, we have seen that the 4-core repair is a good repair for tendon. However, considering there are more than 19-20 tendons in the forearm on both the sides, so if multiple tendon repair has to be done, and we have to be a little quicker. So in our cases, we contemplate doing a 2-core core suture repair followed by a peritendon suture repair. For the nerve gaps, a simple epineural suturing is followed after orientation of the nerve fascicles. And like I said, that the long proximal avals or distally aval segments of nerve may not be discarded. These can be used as channels to connect the proximal and the distal part. And another advantage of this is that if the nerve function is not proper, or if the tendinal sign is not progressing, still we have tagged the proximal and the distal ends. So in the post-operative period or in the later secondary stage, the ends are easily found on exploration. With the hand replant, there are some special considerations that we cannot shorten the bone to a great extent in the hand or the proximal stump. So in these cases, we resort to doing a proximal row carpectomy, which is removing the proximal row of the carpus. And this shortens the length, which allows us to do a primary anastomosis and nerve repair. Also, in cases which have a long period of revascularization, we all advise the fish-shot piece to be done in the distal part, and this is done to relieve the tension. So what happens as soon as the blood flow is re-established, there is formation of acidic components and free radicals in the distal limb, which results into muscle edema. And if the compartment is tight, the muscle can undergo ischemia and will later on atrophy. Splintage is very important, and this is given along with the elevation. So most cases of arm and forearm amputations will receive an above elbow splint. We tie up a string to the distal end of the splint itself so that it can be easily hanged on a fluid carrier. Then the splint is a dorsal blocking splint with the wrist in neutral position and the elbow in 10 degree of flexion. And passive finger mobilization is started as soon as the patient is pain-free. Post-operative monitoring is done mostly in the limbs by SpO2 alone, as it is non-invasive, and capillary refill time monitoring. So in secondly, you can see that the part is compressed and the blood flow is re-established within 1 to 2 seconds. If it is found to be brisk, that it means that there is some venous problem. And on the second video, you can see after pricking, bright, fresh blood comes out from the finger. I think some part of the slide is getting cut. So these were the 3 techniques by which we monitored the circulation post-operatively. RBS monitoring was also a good modality. So if it is found to be less than 60, it definitely means that there's some problem with the venous return. For the artery and the veins to function, or the anastomosis to function, it is important to take care of anticoagulation. So in all clean-cut injuries, we do not use anticoagulation. However, in all injuries with some amount of crush or aversion element involved, we use heparin, plain heparin, in a dose of 200 units per kilogram over 24 hours to keep the PTT between 60 to 75 seconds. And this is gradually tapered after 7 days. Physical therapy, I think we have already had a good session about physical therapy, and the same applies to replants also. So to prevent the contractures and to maintain the range of motions of the replanted extremity, we quickly start passive physiotherapy and mobilization. We also use galvanic stimulation for the distal muscles in the forearm or the arm to prevent their atrophy. And lastly, since the patient is not ambulatory for a significant period of time, we have to take care of the other muscles of the body also, so that they do not undergo any atrophy or weakness. Now with all this information in mind, I will discuss some interesting cases with you, different scenarios which were challenging for us. So number 1 was the polytrauma cases. So this was a 4-year-old child who had a femur fracture, cervical spinal injury, and a proximal replant. So in such situations, the majority of the times is that the amputated part is, the stump is closed, and the other injuries take a precedence over the management. However, because we were happy that our team of neurosurgeons and the orthopedicians were convinced that they can manage the other injuries simultaneously. So the child was, the neck fracture was stabilized, the femur was fixed with a splint, and then we were able to do a replantation in this small child. And the replantation was successful, and we were able to save this extremity. Then there are multi-segmental injuries. So in such cases, we have to get a CT angiogram done. So this patient also had a proximal thrombus, not an injury of the brachial artery, but there was a proximal thrombus. So first the proximal thrombus was evacuated using the, and then the repair was done distally to replant the arm. We usually use the Fogarty's catheters to remove the proximal thrombuses. And later, this is after the fasciotomy, so all the fasciotomy sites were covered with a skin graft, and we also ended up doing a LD flap to cover the proximal area of the repair also. Then in some situations, there can be skin defects after arm replant, and the most common area where this occurs is at the cubital fossa. So this was again a 35-year-old female who underwent a road traffic accident, and there was a supracondylar amputation. So the brachial artery, the venae comitants, and the median ulnar nerves were exposed. So most of the cases of proximal replant especially can be covered with various designs of pedicle latissimus dorsi flaps. So in this case also, you can see that the patient was turned, a latissimus dorsi flap was harvested, and it was used to cover the exposed neurovascular structure site. The flap settled well, and the patient was able to get a good range of motion in the arm and the hand. Next, we have the skin defects after hand replants. Again, a 7-year-old boy who met with a machine cut injury, and he had some the necrosis of the dorsal skin flap. So hand is, in particular, there are many locoregional flaps which can be done, but we prefer to use the groin flap, not a free one, but a pedicle groin flap, because we have already done a significant amount of repairs in the hand, and therefore we do a pedicle flap so that we do not need to require more anastomosis in the same part, and the patient regained good function. Then periods of prolonged ischemia, I think this is a judicious decision. Sometimes the patient is a very active member of the society, and they tend to accept the risks which is associated with the prolonged ischemia. So some of the cases, electively, after explaining the risk, we can take up a call to replant them. So this cases was replanted after 10 hours of cold ischemia. There was a serious severe crush amputation at the mid-arm level, and the warm ischemia time was around 2 hours, cold ischemia was 10 hours. we ended up doing a replantation, and the hand and the forearm and the hand survived. However, you can see that there was patchy necrosis of the muscles, and this mostly occurs because the peripheral part of the muscle sometimes does not get fully vascularized. And there are avulsion injuries such as this one, and you can see that there has been significant avulsion of the hand. So the muscle valleys have been avulsed, leaving the bone behind. So in such cases also we can attempt the replantation, and post-replantation good blood flow could be re-established. Another set of challenging cases involve the elbow amputations. So in this case you can see that not only the forearm but also the proximal the elbow joint has been completely disrupted. Now with an unstable elbow joint, it is very difficult to achieve any fruitful movements which is good for the patient. So in such cases we recommend doing a hand to elbow replantation. So in this case you can see the short segment of the distal bones has been replanted directly with the humerus, and then the biceps and the triceps muscles has been used to take up the function of the flexor and the extensor tendons of the hand. And later on you can see that the patient, although the extremity was shortened, but patient was able to perform significantly good functions with that, using that hand. And finally you can do the total loss of forearm. So in these cases, although the elbow is good, but the forearm has been entirely crushed under a pressing machine. So the hand is separate and the entire forearm is crushed. So one thought is to do again a hand to elbow replantation, but it significantly shortens the upper extremity length. So to preserve this length, we have to completely reconstruct the forearm. So in this particular case, what we did was we implanted the hand onto the foot, and then we performed the elbow reconstruction as a 3-staged surgery. So in the first stage, the ectopic hand was implanted onto the foot along with the preparation of the stump. In the second stage, you can see this forearm has been reconstructed, and this was done using 2 composite flaps. One was the free fibula osteomyocutaneous flap, and then the second one was the ALT with vastus lateralis muscle flap. So with both these units, we combined together to form the forearm, and then in the third stage, we harvested the hand again and put it onto the reconstructed forearm. And as you can see, after the reconstruction, the patient was able to do many activities for his daily living. Even using the hand to grip several objects with a short grip was also possible. And he was able to even manage writing with the same hand after stabilizing the finger and the thumb. And the donor sites are all good, so you can see that wherever all the donor sites that we have used, there was no possible complications. So to conclude, advances in the microsurgical equipment coupled with surgical ingenuity have allowed replantations of increasingly complex amputations, and microsurgery has been and continues to be superior to all other forms of surgical or prosthetic modalities of treatment. With this, I will say thank you to all of you for patiently listening.
Thank you, Dr. Tiwari, and congratulate you for that wonderful results of proximal amputations. I think the topic is open for discussion. There will be a lot of questions to you. You have mentioned somewhere in the, you are creating a proximal amputations, an AV fistula is created in this. When do you disconnect it, or you allow it to continue like that?
I didn't get your point, sir.
You have pointed out that in proximal amputation you make AV shunts, and you are disconnecting it and then you using the repair.
So the idea is to reduce the period of ischemia of the limb if it is received late. So the artificial shunts are done, the extremity is revascularized. If it is a forearm, then we have 2 arteries. So if we have done the shunt on the radial artery, then we'll do the ulnar artery first. Then we will remove the shunt and repair the ulnar artery. If it is the brachial artery, then there's only 1 artery. So we have to remove the shunt and do the artery again using a vein graft, and then do the rest. So the shunt is only temporary. It is not kept within the replanted limb.
Thank you. If there are no questions, we will move on to the next topic. Thank you, Dr. Tiwari, once again.
Thank you so much.
Thank you, sir. Now I request Dr. Mohanan and Dr. Jacob to please come out to the dais and hand over the memento. To receive the memento, I invite Dr. Raja Tiwari, Dr. Sabari Girish Ambat, Dr. Anil Raj R, Dr. SUSHRUTHA Babu, Mr. Subin Solomon, Thank you, sir. For the next session, I welcome Dr. G. Karthikeyan, Professor and HOD, Tamil Nadu Government Multi-Super Speciality Hospital, Chennai. The topic of the session, Management of Mallet Finger and Management of Botany Deformity.
Good afternoon and vanakkam. I have come to the mallet that I promised you in the morning. So you can't escape the mallet finger. It's a very common injury. We'll come across this injury quite often. Now the mallet finger is characterized by persistent flexion of the distal phalanx due to a lesion of the extensor apparatus at the level of the distal interphalangeal joint. Now we need to remember here that the flat terminal extensor tendon inserts on the base of the terminal phalanx. We all know that. The excursion of this tendon is only 4 millimeters. So, if you have a scar over there which is about 1 millimeter, there will be a 25-degree extension lag. And if there is a lengthening of the scar by 0.5 millimeter, you will have a 10-degree extension lag. So that is why we get such poor results after treating mallet finger. We always say this is, you give them a splint, you do surgery, whatever, there will be a slight flexion over there. Some very fussy patients will say, doctor, it's still not come straight. See, this is the reason. Even if there's a scar of 1 millimeter, this is what happens. So here, the importance of the transverse retinacular ligament and the oblique retinacular ligament. Now this ligament actually runs. Is there a pointer? See, you can see here, from the insertion on the tendon, it runs like this and gets inserted into the fibrous flexor sheath. So it is something like a shortcut. It bypasses the extensor, the PIP joint. So when you flex the PIP joint on your own finger, you will find that you can't extend your DIP joint. That is because the retinacular ligament has become lax. So you cannot extend your distal interphalangeal joint. So mallet finger can present as an open injury, as a closed injury or an open injury. We need to understand the classification of when you get a mallet finger, first you have to classify it so that you can manage it correctly. Type 1 is a closed injury with a tendon avulsion with or without a fracture. This is a type 1. That is what you can see in that picture. Type 2 is a closed injury which has got a laceration. So there is no fracture inside. Type 3 is an open injury. This is also quite common, where you have a tendon abrasion. You may have a skin loss or a tendon loss. Usually it's only a tendon injury and a skin laceration. And type 4 is a tendon injury with a significant bone fragment. So big avulsion of a base of the terminal phalanx. Now, type 4 has been classified again by Dameron and Egbert into 3 types. Type 4A is physeal injuries. I think you know about the physeal injury where you get a mallet finger. Have you heard of that? Have you heard of the Seymour fracture? That is a type 4A. 4B is where the fracture is 20 to 50% of the fracture surface, and if the fracture is more than 50% or with volar subluxation, it is a type 4C. As in this example, this is a type 4C because there is a volar subluxation and the bony segment is more than 50% of the articular surface. So what is the treatment protocol? In type 1, it is only splinting. In type 2, it is splinting. You may require surgical management if the splinting does not work or if the patient has presented late. In type 3, it is surgery alone, and in type 4, it is surgery alone. So the treatment I was telling you in the morning about how you can do a non-operative management of an extensor tendon injury. So non-surgical management is keeping the distal interphalangeal joint in slight hyperextension. So what happens when you keep it in hyperextension? There is a fibrous tissue of the resulting scar. So this can restore extension, of course, with a small lag. So to achieve this, you use splints. So immobilization of the distal interphalangeal joint in extension, but it is very important here to spare the proximal interphalangeal joint. Never give a total straightening splint instead of a mallet. Why this, we will see soon. And most important part of the conservative management is patient compliance. You're going to look at the patient, tell the patient, wear the splint 24 hours, 24/7. It all depends on whether he is going to wear it or not. So this is the splint that is applied. You've got different types of splints. And in open injuries also you will be using the splint, of course, as an adjunctive management. So this is the Graham stack splint. Now the usual mallet splint that I showed you is a 2-point stabilization, whereas this Graham stack splint is a 3-point support. As you can see, there is one support from the dorsum over the distal interphalangeal joint. And thirdly, for children, these splints have to be applied for 6 weeks and night splinting for another 2 weeks. If the patient has inadvertently flexed, you teach the patient to take off the, some patients are so diligent, they wear it completely, they come after 1 week with a maceration of the skin and sometimes even ulceration. So we need to tell them to take it off every day, wash it, make sure they don't flex the finger while doing so. If there is inadvertent flexion of the finger and patient tells you, doctor, I used the finger, I had to do it, then you have to start all over again for 6 plus 2 weeks. For children, they may not be able to wear the splint. So there is a technique described by Smiley, who said you can put a cast on the finger where the PIP joint in 60 degrees of flexion and distal interphalangeal joint in slight hyperextension for 4 to 6 weeks. Now the complications of splinting, most of them are short-term complications. As I told you, skin maceration, ulceration, allergy to the skin tape, and a persistent extensor lag. This is after the removal of the splint. Surgical management is ideal for open injuries, obviously, and also in some cases of closed injuries. Now, in open injuries, you can see that the tendon has been cut. So what do? You can suture the skin alone and then continue with conservative management with a mallet finger splint. Or you can put in a suture that incorporates both the skin and the tendon and suture it together. This is also a described technique. But it is important to put in a wire, K-wire, through the distal interphalangeal joint because the flexors are very powerful and your tendon suturing will not hold against it. So, in closed injuries, what is the indication for surgical management? If it is a very small fragment, indirect reduction by external block fixation, external block pin fixation or doorstop osteosynthesis. This is important. Now, if a patient says, doctor, I do not want to wear the splint, I cannot wear a splint, please do some surgical, you are saying the splint has to be worn for 8 weeks and all that, I cannot do that. So we can try this doorstop osteosynthesis provided this bony fragment is small. Here what happens, the first step is flex the distal interphalangeal joint maximally, almost 90 degrees, and pass in a wire. This, when you do this, what happens? That bony segment along with the extensor tendon is stuck there now. It cannot run back. So you are putting a doorstop over there. Next is, as I said, pass in a 1 mm K wire advanced into the middle phalanx, dorsal to the oval segment at a 45-degree angle. You can understand this picture. So this creates an extension block. Then what you do is you put in a wire through the terminal phalanx and use it as a joystick to lift it up, and then you can, all this is done under image intensification. Now when you lift it up at one point, because that bone cannot run back, so this bone will go and come and stick close to that bone, so you have reduced the fracture, drive the wire into the distal interphalangeal joint. So this is again, you have to be applied for 6 weeks, but the results are much more predictable. If conservative management fails and the fragment size is more than 30% of the joint surface, you need open surgical management. We saw a technique of closed percutaneous pin management. This is an open surgical management. If the avulsed fragment is 30 to 50%, you can do one of two techniques. One is a pull-out suture or the anchor suture. You might have seen anchor sutures where you just put a screw into that bone. There are two suture ends with 2 needles. You suture it to the tendon. And if the avulsed segment is more than 50%, you can do a percutaneous pinning or an open reduction internal fixation with screws. So, avulsion of tendon insertion with bone fragment can be with bone fragment, without bone fragment, and the diagnosis can be made with an X-ray if possible, or with an ultrasound. So, then you have a patient with an avulsion of a tendon without any bony segment. There is a very common tendency to just suture it to the periosteum that is there. This will definitely not work. So, you can do one of two techniques, as I told you, pull-out suture described by Doyle or the anchor sutures. Now the pull-out suture of Doyle, actually it has a, I'll just show you the surgical procedure, the steps of the surgical procedure. It is very difficult to make a hand function, and it's even more difficult to make a video of a hand function. Yes, will it work? Yes, it works. Right, you can see the mallet finger there. So now what we need to do is, we have made an incision there. That is the extensor tendon, right? Now we need to attach it back to the terminal phalanx base. How are we going to do it? First you take a stitch through this extensor tendon and keep it ready. This has got 2 needles, it's a 2 needle suture. Now pass a drill hole longitudinally through the terminal phalanx. Not one drill hole, 2 drill holes parallel to each other exiting on the tip of the finger. Thread this prolene stitch through that and then suture it over a button. This button that I have used is nothing but the wings of the butterfly scalp paint set that you get. You just cut out one of the wings like a round and use that. And of course you need to stabilize the joint with a straight K wire. So the complications of this sort of management, this of course will be continued for 6 weeks. For after 6 weeks you take it off, give a night splint for 2 weeks and start active mobilization. So complications could be starting from deep infection to joint incongruity, and finally it doesn't work or there is a little extensor lag that still presents. Splinting must be done for 8 weeks. If surgical management, you can remove the K wire at 3 weeks. But you need to continue to wear a mallet splint for another 3 weeks. So after 8 weeks, you're going to start gentle active flexion. First week, it's going to be active extension and active flexion. Second week, it will be flexion up to 35 degrees if there is no extensor lag. So the evaluation, very important to evaluate what has happened, whether it has worked or not. If there is full flexion of the joint and full extension, it is excellent. But it is very difficult to get this. It is considered good if you have 10 degrees or less of extension lag and up to 20 degrees of flexion lost. But it is always important to note that you should avoid losing flexion. So this flexion is sometimes lost, as I told you, because this suturing may be too tight. It is always, we will always be able to get back the flexion of the distal interphalangeal joint if you start, 1, active mobilization at 6 weeks, and 2, after 8 weeks, you can even start passive mobilization so that the scar can sort of give way. But if you're doing that, if by 6 weeks you have not achieved full flexion, you're going to have a problem because the extensor is still not healed. If you start passive mobilization, you have a chance of losing your good results in extension. So, to conclude, most mallet injuries can be treated with splinting alone. Surgery offers no great advantage over non-operative treatment, but there are some indications for surgery, like patient is not willing to wear a splint or the compliance of the patient is under question. And thirdly, whenever possible, close treatment should be attempted before you go in for a surgical management. In open repair, careful rehabilitation is necessary to optimize final motion. Thank you.
Thank you for Professor G. Karthikeyan for your excellent talk, as he has covered all aspects of it, and I would congratulate you for that. Any doubts to be cleared? As told by Professor, it's an injury with a lot of complications. Most of us are in our series, we have fair results. And as Sir has emphasized, the splinting should be continued for at least 6 weeks. And in open injury, always it is better to transfix the joint with a K-wire. And in avulsion injuries, percutaneous fixation is giving very good results. Thank you.
And just one more word of caution. Sometimes the bone fragment that you see on X-ray looks very nice. You say we can go in and fix that fracture. Usually it is not very easy. It's not very easy. Even if you have an image intensifier, it's quite difficult because that bone fragment is so small actually. On X-ray it looks quite large, but it is quite small. So we need to be very careful. If it is possible, always err on the side of conservative management rather than the operative management as far as a mallet finger. Thank you.
Sir, what about chronic mallet fingers?
Yes, I have not covered that. Chronic mallet finger, up to almost 6 months, patient is presenting 6 months after sustaining the injury. He has a mallet finger now. We need to assess whether we have to go for an operative management or a conservative management. If the extensor lag is less than 35 degrees, it is better to go in for a conservative management. What happens in chronic mallet finger is that they start going in for a swan neck deformity. So that goes into the next topic of swan neck deformity, of course. But swan neck deformity is pretty difficult to treat because once it goes in for a chronic mallet, I did not mention that point. Why I said you have to leave the PIP joint. It is very important so that the transverse retinacular ligament is kept nice and lax. If you're going to let it stay like that, like you get in chronic mallet, you will go for a contracture of the retinacular ligament. So it is better to, even chronic mallet, if the extensor lag is less than 35 degrees, conservative management with splint alone. If it doesn't work, you can go in for a fixation like I showed you, pull through suture. If it is more than 35 degrees, straight away you can go in for an operative management. Right, we'll go straight away into the boutonniere deformity. We'll talk about the introduction, the pathoanatomy, the etiology, clinical findings and staging, and management. Now, we need to remember that the boutonniere deformity is a flexion at the proximal interphalangeal joint and hyperextension at the distal interphalangeal joint. Only flexion at the proximal interphalangeal joint does not classify as a boutonniere deformity. Now the word boutonniere derives from the French word for buttonhole flower. You know, there is in the lapel they place a flower, that hole, it's called the boutonniere. So it's like this. So like on exploration, if you look at this, there is a small rent in that central slip over there. So that is what looks like a buttonhole. So it's called a boutonniere. Now, one important point, the difference between swan neck deformity and boutonniere deformity according to the pathology. The boutonniere deformity is caused by a problem in the proximal interphalangeal joint, that is, an injury to the central slip. Whereas, a swan neck deformity can be caused by a problem in the distal interphalangeal joint, in the proximal interphalangeal joint, and in the metacarpophalangeal joints. So please remember, the swan neck deformity can be caused by so many problems. Boutonniere deformity is caused only by one problem, the injury to the central slip. So what happens when there is an injury to the central slip at the level of the PIP joint? These are the lateral bands and these are the retinacular ligaments. Now these play a very important role over here. So when there is an injury to the central slip, the PIP joint naturally goes into flexion. So now all the power of the extensor is not able to go through the central slip, so all the power goes through the lateral bands. So all the power ends up in the distal interphalangeal joint. So there is a hyperaction over there, so there is a hyperextension at the distal interphalangeal joint. So there is a, as I said, distal interphalangeal joint hyperextension. Because of this hyperextension at the distal interphalangeal joint and because of the flexion at the proximal interphalangeal joint, this is exactly the opposite of the normal stretched retinacular ligaments. So now it has become shortened, so here it will become contracted. So when it becomes contracted, it pulls the lateral bands volar to the axis of the PIP joint. So this leads to the characteristic boutonniere deformity. When comparing between swan neck and boutonniere deformity, which is the better deformity to have? The more debilitating deformity is the swan neck deformity because they can't do any work. Whereas the boutonniere deformity is a very good deformity because the PIP joint is kept in flexion, so they'll be able to carry out most of their work except the precision work. So this central slip injury can be caused by trauma, it can be caused in burns, and it can also be caused in rheumatoid arthritis. But the pathology is only affecting one particular structure, the central slip. Now, clinical staging, clinical findings, we know the characteristic deformity. And you need to check the passive range of movements at the PIP and DIP joints. But this is in a complete injury to the central slip. What happens where there is an occult injury to the central slip? How do we identify whether the central slip is injured? So there are certain tests that we can do. The Elson test, the Boy's test, and the Haynes-Zancoli. 3 important tests to test when you have a suspected boutonniere or an injury to the central slip. Now, in the Elson test, you ask the patient to keep the PIP joint over the edge of the table, and then you ask the patient to extend the PIP joint. If he is able to do it, the central slip is intact. Second, when he is starting to extend it, feel the DIP joint. Is it flail? It should be flail if the central slip is intact. When he is attempting to extend it, if the DIP joint is also tight, that means there is an injury to the central slip. Sorry. This is the second test. This is a very simple test. Just hold the PIP joint in extension, ask the patient to flex the DIP joint. If he is able to do it, good. He doesn't have a central slip injury. The Zancoli test. Now, he is not able to actively flex the DIP joint when you hold the PIP joint. So what you do now is passively try to flex the DIP joint. If you are not able to flex the DIP joint passively, it could be due to contracture of the joint, or it could be due to contracture of the transverse retinacular ligament. So to find out this, passively flex the PIP joint. Now see if you are able to flex the distal interphalangeal joint. This is something like the intrinsic test of Bunnell. This you are able to do. Now let us see how the boutonniere deformity is classified. The Burton's classification. In stage 1, it is a supple joint, passively correctable. In stage 2, it's a fixed contracture with contracted lateral bands. In stage 3, there is a fixed contracture, joint fibrosis, collateral ligament and palmar plate contractures. So even if you try to release the joint, it will not get released because your palmar plate is also contracted. And stage 4, there is arthritis of the PIP joint. So how do we manage it? Similarly, non-operative and operative. In non-operative management, in the acute stage, less than 4 weeks of stage, you can splint the proximal interphalangeal joint in extension. Again, I told you all extensor injuries distal to the metacarpophalangeal joint, immobilization for 6 weeks. So here, full extension for 6 weeks, and encourage DIP joint extension and flexion. So similar to what I had mentioned for mallet, the splint is applied only for the PIP joint, not for the entire finger. At the same time, the patient must be taught to passively flex and extend the distal interphalangeal joint. If he is able to passively flex, he can do it actively. And night splinting for 6 weeks more. Now, operative management. How do we manage a boutonniere finger? If supposing there is a central slip injury, it is very simple. You just have to go in and do a primary central band repair. Supposing the central slip has not been cut but has been avulsed, you can put the avulsed bone back just by a similar technique what I showed you, where you fix the extensor tendon in a mallet finger. So this is ideal for open wounds with central slip injury. But what about a chronic boutonniere deformity? Deformities of 30 degrees or less are quite difficult to improve with surgery. We need to realize this, and we need to tell the patient also. Before we go into the different types of management, there are Burton's 7 principles of boutonniere correction surgery. Because this is quite a specialized surgery, Burton has done a lot of work on this. There are 7 principles. First, he says it must be done by an experienced surgeon. Second, it is rarely indicated, surgery is rarely indicated if there is a supple deformity less than 30 degrees. Go ahead with only a splint. Third, even if the deformity is more than 30 degrees, do not think about surgery if the joints are not supple. Pre-op and post-operative exercise program is very important, and before you plan any surgical management, think of the option of PIP joint arthrodesis if there is any sign of arthritis. And do not jeopardize flexor function to gain extension. As I told you, boutonniere deformity is quite functional. So if you are going to compromise on flexion, it is going to be a negative effect for the patient. And lastly, procedures for surgical management of boutonniere are divided into 2 types. One, to decrease the tone at the, you know that there is a hyperextension at the DIP joint. So procedures to decrease the tone at the distal interphalangeal joint or increase the tone at the proximal interphalangeal joint. So now let us see the different operative managements. There are release of retinacular ligaments can be done, extensor tenolysis, distal tenotomy. This is an important procedure. All these are to reduce the tone at the distal interphalangeal joint. The next set of procedures, like the lateral band relocation, tendon reconstruction, and PIP arthrodesis, are done to increase the tone. These two, the 4th and 5th, are done to increase the tone at the PIP joint. So, release of retinacular, I told you if it is left for a long time, what happens is the retinacular ligaments get tight. So all you have to do is go in and divide those retinacular ligaments. Extensor tenolysis. when the retinacular ligaments get tight, the extensors proximally are also stuck. So you have to release them. So that is the next procedure of extensor tenolysis. And thirdly, the important procedure is distal tenotomy. Now this is something like creating a mallet finger. The terminal tendon is getting inserted into the base of the terminal phalanx. If you're going to do a tenotomy over here, what will happen is the distal phalange will flex. So this is like creating a mallet finger. But this is to improve the tone in the, because the deformity of the mallet finger can be corrected with a splint. So this will decrease the tone at the DIP joint, allowing DIP joint flexion. This distal tenotomy is of two types. You can have the dolphin or the Fowler. The Fowler is done a little more distally, and the dolphin tenotomy is a little more proximally. Then lateral band mobilization. Now if you just open up, I told you the two lateral bands have run on two sides of the PIP joint. All you have to do is lift up both these lateral bands and suture them together along with the central slip to increase the tone at the PIP joint. Tendon reconstruction. Now supposing you have gone in, you have found the lateral bands, you have brought them up, but you find that there is a gap in the central slip. How do we reconstruct it? Can you put a tendon graft? There are different methods of reconstructing this gap in the central slip. One is the Matev technique, where you use, all these techniques use a small tendon graft. That tendon graft is nothing but one of the lateral bands. Different techniques of using it, like the Matev, Haywood, and the Littler technique of reconstruction. And finally, PIP joint fusion, whenever there is evidence of arthritis in the PIP joint. Now, you will find that one single procedure may not answer the question. You may not get a good result. So Curtis has said you do a staged reconstruction. You keep doing one by one after the other, slowly improving. One, reduce the tone at the distal interphalangeal joint, then increase the tone at the proximal interphalangeal joint, so that ultimately you will have a functional finger. And all these procedures, you're going to put in a K-wire across the PIP joint, and at the same time you should leave the DIP joint free, allowing for active movements. So the salient points about the operative management of boutonniere: exhaust splint protocols before you go for surgical correction, ensure full PIP range of movement, and always remember 20% persistent extensor lag is quite common even after the best surgery. And flexor loss must be avoided at all cost. Thank you.
Thank you, Professor Karthikeyan. I think people will have doubts about that one. My question is, when there are multiple boutonniere deformities, are you going to correct them all in the same sittings, or you plan a staged procedure?
In multiple boutonniere deformities, are you referring to burns, sir?
No. Various situations.
Yeah.
Rheumatoid disease? Or?
Yes. In whatever disease, it is important, it is not possible to actually correct each finger at a time. We need to correct all of them at the same time, because our splinting, all that will be very difficult if one is going to be corrected and the others are continuing to be in a boutonniere deformity. So we need to, I have not come across a situation where I have had multiple fingers to be corrected. I have done one single finger alone reconstruction, but when it is all fingers, I feel it is better to do all the fingers at the same time.
This we commonly see in the rheumatoid patients.
Yes.
Probably.
You prevent a chronic boutonniere deformity rather than treating it. Basically, I feel all wounds on the, sharp wounds on the dorsum of the hand should be explored. And whenever a rheumatoid patient comes with some pain, it's better to take an ultrasound and rule out this condition earlier, so that you can prevent chronic boutonniere deformities. Whatever you do, the results are very bad after transfixing the joint with the PAP joint. Never you are not going to get a full flexion.
Exactly. So prevention, not only in rheumatoid, even in burns. In burns, even in the early stage, you will note the patient would have had a burns on the dorsum of the finger. The finger skin will be pink, and you can see that it becomes pale when the patient flexes the PIP joint. That is a cinch. It will go in for a boutonniere deformity later. If you correct it with a boutonniere correction splint, you can save the patient a lot of problems later. Prevention, as he said, is so important.
Thank you, sir.
Thank you very much.
Thank you, sir. I also thank Dr. Mohanan and Dr. Jacob for chairing the session.
For the next session, I invite Dr. Kurian, Dr. Pramod to chair the session. The speakers are Dr. Ramya Matthew, Consultant in Charge, Department of PMR, Rajagiri Hospital, Kochi, and Ms. Naismol PJ, Occupation Therapist, Department of PMR, Rajagiri Hospital, Kochi. The topic of the session, Post-Surgical Holistic Rehabilitation in Limb Trauma.
Respected sirs, dear friends, good afternoon all. So I would like to extend my heartfelt thanks for giving us an opportunity to present this topic here. I heartfully congratulate Team Allied Group, especially the plastic surgery team, for bringing very excellent results in especially the brachial plexus. Brachial plexus reconstruction surgery, actually, in rehabilitation, we know the challenges and the complications that we have, but it's well known that you people bring out very excellent results in PAN and other brachial plexus injuries. And with that, I just start my presentation. So I'll be presenting my topic just in 3 heads, like presenting a case scenario, some general rehabilitation concepts, and some recent advance points. So for this case scenario and the pics presented here, I extend my heartfelt thanks to Dr. Jijiraj sir. Actually, we work as a rehabilitation team after his surgery. So I extend my thanks to sir, and with his grace and permission, I present. So the case here is regarding a 11-year-old girl. She had a road traffic accident. It was an auto accident. She sustained a very major, severe crush injury to her right upper limb. And there was comminuted both bone forearm fracture, along with brachial artery injury, and there was a right knee injury. So this was the picture right after the initial debridement. And the median nerve was almost partially transected. The ulnar nerve and FCU was intact, but all the other flexor muscle groups was totally avulsed from the origin with severe crush, and there was absent blood supply. And the sensation was present only at the little finger. The brachial artery was fully contused, and there was both bone fracture, and the distal end of the radius was almost extending up near to the radial nerve and posterior interosseous nerve. So our excellent team, plastic surgery and orthopedics, came into the scene, and they did the procedure one with emergency exploration and debridement with open reduction and exfix. And the brachioradial bridging vein graft was also done along with the knee wound correction. And after the exfix fixation, and the limb is ready for flapping, and she was taken for the procedure with musculocutaneous ALT flap. And this was the flapping. And there was neurotization of the nerve to vastus lateralis with a cut branch of median nerve. So this was a summary of the case before us. It was a severe crush injury with open reduction with both bone plates and revascularization with GSV grafting and free musculocutaneous ALT flapping and the neurotization procedure. So this is the case. So whether she, the 11-year girl with all these trauma, she's a 6th standard student, whether she'll be able to go back to her studies. With this severe injury and to the right hand, whether she'll be able to perform her ADL, how much independent she will be. So what about her deformities and the severe pain that she is suffering after the surgical treatment? And she was a great artist. So what about the returning to her artistic skill? So that was the questions for rehabilitation. So now the hand is handed over to our hands for rehabilitation. So it will be mainly 2 headings that we will be dealing the case, like prevention of the deformity and improving the quality of the hand function. And the rehab pathway included mainly the catering the nerve injury and joint trauma, and of course the psychological support for the girl to go through this hectic process of rehabilitation. The challenges before was the great pain that she had at whenever we advise some exercises or advice regarding the splint, she'll be complaining that I am having pain here. So she will not be cooperating with the team's plan, and her limb was just like that without doing anything with that limb. And there was severe weakness because of the median nerve problem and sensory issues. And there was post-traumatic stiffness and features of myositis ossificans for the right elbow. So the CRPS features, the typical CRPS features of pain, the complex regional pain syndrome features was there with pain, swelling and limited range of movement. She was so depressed also because of this pain. And the non-pharmacological treatment of contrast bathing and pharmacological treatments including the GABA medications with nortriptyline combination was advised to her. And some psychological support also was started along with. And this non-pharmacological measures helped her a lot. This was given as a home program and taught mother. And the myositis ossificans features, which was when she was once presented to the OPD, there was severe warmth and swelling for the right elbow. In the blood test, there was great elevation of the serum alkaline phosphatase. We started on indomethacin, which is the COX-2 inhibitor. And the rest was advised and icing was given. And the aggressive physio for that joint was held for a while because of the pain and features of myositis. The NCS report in the subsequent weeks gave the idea of the right median function, that there was severe reduction in the CMAP and SNAP amplitudes. The compound muscle action potentials and the sensory nerve action potential was less. So we started catering these points in particular, and the team occupational therapy came into the scene right after this. So occupational therapist along with the physiotherapist and prosthetic and orthotic team, they will be concentrating on the functional aspect of the hand. So to bring hand function retraining, facilitating for the optimal use, her ADL should not be affected at any cost, and they will be a good companion for us in the decision of the orthotics in day-by-day visits in the OPD. And the exercises should be in a graded way, that it should not at any cost hinder the healing nervous tissue. So that was the challenge, and initially the isometric exercise will be started along with nerve glides, tendon glides, graded stretches, graded wrist movements. All this was bringing into the program in a graded way. The sensory re-education was so important because it was severely affected. Repeated sensory stimulation and adaptive relearning was started by the occupational therapy team. And the importance of this particular part of the rehab is mentioned in several literatures. And joint stiffness because of the adhesive capsulitis and the presenting inflammation was there till, and careful mobilization without hindering was also required for catering this joint stiffness. Graded range exercises and splintages was very much needed to cater this stiffness part. The ranges was actually the elbow was having a fixed flexion deformity by the time she presented, And the flap site was healthy and healing. The wrist was having limited ranges, and there was finger movement restriction, thumb movement restriction. All these were measured with goniometer and recorded each time when she presented to our OPD. So this was a girl, and while she presented, this was the extension possible to the elbow. There was almost a fixed flexion deformity. And the specific orthotic decision, that is a very crucial point in rehabilitation. Actually, the splint given to her was a serial static splint. And mother was taught how to change the settings of this, and as the extension improves, mother will give slight more extension, and the serial static splint helped in improving the fixed flexion part. And by the last time she presented to OPD, this was the extension that came to the elbow, which was measured with the goniometer, and the flexion range also showed improvement. And for the wrist part, we have to give the volar cock-up splint to prevent the finger flexion tightness, which was extending up to the finger length. And by the time last she visited, the ranges of the joints was almost normal, but the median nerve injury part was still there, which is currently we are working through. And this is the basic of that case scenario. So in general, when a hand trauma is coming to our rehab unit, we have to see it as a team. It is a teamwork as the surgery was done. So here, the rehabilitation specialist, she or he will be taking care of the medical aspect. And the physiotherapist, occupational therapist, and the prosthetic orthotist team, we work together to make the decisions in rehab plan. The medical aspects which we'll be watching for the infection and intact of the vascularity as the time goes. And the medications which will be helping will be GABA medications. And if the CRPS component is more and still it is not responding to oral medications, we can think about injection botulinum toxin marking the area. And we have to see whether there is disturbance of myositis ossificans. And the role of the doctor will be to coordinate the entire rehab team. And the team physio will be deciding. We got a very good presentation, an excellent presentation from physio regarding the post-trauma management. So they will be deciding on whether it is a galvanic current or a Faraday current, how much should be the frequency, amplitude, what to be given for the pain control measures like TENS or UST, and the gradation of exercise, which is the most important part of the rehab. Our excellent team physio will be deciding on. And Team OT will be concentrating on the functionality, sensory re-education, ADL training, and in this particular case, it is her right hand that was affected. So she is a 6th standard student who was about to go for the exam. So Team OT trained her left hand, and the hand function got better. And with that writing skill, she could complete her annual exam in the March. And now, without any sem break or year break, she is now going to the next year. And Team OT is also helping in the customization of the orthotics. So the prosthetic and orthotic team is really important, and they do come to the evaluation when patient comes to our OPD for customization and deciding on the material of the splint making, and also revision of the splints if it is needed, and also adaptive devices to make her ADL and life in a better quality. So it's a teamwork. And there should be a full concentration for the nerve injury part, for the detailed exercise program, and also the tendon injury part with graded mobilization and adequate serial splintages. And there is a new concept that is evolving to cater the tendon injury part is the regenerative medicine concept. So this is also getting practiced in our clinic. So that will be discussed in this recent advance area. So regenerative medicine, how helps in bringing good results in tendon repair. In the subacute and especially in the chronic phase of rehabilitation, and few words regarding the hand transplantation and the new advances which is known as biomechatronics and 3D printing. So regenerative medicine, here we will be using mainly the injection techniques like PRP, which is the platelet-rich plasma, and also the prolotherapy, which is with dextrose and anesthetic. The advantage of PRP is it is a rich source of so many growth factors like platelet-derived growth factor, endothelial growth factor, epithelial growth factor, collagen growth factors. So this rich source of this PRP we will be injecting to the growing tendon, whether if it is partially avulsed or partially injured, then it helps in remodeling and bringing regeneration in that particular tendon or ligament. Several studies is coming up to quote the advantage of this PRP, especially the leukocyte and platelet-rich plasma in tendon models. Several systematic reviews and meta-analysis has been published in even 2022, which is showing good results in vitro studies, and the results are with increased cell proliferation, cell migration, improving collagen synthesis, bringing good anabolic response, increased collagen type 1 content, and in vivo, the quality of the tendons is almost 67% enhanced with increase in the biomechanical properties. So this PRP is now offering a very good results in partial tendon injuries and in subacute and chronic stages. And the particular component, that is the HMGB1, that protein which is rich in platelet. So the platelet-rich plasma, if we inject, this particular component is acting as a chemoattractant that will recruit more stem cells to the tendon wound site, and which helps in augmenting the healing of that area. And regarding few words for the prolotherapy, it is a natural irritant we are injecting to that particular tendon. So usually we use dextrose, even 5% or 25% we use. This dextrose will induce an acute inflammatory process, and which will be naturally followed by a healing response. Several studies has come up with good results like effect of dextrose prolotherapy in tendinopathy, fasciopathy, and ligament injuries. So that's with PRP and prolotherapy. And in hand transplantation, after your extensive and hectic job of transplantation, the rehabilitation team take care of them to monitoring the signs of rejection with adequate splinting. As a team, we work including physios, OTs, rehabilitation, even psychological teams. We physiatrists create the platform for hand transplantation rehabilitation. And also a few words regarding biomechatronics and 3D printing. This is an advance that is coming up in the field of rehabilitation, which caters the neurobiomechanics and concepts of robotics, sensors, artificial intelligence. It is used in rehabilitation process. And several exoskeletons are formulated based on this biomechatronics, and customization is brought out if a complex design is needed, because it is giving a real-time feedback. When we use that exoskeleton, the patient himself is getting a real-time feedback. So he is becoming more interested in the therapy. And there are certain thought control devices using brain-computer interfaces. The limitation of this is cost, but this is slowly coming up into the field of rehabilitation. So this is a pediatric exoskeleton. This study has been published last year. So it is a customized exoskeleton device, especially in the case of pediatrics, which is bringing good results in hand mobilization. These are the two new robotic equipments we use in our department. A mini hand robo for bringing passive movements to the fingertips. And the first picture, it gives a visual feedback to the patient, and he or she can see how the hand is moving, and she'll get the feedback from the monitor. So this is a work after the latest. She brought this product. She's a great artist, our girl. Thank you.
Thank you, Dr. Ramya, for the nice talk and throwing light into all the recent advances in hand rehabilitation, and highlighting the point that it's a teamwork and not an individual work. I'd like to open up the discussion. Any questions from the delegates? I would like to ask you one question. You told about the injection of PRP into the tendons before hand rehabilitation. Is it actually a blind procedure, or you actually use an ultrasound or something to actually, what is the quantity you inject and in what areas? Like?
Usually we do it in ultrasound guidance, sir. Actually, it's a 20 ml blood. The patient will be coming to our OPD. 20 ml blood will be extracted, and that 20 ml blood will be taken for centrifugation process. So the blood bank team will discuss with us how much ml you want, how much extensive is the area. Then we can tell it is a 5 ml or 7 ml or even 3 ml, depending when the concentration, when the amount is less, the platelet concentration will be more. So depending upon the extensivity of the area, we can tell the amount, but on average 5 to 7 ml, around 5 ml, we can take as a clear supernatant plasma. So it is done in a special PRP kit, and the matter is that kit cost. And
to which tendon to give and which not to, is it desired pre-op, or you just into all the injured tendons?
No, sir, we will clinically examine the joint, and which all are the tendons we will locate and point, and musculoskeletal ultrasound report, if it is there, it is well and good. And parallelly, during the time of injection also, we can use the probe and inject.
The medications for CRPS, do you use bisphosphonates as a treatment modality nowadays too?
Not usually, sir, but that can also be included. The study says so, but if it is no great demineralization is happening and the bonds are good, usually it doesn't have much role, but GABA with nortriptyline or amitriptyline combination is the one which we usually use.
Good afternoon. Using PRP, have you found any actual improvement?
Yes, sir. Actually, for the subacute to chronic cases,
yes,
actually it brings good results.
Okay.
In the initial phases, we too did it as on a trial basis, but when the patient reported that area's pain and swelling and inflammation settled, we also got
there
conviction.
Is a clinical difference you could make out.
Okay. Of course.
Okay. Okay. And you use a 3D printing for the exoskeleton?
That is from the theoretical point I discussed. The last two pictures which I showed, we do have the instrument.
The robotic hand, mini hand.
These two things, it is there in our hospital.
Okay. Thank you.
Thank you, sir. I welcome.
Thank you, Doctor.
Thank you, sir. I hand over the presentation to Ms. Nicemore.
First of all, I'd like to thank for giving me the opportunity. And I'm going to discuss about the occupational therapy in post-traumatic upper limb injury. So I'm just giving an idea, what does the occupational therapist cover? We will be mainly focusing on the ADL and IADL, also the education, work, play, leisure and social participation. We will be dividing and we will be evaluating all the given concept of the patient, and we will plan the treatment accordingly. So coming to the case which Dr. Ramya already presented, she's an 11-year, 5 months old girl. She's a student and she diagnosed with severe crush injury in right upper limb, and her hand dominance is right. The reason why I mentioned hand dominance in my presentation is she always used to do every activity in her daily life and also in school with right hand. So it will be my major concern in my treatment plan. So she's referred by Dr. Ramya, and the chief complaint presented by her mother was the position of her right upper limb. She came with a pouch, a sling, in which the position of her elbow wasn't flexed. It will make the scenario more worsen, leads to flexed deformity in her elbow. And another chief complaint was her activity of daily living and also her handwriting. Then on observation, patient came along with her mother by walking. Attitude of limb, shoulder was adducted. And elbow was in flexed position, wrist was also in flexed. Thumb was extended in PIP and DIP joints. Index finger was in hyperextension, both in PIP and DIP joint. Middle finger was extended at MCP, flexed PIP and extended DIP joints. The ring finger was in the same position and little finger was extended. On examination, edema was present at the surgical site and tenderness was also there. Range of motion was affected and pain was her major complaint while doing the movements. Then sensation was affected at the surgical site, at the flap site. All other intact sites sensation was intact, normal. Then coming to the hand function, this is the main area in which an occupational therapist plays a major role. Here I put a 4-point rating scale to evaluate the hand function. Reach, that is all 5 area, that is forward, backward, reach midline, reach overhead. She can able to perform the movement, but she complained pain while doing the movement. So it is possible with difficulty. Prehensile, there is 2 main components, that is grasp and pinch. She can able to perform, but it's not functionally adequate. So I had put the score as 1. And release, it's able to perform, so it's functionally adequate. In hand manipulation, translation and shift was not possible. Pinch was also, it's functionally inadequate. Then non-prehensile, she can able to perform, but it performed with some kind of pain, and she complained, I can't able to do like this, like that. She always complained about the pain while doing every kind of movement. Then ADL evaluation, I evaluated with using FIM scale. Only the self-care component have major problems. Eating, she is independent. She was using her left hand to feed herself. And grooming, moderate assistance was required to complete the activity. Bathing, dressing and all, she required some kind of assistance for performing the activity in a proper manner. All the other domains was normal. She's independent in performing all other domains. Then therapy goal, the short-term goal was to prevent deformity. She was presented with a flexed hand deformity in her elbow joint. So it was my major goal. And next goal was hand function retraining, self-care skill retraining, sensory re-education, improve quality of life and reintegration to school and community. So for preventing hand deformity in elbow joint, proper positioning was required. So we suggested her a modified full cock-up hand splint in which we can extend the degrees in an extended wrist position. So we can change the position of the wrist joint and modified hinge elbow gaiter. Passive range of motion with task-related activities. We give passive-related movements correlated with the ADL. Then graded stretching for elbow, wrist and finger. Then hand function retraining. Play-doh activities was the major activity which I have given to the girl. And task-related hand function activity which correlated to the ADL task. Then tabletop activities like flexing finger by placing the dorsum of the hand on the table and making balls in therapeutic, squeezing the sponges like that. And opening finger against rubber band resistance, opening and flexing graded clips, picking beads out of therapeutic, making dough and making balls using therapeutic or clay. Then training the left hand for writing and performing other ADLs was a major role I played in her life because she used to write or do activities with her right hand. So we want to train or we want to make her to do all the things which she had done in her right into left hand. So I give her homework and give therapies while doing in my session also. Then self-care retraining. I started with one-handed techniques for dressing, upper limb dressing, and work simplification and energy conservation techniques had used. adaptive devices and some kind of modification in her ADL, like for buttoning and all. I asked her to practice in a big buttons rather than the small one. Like that small changes I had made in her ADL also. Then sensory re-education, mirror imaginary training, and visual audio tactile interaction, and safety education in the flap side. These are the work which is done by that girl. Thank you.
Thank you, Naismul, for the nice presentation again. Again, you have, the stress upon that teamwork, which you have again shown us that the teamwork is very important. It's not an individual. The surgeon does just half the job and the rest of the work is done by the physical medicine and the physiotherapy and occupational therapy department to get the patient back. Any questions? Thank you. It's nice, ma'am.
Thanks.
Thank you, ma'am. Moving to the next session, Dr. Ranjit John Matthew, Consultant Orthopedic Surgeon, Luth Hospital. The topic of the session, Post-Traumatic Recurrent Dislocation of Shoulder Arthroscopic Management.
Good afternoon, everyone. I thank the Light team and especially my friend Dr. Vinu, who is also my MBBS batchmate. Moving on to the topic proper, after all the micro work that you have seen, we'll move on to something a bit more macro, I guess. So my topic is post-traumatic recurrent dislocation of the shoulder, current trends in arthroscopic management. A brief introduction. As you all know, the shoulder joint is a ball and socket joint. It is the most mobile joint in the body, but as Spider-Man said, with great responsibility, with great power comes great responsibility, with great mobility comes great instability. So it is also the most unstable joint in the body. It has been likened to a golf ball on a tee. So only 1/4 of the humeral head actually articulates with the glenoid. The presence of the labrum actually increases the area of contact by around 75%. So a brief word about the anatomy. There are a lot of static restraints, lot of dynamic restraints. The static restraints are provided by the humeral head, the capsule, the labrum and the glenoid, while the dynamic restraints are by the rotator cuff, the long head of the biceps. There are a lot of capsular condensations around the anterior aspect of the shoulder joint, mainly the superior, middle and the inferior glenohumeral ligaments, out of which the most important is the anterior band of the inferior glenohumeral ligament, which is the main restraint, that is the static restraint with the arm in the 90 degree of abduction and external rotation. The MGHL is the static restraint at 45 degree and the superior glenohumeral is the static restraint with the arm at the side. So these are the, you can see the capsular condensations. It's very easy to identify on a picture, but when you see it scopically, it's not very easy. So this is the superior glenohumeral ligament, the middle glenohumeral ligament, and the IGHL. So I'm sure every one of you have come across a shoulder dislocation. Every one of you must have reduced a shoulder dislocation at any point in your career. So to classify, based on direction, it may be unidirectional, bidirectional or multidirectional. Based on the direction of dislocation, it can be an anterior dislocation in 97% of cases and posterior dislocation in 3% cases. So we are all familiar with this classification. That is, we have been hearing it during our UG times. Although I was not very familiar with this, I didn't even understand what was this during my UG time. It is Tubbs and Ambry. The Tubbs is actually a traumatic dislocation which is unidirectional, the cause of which is a Bankart lesion, and it is usually corrected only by surgery. And Ambry is atraumatic, multidirectional, bilateral, and the management is rehabilitation, and if this fails only, you have to go in for an inferior capsular shift. So shoulder stability as such depends upon many things. It depends on the position of the arm at the time of dislocation, the power of the muscles around the shoulder, and the integrity of the capsuloligamental structures, and the negative intra-articular pressure and the concavity compression. So after a person has a shoulder dislocation, it is not just that you just go to the casualty and reduce the shoulder dislocation and you send him off. You put in a shoulder brace, a shoulder immobilizer for 3 weeks and ask him to come back. There are a lot of things happening inside the joint as well. So the major thing which happens inside the joint is the presence of a Bankart lesion. So a Bankart lesion is nothing but an avulsion of the anterior inferior labrum and the anterior band of the IGHL from the antero-inferior glenoid. So 80 to 90% of patients with a traumatic dislocation will have a Bankart lesion. The next thing is a humeral avulsion of a glenohumeral ligament. This occurs in a slightly older age group, and it has a higher recurrence rate if not recognized and repaired. And this is a possible indication for an open repair. We generally don't do an open repair in shoulder these days. All of the things can be managed arthroscopically. The next is a GLAD. GLAD is nothing but a glenoid labral articular defect, which is a sheared off portion of the cartilage of the glenoid labrum. Along with the labrum, you get a piece of the cartilage also is lost. One of the more important things is this, the Hill-Sachs defect. It is nothing but a chondral impaction injury in the postero-superior part of the humeral head, which occurs secondary to contact with the glenoid rim, with the anterior glenoid rim while dislocation. So this is also present in 80% of traumatic dislocations and 25% of subluxations. So this is not clinically significant unless it goes and engages the glenoid repetitively and it causes a redislocation. GT fractures, I'm sure you must have all seen GT greater tuberosity fractures which occurs in association with shoulder dislocation. In patients, this is more seen towards an elderly age group. Lesser tuberosity fractures can occur. Nerve injuries can occur very rarely. Rotator cuff tears can be seen in 80% of patients with traumatic dislocations who are above 60 years of age. So when you see an older patient with a dislocation of the shoulder, you have to tell them that there is a high chance that you can have a cuff tear associated. So moving on a bit detail about Hill-Sachs lesion. A Hill-Sachs lesion, as you can see here, it is a depression in the posterolateral aspect of the humeral head. So as said earlier, 4/5 of patients, 80% of patients with anterior shoulder instability have both a Hill-Sachs and a glenoid bone lesion. That is, they will have both Hill-Sachs and a Bankart lesion, that is called a bipolar lesion. So then another thing is a bony Bankart. So bony Bankart can occur in a first time dislocator, or usually it is more commonly seen when the patient has a recurrent dislocation, there is repetitive trauma and the bone gets eroded, and then it leads to a bony Bankart. So a bony Bankart which is with a defect of more than 20 to 25% is considered a critical bone loss. So this type of bone loss to the glenoid is considered biomechanically, it is very unstable. So such patients cannot be treated with a soft tissue stabilization alone. That is, you cannot treat a patient with a glenoid bone loss of more than 25% by using a Bankart repair alone. That is totally unacceptable. You will have an unacceptable failure rate. So then you have to do something else to make up the bone defect in the glenoid. That is, you have to do either a Latarjet procedure or another bony procedure like an Aden-Hibernate procedure. So in our center, we generally keep the bone cut off as 25%. Above 25%, we go in and do a Latarjet procedure or an Aden-Hibernate. But in some centers, especially in France, many centers in France, they take the critical bone loss to be around 13.5%. So as said earlier, the traumatic has a high chance of recurrence. One thing to be noted is the age at the first dislocation. So it is said that if the patient is less than 20 years at first time dislocation, there is almost 100% chance that he is going in for a dislocation later. So the first time is the best time to operate. So because he will be the soft tissue structures will be more amenable to repair. So the first time is the best time to repair. You have to convince the patient that anyway he's going to dislocate again, and you have to get treated by a Bankart repair. So I'd like to introduce one concept to you. Here is the on-track, off-track concept. For that, you have to understand what is a glenoid track. So when you keep your arm moving along the posterior range of movement, or arm in varying degrees of abduction, external rotation and horizontal extension, the glenoid actually moves along the posterior articular margin of the humeral head. If you see that the highlighted portion, this contact of the glenoid with the humeral head is called the glenoid track. So if you see that the picture A, you can see that that is the cut section of the glenoid. The glenoid is an inverted pear-shaped structure when you face the glenoid. And if you see that circle, that white part is the area where the glenoid bone loss is there. So if you see, there is a hill sac lesion which is marked as HSL, and there is the glenoid track. When the hill sac index is lesser than the glenoid track, you get an on-track lesion, and when the hill sac is a big hill sac, then you get an off-track lesion. So I'll explain it a bit more detail. An on-track lesion has a hill sac which stays on the glenoid track and it does not engage with the glenoid and cannot cause dislocation. And an off-track is like this. I'll show you. This is you can see the you can see the defect in the humeral head. That is the hill sac lesion, and you can see an intact glenoid without any bone loss. So this patient has no instability in mid-range. So he is not in full abduction. That hill sac is not going to get engaged in the glenoid. So this patient again has no instability at end range. So this is an on-track lesion. For example, but in this situation you can see that when the patient even in mid-range, that it is a huge hill sac which gets engaged into the glenoid, while it is even in mid-range it gets engaged into the glenoid. So that such a patient will have definitely instability, and this is called an off-track lesion. So the management is different for an on-track lesion and an off-track lesion. And especially in this case, in diagram B, you get a bipolar lesion. That is, you get a bony Bankart along with a hill sac, and such cases also, it is a very unstable lesion. So moving on to the clinical features, you have to ask the patient some questions regarding the traumatic event which caused the dislocation. The patient usually presents with feelings of instability and pain. You have to ask the position of the arm at the time of dislocation, the nature of trauma, whether it is a trivial trauma or is it a significant one. Did it reduce by himself? And then there are a lot of tests you can do to assess shoulder stability, but the major ones which can be done are the load and shift test, the apprehension test, the relocation test, the sulcus sign, and you can check for signs of generalized ligamentous laxity like a Baton's criteria. You can do X-rays to find out. There are several other views which can be used. A CT scan can be used to quantify the amount of bone loss in the glenoid and the hill sac index. So that is very important, especially in the case of recurrent dislocation, when you have to plan your treatment according to the amount of bone loss which your radiologist gives. So the MRI is also useful, especially for visualization of the labral tear. Moving on to the treatment, non-operative treatment is highly controversial, especially in patients younger than 20 years. We generally prefer not to go conservatively. In elderly patients, first-time dislocator without any cuff tear, you can go in for a non-operative treatment, like you can just give an immobilizer for 3 weeks and then watch out for his movements and then do rehab and then see whether if he has a cuff tear later. So risk factors for redislocation, as I said earlier, almost 100% of patients with age less than 20 will dislocate. Male persons have a higher risk of dislocation, patients engaged in contact sports, patients with hyperlaxity, and with the glenoid bone loss of more than 20 to 25%. So the gold standard is a arthroscopic Bankart repair. So you can do a remplissage. Remplissage is nothing but you are just covering the hill sac by using the infraspinatus tendon. You're actually making the hill sac extra-articular. That is, you are covering the hill sac by using the infraspinatus tendon by putting an anchor into the hill sac lesion. So the remplissage can be considered if the hill sac is off track. That is, if it is going and engaging and causing a dislocation. So this is a short video. You can see we use cannulas there. This is the glenohumeral joint. This is the anteroinferior part of the glenoid labrum. This is a liberator being used to separate the labrum off the anterior aspect from the neck of the glenoid. So this step is very important. So in chronic cases, if the patient presents to you late, you may not be able to make out the labrum from the anterior aspect of the glenoid. So you can see that the labrum is actually coming onto the anterior surface of the glenoid there. Next, you use a rasp to prepare the anterior surface of the glenoid so as you can ensure good healing of the labrum onto the bony surface. Then an anchor is placed. We generally use a single loaded anchor, and then we put another portal for suture management, mainly for suture management. Some people don't use two portals, but we generally prefer to use two portals for suture management. Then this instrument is called a suture lasso, in which we take a bite through the anteroinferior part of the glenoid labrum along with the band of the IGHL. This is very important, so because this provides some amount of inferior shift to provide the inferior capsular shift along with the bump. So then we use this bird beak to retrieve that wire, and then the suture is passed along the anterior aspect of the labrum. So once this is complete, then you can just tie these sutures, and you can see that a good bump is provided on this is the inferior most anchor we are placing now. And this procedure is, we have to use around 3 anchors. So you can see that the knot tying is proceeded there. So the first anchor is done with, and the next anchor. And this procedure is repeated on the next 2 anchors as well. So an open Bankart repair, generally we don't do an open Bankart repair. It can be done in case of a Hagel lesion or in cases where there is a failed arthroscopic Bankart repair, which we generally don't do nowadays. And arthrolethargy is actually said to be the final frontier for glenoid bone loss. We have done a limited number of cases in our institution, around 5 to 6 cases we have done. An arthrolethargy is actually the same lethargy procedure, but it's done arthroscopically. It has a bit of a steep learning curve. The critical bone loss patients, that is patients with more than 25% of glenoid bone loss, a piece of the coracoid is transferred with the attached conjoint tendon and the CA ligament. So it actually provides a triple effect. It addresses the bone defect, it provides a skin sling effect due to the effect of the conjoint tendon which is passed through the subscapularis, and it provides some amount of capsular reconstruction through the CA ligament. This procedure we have actually done quite a few in our institution. This is called the Aiden-Habenet procedure, which can be done for the same indication as an arthrolethargy with bony procedure for 20 to 25% of bone loss. And in this, there is a mini open incision which is required to pass the iliac crest bone graft. We use a 2 to 2.5 centimeter long bone graft. There is a specific instrumentation for drilling holes, and we generally don't use screws. We use a circlage wire to tighten the graft onto the, I don't know if you can appreciate, you can see that there is a glenoid bone loss in this region, and it is covered with bone there. And once this is done, you have to do a standard Bankart repair so as to make the graft extraarticular. So this is a paper which was published recently, which got the Neer Award, in which they have compared lethargy with ICBG transfer for treatment of shoulder instability. And this the conclusion is that both the groups have no statistical significance, except for some internal rotation is restricted in the lethargy group. So this is the remplissage technique, as stated earlier, in which we make the Hill-Sachs lesion extraarticular. This can be done in cases of an extremely large Hill-Sachs lesion with a high Hill-Sachs index, and in case of an off-track Hill-Sachs lesion with the 20 to 25% glenoid bone loss. Bone graft reconstruction for Hill-Sachs defects have been described, but I have no experience in such cases. And there are a lot of historical procedures we have learned during our UG days, like Putty-Platt, Magnuson, Stack, Boyd, Sisk. These are all obsolete nowadays. So to summarize, a patient with an anterior bone shoulder instability with bone loss, you have to see the glenoid bone loss. If the glenoid bone loss is less than 25%, you can go in for a Benkart repair. And again, you have to see whether if it is an on-track hill sag or an off-track hill sag. If it is on-track, you can get away with a simple arthroscopic Benkart repair only. If it is off-track, you have to add a remplissage to your arthroscopic Benkart. If the glenoid bone loss is more than 25, then you have to see whether if it is an on-track lesion, then you can do a Letarge. If it is an off-track, then you have to do a Letarge along with the remplissage. So there are several complications which can occur. The patient can go in for a recurrence. There can be pain, there can be nerve injury, although very rarely. Stiffness, infection, graft lysis can occur, hardware complications can occur, chondrolysis can occur. Thank you for patient listening.
Thank you, Dr. Ranjit, for that extensive coverage of management of shoulder dislocations arthroscopically. I'm sure nobody would be having any questions. He has almost covered everything. Leaving it open for discussion.
If you do a MR image of the shoulder, if you see a glenoid bone loss in the MR image, will you go always for a CT scan?
Yeah, definitely. We have to do a CT cuts. Usually the radiologist will be taking CT cuts along with the MRI.
Along with the MRI. So you always go for a CT after MRI?
Even if you don't ask, they will do a CT
They will
cut.
do it for you. Oh, good. Okay.
Have you encountered any patients with generalized generalized hyperlaxity even after doing a Letarge, recurrent dislocation after that?
Actually, if patient has a generalized hyperlaxity, then I don't think we have to do maybe not in case of anterior dislocation. If you see a sulcus sign positive and you are of the idea that the patient has a generalized laxity, then it's better not to do surgery and offer him some rehabilitation. And even then, if he is adamant, then you can do a 360-degree labral repair. Maybe you can do an inferior capsular shift, volume reduction surgery can be done.
Thank you.
Thank you,
Dr.
sir.
Thank you, sir. Moving on to the next session, I invite Dr. Oni Chiriyan, Consultant Orthopedic Surgeon, Allied Mission Hospital, Thrissur. The topic of the session, Principles of External Fixator in Limb Trauma.
Good evening all, and thank you team SUSHRUTHA for this wonderful opportunity. So my presentation is principles of external fixation. Mainly this presentation is to understand the basics of external fixation, its principles and protocols, and how to do a simple and quick X-fix, and also how to find an adequate external fixation for a particular patient or a particular case. So historically it was, it had a bad name because of its inherent instability and poor union rates. It was called as a non-union machine. But later introduction of new generation external fixators, and now it gained popularity among orthopedicians. So overview, we'll be dealing like why, when, what and how. Like why to do an X-fix, when to do, and what X-fix to do, and how it can be done. So why X-fix? What are its advantages over internal fixation? So it is very minimally invasive. It consists of only rods and rings and pins. So it's very minimally invasive, so you won't give another headache to a plastic surgeon. So, and also it's very flexible. There is no hard and fast rules. You can construct your own frames, but you should adhere to its principles and protocols. And it's usually simple, and you can apply it very quickly, so you can get away within an hour if you are skilled enough. And it is useful both as a temporary and also newer generation ones we can use as a definitive stabilizing device, and also you can use it in reconstructive and salvage applications like arthrodesis. So moving to when to do exercise is major indications. Usually we use it for compound fractures, especially in damage control, like when you want to do a quick stabilization of an unstable patient. We cannot go for a definitive procedures because it will give another second hit. So we have to go for a external fixation. So mostly for type 3 compound fractures, and also some type 2 or even in type 1 with severely comminuted fractures, we can go for a external fixation. And obviously open vascular injuries, we may need a extensive reconstruction of vessels and or repair. So we need a stable fixation around the joint or around the repair site. So we need external fixator. And polytrauma with associated pelvic fractures, patient may be very unstable. So you need to get away with a stable limb. So we need an external fixator. And closed fracture with severe soft tissue edema or condition, or we are expecting a compartment syndrome and needing a fasciotomy, external fixator is ideal in that situation. Also, if you are suspecting a vascular injury and there is a vascular compromise, planning for a exploration or repair, here also exercise will help. And some other acute indications are periarticular complex fracture. Even if it's closed or open, like Shaska 5 or 6, we can go for a modified external fixators, and pelvic ring injuries and some pediatric fractures like femur fractures. So moving on to other chronic indications like malunion, non-union, extensive bone loss if you're planning for a graft or a free flap, we have mentioned earlier, or we are planning for a bone transport, we can opt a external fixator. And some cases of chronic osteomyelitis where you have to, we cannot do a plate or nailing, we can go for a external fixator, and also for deformity corrections and reconstructive procedures. Now, what exercise? We have different generations of exercise. Early, the first generation was a failure because it was just a simple construct with very unstable. But further generation like second generation, simple unilateral exercise with better stability, but still not that stable. One is the second generation, one is the standard S-fix with just pins, clamps and connecting rods. So it is very simple and you can apply it quickly. This is a workhorse of major trauma in damage control. Now we have modified ones like LRS lip reconstructive system, LRS fixators with advanced clamps and telescoping bars. So, and compression and distraction units. So you can do a bone transport, and also they are more stable because of the multiple pins and bigger rods and bars. And we have third generation ring fixators. Here we have a multiplanar stability using thin wires or olive or beaded wires, half pins, rings, rods, hinges and posts. Here we can be getting more stability because of multiplanar construct. Now we have fourth generation I skip because it is a articulating type of similar S-fix. Now fifth generation we have multiplanar adjustable ring fixators. Here we have rods, rings which are connected with the telescoping rods which are fixed in a certain angle. We have 6 rods around the ring, and it can be applied with wires or half pins, and it has 6 degrees of freedom, like can be rotated, can be shifted up and down, or translation sideways. So you mainly use for deformity correction in acute or chronic conditions. Now we have a 6th generation hybrid external fixator. Here we are combining both advantages of ring fixators in periarticular metaphyseal region, and also simplicity of planar half pin or wire fixation in diaphyseal bone. Now coming to the major part, how to exercise. So key points should be stable enough, and it should be simple and quick. So we have to get away at least within 1 hour. So mainly in damage control. and do not overstep X-fix, because plastic surgeon have to do further procedure because we cannot make it as a space occupying lesion. So select proper X-fix before surgery and proper planning before surgery, because if you are planning to do quickly, you need to plan before, like what all rods we need, what all pins we need, how many clamps, how many rods. When you are preparing it before the surgery, it is very easy for the scrub nurse or assistants, so we can finish it fast. Also, we have to achieve good alignment and satisfactory reduction during the primary external fixation procedure, because we may not know when we are getting it again for the definitive procedure. So reducing a fracture, displaced fracture after 2 to 3 months, it will be very difficult. So whenever you are doing an external fixator, always do it correctly with good alignment and satisfactory reduction. And also joint should be kept in neutral or functional position, because it will prevent further complications. And principle, pin is a critical link between the bone and the frame. So selecting the pin is very important, because its diameter should be adequate. There are protocols for pin diameter, and it should be less than 1/3 of the diameter of the cortex, and also it should not be very small. So we have different types of size and different types of pin and different types of threads. And materials we use is stainless steel, titanium. Titanium is more biocompatible, MRI safe, and less stiff. And pin geometry, we have blunt pins, straight and conical pins. Conical pins we are used in LRS because it's more stable and have more purchase on the bone because of its conical shape. Pin insertion technique should be carefully done, because this is the main part of the external fixation. So you have to insert the skin adequately, spread till to the bone, spread the soft tissue till to the bone, use sharp drill with sleeve to prevent injury to muscle and neurovascular tissues, and irrigate while drilling, because it will prevent thermal necrosis, and also place appropriate pin using a sleeve. Avoid soft tissue damage and bone thermal necrosis. Pin length. So you can use half pin or a transfixation pin. Half pin, there will be only one point of entry and you have to engage 2 cortices. In transfixation pin, you can cross the bone and the limb, and here we can use bars on the both sides. This is more stable, and you can use it as a distraction external fixator, but limited anatomical sites. You have to take care of neurovascular. Then pin diameter guidelines, you have for guidelines like femur 5 to 6, tibia and humerus 4.5 to 5, forearm 3.5 to 4, hand, foot 2.5 to 3 mm pins. Then connecting rods and frames, you have steel, aluminum, carbon fibers. You can use simple rods, articulated rods, and telescoping rods. Principle is to in order to increase the stability, you have to either increase the diameter of the rod or the special types of rods. You can also increase the number of rods, like parallel bars or rods. Stainless steel versus carbon fiber is more radiolucent and also more stiffer. Frame types, there is uniplanar, biplanar, circular and hybrid. Uniplanar have 2 types, unilateral and bilateral, where in unilateral you are applying in one side, and in bilateral you are applying the rods on the both sides, like in 2 planes. In biplanar we have unilateral and bilateral. As biplanar is usually in very unstable cases we can choose biplanar because it will give more stability in 2 planes. In circular ring, they have multi-axial, multi-planar stability because of pins and wires transfixing in multiple planes and connecting to circular ring fixators. Hybrid, we combine both ring and planar frames. Frame types, we have standard frame, joint spanning frame, which can be articulated or non-articulated, distraction or compression frames. Ring fixators principle is to, by tensioning the crossing wires to 90 to 130 kg, place wire close to 90 degree to each other half pins are also effective mostly in the diaphyseal region. And better to use full rings instead of half ring or quarter rings. And it can maintain good purchase in periarticular area. So any periarticular fractures, better go for a ring fixator. To allow axial loading, it can weight bear, so patient can be mobilized early with the fixators on. So there will be axial loading and also allow joint motion. Standard frame is a simple frame and it can be mainly used in damage control, or if the fracture is simple or stability is good, we can go for a standard frame. Usually for diaphyseal fractures, allow joint motion and almost stable. Joint spanning frame here mostly we use for periarticular fractures or for major ligament injuries or neurovascular injuries. We are usually as a temporary fixators. Later we can go for a definitive procedure, mostly in a damage control orthopedics. Articulated frames we mainly use for periarticular fractures and ligament injuries, also along with ligament repair or after fixation. If for extra stability we can use articulated frames. Here also it allows controlled joint motion, but require to precisely place the hinge of axis of joint motion. Now correction of deformities and defects, you can use unilateral or ring frames, but according to the complexity of fracture, you have to choose either simple or complex frames. Simple deformity, simple frames. All requires careful planning for the procedure. We already discussed increase the pin diameter, increases spin spread, and number of pins increases the stability. Maybe out of the plane or in the plane, we can increase the number of pins. Now, rod factor, if you increase the number of rods or increasing the distance, reducing the distance from bar to bone also increases the stability. Also, increasing number of bars, like parallel bars, increases stability. Now, biplanar construct is more stable than uniplanar, so you can increase the plane of construct. Also, you can connect linkage between the planes, like a delta frame. You can increase the stability of the, so you can use for highly unstable fractures. We already discussed ring fixators have put the wires as close to 90 degree, and also use at least two planes of wires of half pin in each bone segment. You can go more than two, but minimum two. Now, modes of fixation, we can use a compression frame, neutralization frame, or distraction frame. Compression frame, if you have sufficient bone stock or to increase the bone union, you can go for a compression frame. It increases the stability. Neutralization, if you have a severe comminution and you want to maintain the length and alignment, better go for a neutralization frame. In distraction, if you want a reduction with the ligamentotaxis, you can go for a distraction frame or just as a temporary device in damage control to keep the alignment. Also, you can use for distraction osteogenesis in Elisaro. Biology, you need fracture healing, so it should be stable but less rigid. So you can go for dynamization and or micro motion because those increase fracture healing. So dynamization is by at least weight bearing, and with less rigid system you can get micro motion at fracture site, so there will be increased healing. So it's like a load sharing. So anatomy consideration, you should be careful while putting the pins and wires. So lower extremity safe sides are anterior and lateral part of the thigh, in tibia, anterior and medial part of the tibia. It should be just below the articular surface. In upper extremities, you are careful about axillary nerve, radial nerve, and mostly radial nerve in the middle part. In ulna is very safe because it's subcutaneous bone. In radius, proximally you have to avoid because you have radial nerve and pin. And MRI compatibility, stainless steel, you may get heating, so some centers won't allow it, so better titanium, aluminum or carbon rods. Damage control, already discussed, better quick and safe external fixation as early as possible and plan for definitive later. So conversion to internal fixation, you can generally 2 to 3 weeks is safe. You can directly go for internal fixation, but after that, better take care of pin tracks, let them heal, and you can go for a stage procedure. Some complication, disadvantages are mechanical and biological. So usually due to poor external fixation, they will go to non-union or malunion, pin track infection, and compliance issues, weight, etc. And biologically, mainly neurovascular injuries and infection and joint stiffness. So complication, mainly pin track won't be good. So most common complications, pin track, you can deal it with antibiotics and curettage, or you can remove or exchange pins and the construct. So if it is too much osteomyelitis, you need to address the osteomyelitis. Non-union, if you are planning to keep it for long, it may lead to non-union, so you have to go for a definitive procedure in between. So early bone grafting or rigid construct, good surgical technique, controlling the infection, you can minimize the non-union. So construct trips, choose optimal pin diameter, use good insertion technique, place clamps and frames close to skin, frame in plane of deforming forces, stack frame if necessary, reuse and recycle components. So, summary, multiple application, we have multiple type of exercise, multiple applications, so choose component and geometry suitable for particular case. Appropriate use can lead to excellent results. Recognize and correct complications early. So, some few cases we have done as a damage control. So, femur fracture with minimal injury, but we went, because of damage control, we have done a pelvic S-fix and a femoral S-fix, later converted to plating and open reduction. So, it's a pylon fracture with severe combination. So, we went fixed the fibula fracture and reduced the pylon with external fixator. And there's a lot of combination, lot of contamination the other side with minimal bone injury, but we went for external fixation for the wound healing. And this all other some communicated cases with done flap, and later we converted to definitive procedures. These are few cases. So thank you.
Thank you, Dr. Ronnie, for that extensive presentation on external fixators. Any questions from the delegates? I think we are running short of time. Thank you, Dr. Ronnie.
Thank you, sir. For the next session, I invite the speaker, Dr. Joshidhar Balan, HOD, Consultant Plastic Surgeon, SUSHRUTHA Institute of Plastic Surgery, Elite Mission Hospital, Thrissur. The topic of the session, replantation of fingers and role of super microsurgery in fingertip replantation.
Good evening, respected seniors and dear friends. So I'll be directly go to my topic, role of super microsurgery in fingertip replantation finger reconstruction. So the fingertip is defined as the part of finger distal to the insertion of the flexor and extensor tendon. And by Allen's classification, you can see it has divided into four zones. So distal to the flexor and extensor tendon insertion, it is 4, and through the part of the mid part of the nail, it is Allen's class 3, and class 2 is a part of bone will be there, and class 1 there is no bony part in the amputated part. So best result is we will get by replantation. The other options like skin grafting, local flaps, region flaps, and free flaps are there. But the best will be, so we should always try replantation. So you should try replantation. The problem with digital replantation is that most of the time there will be a lot of crush injury will be there, because mechanism of injury may be crush injury by bike chain or some other mechanism. You can see in this, there is a bluish color discoloration you can see. And there won't be any dorsal vein. So you had to bank on volar vein for venous anastomosis. And the artery also will be very distal. So we should have a meticulous surgical technique. So according to Koshima, supramicrocele is defined as microvascular anastomosis for vessels 0.3 to 0.8 millimeter and single nerve vesicle. Now, once we get the part, we have to dissect the part. You know that these vessels will be dorsolateral to the nerve, and there are danger signs like red line sign or ribbon sign, and you can see avulsed nerves. That also are not good signs when you go for replantation. And initially, we should usually we'll be fixing the bone. Then we'll go in distal replantation. There won't be tendons to do reconstruction. So you will directly go to the vascular anastomosis. And the technique we are following most of the time is that we'll be doing the artery anastomosis first, because we won't be seeing much of the veins in very distal replantation. Once you do the artery anastomosis, the veins start bleeding, and this backflow will be there. So you can see which vein is bleeding well. Then you go anastomosis for the same vessel. And prepare the vessel, freshen it. Then the key to the successful result is minimal tissue handling. And we can go, usually we'll be in distal part, we'll be going with 10-0 latches. And here you can see there is a, here in this patient you can see this artery anastomosis and dorsal veins. 2 in number, there is anastomosis is done. And nerve repair always gives better results because sensation will be better. And post-operative care, you know that nowadays we are not giving heparin infusion and because of bleeding and all. So, and we had to monitor, and usually we do the dressing in the 5th or 7th day to prevent the spasm due to the change of dressing. And in the very distal replantation, we can do artery first anastomosis, or without bone, before fixing the bone, you can do the artery anastomosis, because once you put the K-wire or any fixation, there won't be any space actually in the distal part. There won't be any distal tissue only. So it's, sometimes we may go for a artery anastomosis in the initial step. Then you do put the K-wire and you do the venous anastomosis. And once you will always get a volar venous vein. So we can go for a venous anastomosis. And sometimes you have to harvest a small vein graft. This you can see in the thenar veins, you will always have a small vein. You can see at your hand. So there will be a vein actually. So now I'll go through some case series. This is a 20-year-old male with bike chain injury, very distal amputation. So both arteries and veins were done. This is the post-op results. And another sharp cut injury of 65-year-old lady with a kitchen knife. You can see this amputated part is very, you can see the part where actually there is we could manage to get an artery and venous anastomosis in this patient. So this good capillary refill post-surgery, immediate post-surgery you can see. And there was no bony fixation done in this patient. This is the post-op result. And I'll go to the next case. 23-year-old male bike chain injury. This is through the nail amputation. So here, artery anastomosis was done, and there was volar vein, there was a positive vein, so we had to harvest a small vein graft to do the venous anastomosis. So this is the result. Then this was gate crush injury. Here, this is Allen's class 3 injury. So there was vein was less. Actually, we could manage to get a small artery from the same finger itself. So after artery anastomosis, we had a small part of artery that was used as a between the vein. Actually, it was an arterial graft bridging the veins. So this is the 12-day post surgery, and this nice post-op result he got. Another similar crush injury. This is another lower. This both were lower somehow. It is very distal injury. You can see this one was fixed like this, and both we could manage to get both the artery and vein anastomosis in this patient. This is late post-surgery result after. You can see the lowermost part picture. You can see the how distal this amputation was happened. Then this lady had this occupational injury of 3 digits actually, and this one finger, index finger, that it was very distal. In that patient, we had done only artery anastomosis. We couldn't get any vein, but it survived fully. So it's another 8 months. It's not a complete amputation. There was tendon was intact, so we had to do artery and vein. And this is the post-surgery result. That was salvaged. So this is another child with 4-year-old child with a great amputation by cycle injury. So this has replantation was done in this child. So when what is the next best option? So when there is we are not able to get a replantation, we can go for a total transfer. The advantage is that this like with like tissue transfer, and we can take even tendon, bone, partial toe, or free joint, anything with this toe pulp. So I'll brush through the surgical steps. First, this is the marking. So this is the second toe marking, you can see. This is the flap which is marked on the medial aspect of this is the artery going. The volar vein we are marking in the initial step itself. Then that is a line of skin incision. So here, so in the subdural pain, the dissection starts. We are saving the veins towards coming to the flap. Next is the arterial pedicle dissection. So here you will be able to get a good arterial pedicle coming to the flap. Then this flap is elevated from the extensor apparatus. So we have already dissected the vein, artery. Then you can see this flap is elevated from distal to proximal. So already the vein and artery is there in the flap. Now there will be branches going from the artery to the joint as well as to the bone. That we have to clip. These are the small branches which are going into the joint and bone. So these branches we will be clipping. Now this flap is fully elevated. This is a vein, artery, and the lower part is the digital nerve. This is a fully elevated flap till the web space we are elevating. This is an immediate in-drop perfusion. We have to check for the perfusion, and the donor site is closed by putting an FTG. This is the flap after division. This was the defect, distal fingertip defect. We have planned partial toe transfer. So we had to prepare the recipient preparation. You will be able to get a dorsal vein and the digital artery, and digital nerve will be dissecting and do the anastomosis. This is the digital artery anastomosis we are doing. And this is a flap insert. Actually, immediately post surgery, there will be some tissue edema. So we may have to put a small skin graft over the pedicle or some exposed area. This is 5 months post-surgery, and he had a 2-point discrimination of 3 millimeter, and good functional recovery, and donor side also healed very nicely. This is some cases like topal for index finger. This is a second topal was used for reconstruction of the index finger. This is the immediate post-surgery and late post-surgery results. And even you can take the artery. This is the first surgery we have done, partial transfer. That time we have taken the artery till the dorsalis pedis artery. So this was the defect, and this was the big pedicle we have taken. That then the artery anastomosis was done to the radial artery, and this is the result. This is the pre-op and post-surgery. Then we can even take a part of bone. This patient had a osteomyelitis actually. This patient had a chronic non-healing wound. So that bone was, we have taken a partial toe along with the bone. We have taken and we gave insect, and this bone has taken very nicely. And this is for this 3 weeks old injury with part of the thumb was lost. So this bone was osteomyelitic, and we have removed the bone, and the requirement was bone tissue as well as the this sensation nerve everything. So we have taken the partial gray toe actually. So we can take and part of the nail also we have taken. This is the elevated flap. This is the anastomosis, and this is immediate post surgery and 4 months post surgery. We were able to get a good thumb for this patient. And this is another patient with ring finger loss. For the partial second toe was used to reconstruct the ring finger. You can see the pre and post surgery picture. So this was patient initial surgery. He had a crush amputation. Initially, replantation was done, and there was some size was not good for the patient. So we have done a partial this is second toe to improve the thickness of the finger. And I will finish with a small case report. This free joint transfer done for a child, 2-year-old child. He came with a road traffic accident. You can see the amount of injury sustained to the thing. This child's hand, he had a injury to the ring as well as middle finger, loss of middle phalanx of the middle finger, and part of joint loss of the ring finger. So initially, stabilization was done. Then groin flap cover was done in the initial stage. Then flap division, everything was done. This was the child after flap division. That KVS was put as a spacer. So requirement is bone joint. The requirement were bone joint of both middle and ring finger extension mechanism. So second top joint was planned. This is the donor area was dissected. This is the vein which was dissected of the finger. This is the digital artery which has been dissected. And this, both fingers were prepared. So, and the measurement of the required part was taken. And this was the flap in this marking. And you keep a small dorsal skin paddle so that the skin closure won't be tight, as well as you will be able to monitor the flap. So this is the elevated flap. So you can see there is a skin paddle joined with bone, and you can see the pedicle there. Pedicle on the dorsal aspect, you can see the vein, as in the interdigital space you can see the artery. So this is the flap taken. It has given insert was given. This is the other second toe from the right side. Second toe for the ring finger was taken. Both the flap insert were done. This is the late post-surgery result and X-rays. And you can see the movement. Child is having good movement of both digits. And child is able to manage nice hand function. So whenever the conclusion is that whenever you get a amputation of finger with a distal part, when the patient is bringing you should always try do an attempt to replant, so that If because even though there will be crush injury, sometimes that replant may work. So, and when there is no tissue available, we can even think of top up to get a better outcome. Thank you very much.
Any questions from the delegates? Yeah, please,
Yes, sir.
sir.
When you don't find veins, they say that you can avulse the nail plate and
Yeah,
keep
we
pouring
can.
heparin.
Yes,
Have you
sir.
tried that?
No, actually, actually that doesn't work. Actually, for in my hands, actually, in our hands, that success rate is very less. That I don't know why. But we have put that chemical leaching. We put heparin, everything we have tried. But always better to find a vein and do anastomosis, because. Still now, in my experience, actually, plenty of number we have done already. Last 10 years, plenty of number of reverse and replantation has been done. But in 2 cases only, artery only done. It survived actually. One very distal thing and one kid in the in 2013. Now, it's very that chemical leaching and
doesn't work.
Doesn't work. Prince.
Thank you.
Memento.
Thank you, Dr. Joshi,
yes, thank
for
you,
your mind-blowing talk.
Yes, thank you, sir. Thank you.
Who told that bodybuilders can't be good microsurgeons? Huh?
No,
Thank you.
Thank you, sir.
Thank you, sir. Now I request Dr. Kurian and Dr. Pramod to please come out to the dais and hand over the memento. To receive the memento, I invite Dr. G. Karthikeyan, Dr. Ronnie Cherian, Dr. Joshi Darbalan over to the dais. Now I invite Dr. Prince to deliver the vote of thanks.
Good afternoon, everyone. On behalf of SUSHRUTHA Institute of Plastic Reconstructive and Aesthetic Surgery, Allied Hospital, I extend my sincere gratitude and vote of thanks to all the participants who take their time to be here to participate in this event on Sunday. I extend my warm gratitude to all the speakers who came from all the part of the nation, to all the chairpersons. I extend my gratitude to Allied Management, the staff and PROs of the Plastic Surgery Department, the nursing students who helped us in the comparing session, the sponsors who generously sponsored to this conference, the audiovisual team who kept it going, and the Ashoka Inn management and the hotel staff to keep the function live. Thank you everyone once again. I also welcome all of you to our 6th the annual ceremony going on at Merlin International. It will be starting at 6:30 p.m. We will be having a few functions and dinner at Merlin International. So I welcome you all again to that function. Thank you.